Hey, Cable, are we ready? I'm not showing. Guys, are we ready? Can we get a thumbs up or a something? Okay, I'm gonna go ahead and get started and hope for the best. Okay, and we are recording. Wonderful. Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. I would like to call this hearing to order today. Today is Wednesday, April 5th, 2023, and the time is 9 a.m. We are holding a hybrid meeting in room 120 of the John E. Wilson Building and via the Zoom internet platform. This meeting is being broadcast live on cable channel 13 and on my YouTube page at CMC Henderson. Today, we are holding a fiscal year 2024 budget oversight hearing for the Office of the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance. We will first hear testimony from public witnesses for DHCF and then for the witnesses for DMHHS. And then we will hear testimony from Wayne Turnage, the Deputy Mayor for Health and Human Services, as well as the Director of Healthcare Finance. The Department of Healthcare Finance administers in the district's Medicaid program, as well as the State Child Health Insurance Program and the Healthcare Alliance and the Immigrant Children's Program. The mission of DHCF is to improve health outcomes by providing access to comprehensive, cost-effective, and quality healthcare services for residents of the District of Columbia. The agency provides healthcare services to more than 320,000 district residents, approximately half of all residents. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating comprehensive system of benefits, goods, and services across multiple agencies that ensure children, youth, and adults with and without disabilities can lead healthy, meaningful, and productive lives. In addition to overseeing the operations of the agencies within its cluster, DMHHS also leads the Interagency Council on Homelessness, Age-Friendly DC Strategic Plan implementation, and the CARE program for encampment closures. The committee sit pre-hearing questions to all agencies, and we will reference those throughout our materials today. If anyone would like to see those materials, they can be found online on the council website. Don't see any of my colleagues, so I will not turn to them, but I'm going to turn public witnesses. Before we get started, I would like to review the testimony guidelines. Witnesses representing organizations will have 5 minutes to speak, and witnesses testifying on their own behalf will have 3 minutes to speak. The clock will begin when you begin speaking, and I will give you a nudge when your time has expired. So we will do panels of 8. For those who this is your first time testifying with us, just a reminder that you will need to affirmatively accept our invitation to become a panelist and come into the room. So Michael Syndrome, Christian Carter, Catherine Crossland, Makita Vanderpue, Deborah Akil, Mark Lavoda, Ian Perigal, and Corinne Cannon. Okay, we don't have Michael or Christian, but Catherine is here, Catherine Crossland. So if you want to come off mute and go ahead and present your testimony. There you are. Hello, good morning.
Good morning. Good morning. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Catherine Crossland. I'm a DC resident, a physician with Unity Healthcare who's been caring for people experiencing homelessness in Washington, DC for the past 14 years, and a member of DC's Interagency Council on Homelessness. I currently serve as the Director of Homeless Outreach Development for Unity's Healthcare for the Homeless Program. And since 2020, I've worked in collaboration with DC's Department of Health Services on the COVID-19 pandemic response to meet the needs of people experiencing homelessness in DC. I'm pleased to have this opportunity to present testimony as part of the fiscal year 2024 budget process. I want to thank you for holding today's hearing. In addition, I would like to thank Mayor Bowser, Deputy Mayor Turnage, and their dedicated staff for their work in assembling the proposed fiscal budget, 2024 budget. To be sure, balancing the many demands of our complex city is not easy. In February, I was delighted to testify before this committee performance oversight hearing on these very issues. During that hearing, I expressed my gratitude for the effective action to meet the needs of people experiencing homelessness during the COVID-19 pandemic, including the establishment of isolation and quarantine hotel shelters and the pandemic emergency response for vulnerable individuals. Among other proactive measures. I'm here today to urge the district to consider building on its incredible work and the lessons learned during the pandemic on issues related to medical respite services. Undoubtedly, housing is healthcare, especially for someone experiencing homelessness and simultaneously recuperating from an illness. For these individuals who are too sick to be in the shelter or on the street, but not sick enough to be in the hospital, medical respite care is an indispensable bridge for wellness. Given the recent downward projections in the district's revenue, now is the time to be investing in medical respite. Simply put, medical respite saves lives and money. People experiencing homelessness are nearly 5 times more likely to be hospitalized than housed individuals. In addition, the average hospital stay for a homeless patient is double that of non-homeless patient. Homelessness, therefore, represents a major factor in hospital utilization. Studies confirm that the availability of medical respite care significantly reduces future hospitalizations for individuals experiencing homelessness and also shortens hospital stays. In addition, medical respite care is an effective way to avoid unnecessary and costly inpatient hospital stays altogether for this population. The financial savings associated with providing respite care when compared to the cost of inpatient hospitalizations are enormous. And I've included studies in my written testimony that detail some of these cost savings. Unsurprisingly, reductions in healthcare expenditures for people experiencing homelessness translate into savings for publicly funded healthcare programs, specifically Medicaid. In 2000, and again, I have studies that show those cost savings. Furthermore, medical respite permits a more efficient use of shelter resources. When there is someone in the shelter who is too sick to be there, they either cycle in and out of the hospital, as mentioned earlier, or cause a significant drain on the shelter's resources and staff who are not equipped to manage their needs. By having enough medical respite beds for those with higher medical needs, the shelters would be able to operate more efficiently to meet the needs of the rest of the population. As the evidence confirms, there are many tangible benefits associated with medical respite care. At present, the district has a limited supply of medical respite care providers. Joseph's House, 8 beds, Christ House, 33 beds, Hope Has a Home, 16 beds, and Patricia Handy Place, 12 beds. All are excellent programs. The reality is, however, that we need more beds to serve an increasingly older and more medically complex population experiencing homelessness. We also need more low-barrier medical respite beds that are not tied to a specific insurance plan, as well as medical respite beds that do not require sobriety. Last year, Unity conducted a survey of hospital care coordinators, as well as shelter staff and outreach workers. Based on this formal needs assessment, Unity estimates the need to be approximately 150 beds. If we subtract the currently operational medical respite beds listed above, there remain a need of approximately 100 additional beds. Determining precisely how the district should fund these life-saving and cost-effective medical respite beds will require a thoughtful approach. To this end, we urge the district to revisit the work that was initiated as part of the fiscal year 2020 budget related to creating a Medicaid funding source for medical respite care services for homeless individuals. Specifically, Subtitle H, Section 5071A required the Department of Healthcare Finance to submit a report to the council outlining its recommendations for the establishment of medical respite care services for homeless individuals through an amendment to the District of Columbia's state plan, a waiver pursuant to Section 1115 of the Social Security Act for home and community-based services, as well as the types of services that may be offered to homeless individuals through medical respite care, and an identification of potential restrictions on the provisions of service identified pursuant to a subparagraph. For these reasons, okay, so we would love to be a partner in this work, and I'm happy to answer any questions. Sorry,
Awesome.
I went.
Okay, I will also have some questions, so just hang on.
Perfect.
Makita?
Good morning, Chairperson Henderson and
Morning.
members of the Committee on Health. Thank you for this opportunity to testify before you today. My name is Makita Vanderpoy, and I'm the Executive Director of Leading Age DC, an association representing mission-driven organizations serving aging residents across the district, including nursing homes, assisted living, affordable housing, home and community-based services, senior villages, and life plan communities. Prior to my work at Leading Age DC, I was a district employee serving for over 4 years within DC Health's Office of Health Equity. Across 10 years of experience in public service, I've built expertise in collective action, population health improvement, and equity. I'd like to acknowledge and thank Mayor Bowser, her administration, the council, and all DC government staff for your dedicated service to those who live, learn, work, play, and age here in our nation's capital. Today, I'm here to share Leading Age DC's concern about alarming shortages in the direct care workforce. Aging residents have so much to contribute to our communities, from sharing hard-earned wisdoms to the appreciation of life's milestones, big and small. Leading Age DC members, largely not-for-profit organizations, are committed to providing high-quality care, services, and supports that enable aging residents to take full part in community life. For a steadily increasing proportion of residents aged 65 and older, this may include long-term care services to assist in activities of daily living, such as dressing, bathing, and using the bathroom. The direct care workers who provide these essential services to individuals in their homes and in facilities, simply put, are not paid enough. Leading Age DC recognizes DC Council for acknowledging the need to address this issue, most recently through the passing and implementation of the District Support Professional Payment Rate Act of 2022. Unfortunately, this act does not do enough to meaningfully increase the average wage of direct care workers, retain those currently engaged in this work, or attract new professionals required to fulfill current needs. Considering forecasted growth in the older adult population by as much as 24.4% by 2023, this issue poses an imminent community health crisis that demands a sustainable and effective solution. Direct care workers, often home health aides or certified nursing assistants, must attain training and continuing education, maintain current licensure, and demonstrate a high level of skills while assuring the health and safety of older adults. Yet these workers are paid less than other allied health workers and non-health sector workers whose roles require less training and less responsibility. Though Leading Age DC members employ creative strategies in efforts to recruit and retain direct care staff, they remain at a disadvantage, unable to afford to compete with wages paid by hospital systems, staffing agencies, and even entry-level positions at companies like Target and Starbucks. Our vulnerable communities deserve better. Leading Age DC is part of the workforce subcommittee of the DC Coalition on Long-Term Care and supports a true living wage of $24 per hour for these essential workers. Higher wages will make a difference, enabling our members to support the financial health and wellness of their staff, persist in efforts empowering district residents to age with dignity, and prepare for increasing needs and emerging challenges on the horizon. Fair compensation for this workforce, which is overwhelmingly represented by women of color and immigrants, is in alignment with the mayor's priority to provide a fair shot to district residents faced with rising costs of living, stagnant wages, and structural inequity. We know that this is a very challenging budget year, and the decisions made reflect tough choices. We also recognize that this is a national and regional issue that's been exacerbated by the pandemic and other labor market factors. I must emphasize that leading HDC members are committed to providing high quality and effective care and support to the aging residents who need their services. But in order to do so, they need reimbursement at a level that allows them to cover costs and pay a fair living wage to direct care workers and other licensed professionals. Leading HDC recommends that this committee earnestly review the mayor's fiscal year 2024 budget for strategic opportunities to fund and sustain meaningful wage enhancements for direct care workers. On behalf of Leading HDC, I thank you for your time and welcome any questions that you may have.
Thank you. Deborah? Okay, don't see Deborah. Mark?
Thank you. Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for all district residents with mental illness or substance use disorders, including the 30,000 district residents our 31 member organizations serve annually. The mayor's proposed budget for fiscal year 2024 for the Department of Healthcare Finance reflects substantial projected increases in healthcare spending, but relies on assumptions that deserve council scrutiny, both to determine whether adequate funding levels have been budgeted, but perhaps more importantly, to understand the expected impact on district residents if the assumptions are largely correct. The Department of Healthcare Finance has several major tasks in the rest of FY23 and over the course of FY24. Each of those operational tasks has important budget consequences. With the new managed care contracts underway as of April 1st, DHCF will need to watch closely over the next several months to ensure that beneficiaries are well informed about open enrollment, that prior authorized care is not needly disrupted, and that managed care paneling, credentialing, and payment functions are operating smoothly. Initiation of the new contracts provides important spending safeguards absent from previous managed care contracts through the use of payment risk corridors, and the district should benefit from this important tool for improved fiscal stewardship. The contract turnover adds additional stress while DHCF is undertaking 2 other substantial projects. Restart of Medicaid eligibility redeterminations is an enormous undertaking. The district has more Medicaid beneficiaries enrolled than any time in recent memory, both in absolute numbers and as a share of the district's overall population. The council should ask DHCF to explain its assumptions to have necessary assurance that funding levels budgeted will be adequate. The council should also weigh how projected disenrollments will play a role in reduced DHCF spending. That also implies that district residents will need to look elsewhere for healthcare that the district has financed over the past several years. Dramatic drop-offs in DC Healthcare Alliance enrollment since the end of the district's public health emergency and restart of Alliance recertification certainly provide some reassurance that the district is not offering coverage to people no longer eligible because they earn more or live elsewhere. But there are also likely large numbers of now former recent Alliance beneficiaries who simply failed to complete recertification, even though they remain technically eligible. DHCF's budget plans and its aspirations are in tension if the budget is built with assumptions that eligible district residents will reduce their participation in healthcare services due to coverage losses. The $10.1 million proposed reduction in Alliance provider payments reflects that tension and may also be a signal of the path forward for reduced growth in Medicaid spending due to coverage losses for eligible district residents who fail to complete the recertification gauntlet. The transition of DBH certified provider services to managed care is the 3rd substantial undertaking for DHCF over the course of the next 24 months. In my DBH budget oversight testimony, I shared the need for DBH and DHCF to provide an integrated account of proposed behavioral health spending and to clarify enrollment utilization and payment rate assumptions. The reduction to overall Alliance spending seems even more stark given DBH and DHCF plans to add for the first time outpatient behavioral health services to the Alliance program. The new benefit is good health policy, and I am grateful to see the investment. The council must also ask, though, just how many more Alliance beneficiaries does DHCF project will lose coverage if it's able to add this substantial new program benefit and also substantially reduce spending? As I said in my DBH budget oversight testimony, it remains unclear whether there's room in the proposed budget to adjust behavioral health provider payment rates to close the gap from inflation. A structured alternative payment methodology for DBH certified providers needs to be put into place. I hope the council will encourage DHCF to establish that alternative payment methodology for DBH certified provider services during FY24, so we can go into the FY25 budget prepared for the end of the so-called bridge period that DBH and DHCF have promised for the first 18 months that DBH certified provider services are in managed care. There's a great deal of incomplete work to prepare for October 1st, 2023, and it is also critical to begin to prepare for March 31st, 2025. In addition to these significant issues, I also encourage the council to discuss with DHCF the mix of district government staff as well as third-party contractors needed to support the process of restarting Medicaid eligibility redetermination, and encourage DHCF to continue to look for additional federal funds to support continuing need to develop the capacity and capabilities of the provider network. Thank you for the opportunity to testify today. I look forward to answering any questions you might have.
Thanks, Mark. Ian?
Good morning, Chairperson Henderson. My name is Ian Paragal, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. The coalition currently represents over 50 provider agencies, supporting over 2,300 persons with intellectual and developmental disabilities and employing over 4,700 staff. On behalf of the DC Coalition, we support the Mayor's FY24 budget, but we do urge the Mayor to issue the written findings from the Healthcare Workforce Task Force, which convened over the summer of 2022. Within that task force recommendations, there were a number of suggested strategies to address the workforce crisis that continues to exist within the healthcare industry. One such recommendation, which was noted in several subcommittee reports, was increasing the benchmark funding threshold for direct support staff to 120% of the living wage, replacing the 117.6 factor, which was born of the legislation passed in 2019 under the DSP Rate Payment Act. Prior to COVID, the DSP Rate Payment Act remained largely unfunded by the Mayor, and turnover and vacancy rates continued to swell. And then COVID struck, which resulted in a parabolic rise in vacancies from an already dangerously high baseline. As a result, the DC Coalition, as well as numerous other healthcare advocates, suggest that recruitment and retention needs will need to require an even more substantial commitment to funding. DHCF has offered supplementary funding in FY23, which attains 110% of the mandated 117.6% of the funding. But at this point, IDD providers are just too far behind with continually mounting turnover and vacancy rates. We would submit that in spite of the recent efforts, the 117.6% increase, which will not be fully funded until January 2025, will not be enough to attract and recruit staff for these demanding jobs and will not have an impact on staff vacancy rates. You've heard about the training requirements and job requirements, but without suitable workforce, the district will fail to meet the needs of our most vulnerable residents while also failing to address the socioeconomic equity arguments surrounding this workforce that others have raised. Relatedly, providers need some accommodation for or additional funding to account for the overtime generated from these staff vacancy rates, which now result in even higher operational expenses. Within my remaining time, I wish to highlight a few other fiscal considerations that need to be addressed by DHCF. First one is wage compression. Because of the difficulties in recruiting and retaining frontline staff workers have resulted in significant overtime wages, those who are providing direct supports are now earning on an annual basis more than their supervisors, and the supervisors are leaving their supervisory positions to take direct support positions, leaving no supervisors. It's left a supervision gap and an ability to recruit and retain mid-level leadership for the IDD provider community. We're recommending that additional fiscal support for these mid-level staff occurs so providers can maintain appropriate supervision ratios. Next one is the nursing shortage. Similarly, our funding for the nursing cohort lags behind the wages, and these same nurses can earn more in traditional or institutional settings where they have more clearly defined work schedules. We do recognize there are nursing shortages throughout the region, but we're also asking for funding so that our IDD providers can pay their nurses at least a competitive rate. PHE. Providers are using PHE-enabled funds right now to cover overtime and per diem staff coverage, but our staffing shortfalls will not be remedied by the fall. In fact, supplementary funding that is keeping the ICFs afloat will actually disappear in July. We need to engage in a strategic dialogue now, which considers projected vacancy data and post-PHE funding support in order to chart a sustainable future for services that's not reliant on these PHE stabilizing assets. We recommend convening a team of stakeholders to consider the fiscal implications of our post-PHE world. Number 4 is reallocation of remaining ARPA funds. We've requested that the district consider a reallocation of these remaining ARPA funds, which remain either unspent or unlikely to be spent, and that those undeveloped funds be braided into a more meaningful wage factor in order to increase wages, not only for direct support workers, but also for nurses. For example, there remains $5.2 million in unspent ARPA funds, which were targeted for staff recruitment. The DC Coalition encourages DHCF to convene a meeting which describes the planned use for the remaining ARPA funds and addresses comments from the community on possible reallocations. And finally, overtime. I wish to reiterate that the DC Coalition recommends that any continuing wage enhancements for frontline staff include allocations for expected continued overtime costs resulting from the unsustainable vacancy and turnover rates within the industry. On behalf of the DC Coalition Disability Service Providers, thank you for the opportunity and welcome any questions.
Thanks, Ian. And I'm sorry, I always get your name wrong.
No problem.
Corinne?
Good morning. Thank you for the opportunity to testify today. My name is Corinne Cannon. I am the founder and executive director of Greater DC Diaper Bank. Greater DC Diaper Bank is the first ever recipient of the $500,000 DC Diaper Distribution Program grant from the DC Department of Healthcare Finance, specifically intended for the use of purchasing diapers. The grant, which was first introduced in the Diaper Affordability and Access Act by Councilmember Christina Henderson in March of 2022, is unique in that this is the first time the city is providing direct resources to fund the purchase of diapers for redistribution. Today, I'm here to both thank the council for these funds and what they've allowed our organization to do, as well as ask for continuation of this funding in FY24. Greater DC Diaper Bank serves 32,000 babies and 40,000 families in the area each year with approximately 11 million diapers. Since our founding in 2010, we have distributed nearly 45 million diapers to families in need. We also provide formula, wipes, baby food, period products, and baby gear each year. Our vision is to provide basic necessities that aren't covered by government programs such as food stamps and WIC for all families. Providing diapers for your baby is not a choice, though we see too many families who are faced every month with the question of buying diapers or purchasing other essential items. 63% of the families we serve have told us that over the past year, they had to make a choice between buying diapers and spending money on food, rent, utilities, or transportation for their families. The impact of these decisions is felt by everyone in the family. If a family runs short on diapers and cannot change their baby as frequently as they would like, we know that can lead to health issues like diaper rash and UTIs, not to mention that babies who are in wet diapers cry more and can be more irritable, which adds to the stress of being a parent. We asked parents about the impact of diaper need on their own emotional health, and they overwhelmingly told us that when they don't have enough diapers, they feel stressed, sad, anxious, and like bad parents. We are thrilled to be working with the DC Department of Healthcare Finance and so grateful for the support that the DC Diaper Distribution Program provides us. With the $500,000 awarded through this grant, we are able to provide over 3.2 million diapers valued at $1.3 million because of our wholesale and corporate donation relationships. We will serve over 16,000 families in DC this year. And in the first 3 months of 2023, 29% of the diapers we provided in DC have been distributed to partners located in Ward 8. As we all know, Ward 8 has the highest rate of poverty in the city. This means that the diapers we provide are serving the families most vulnerable to diaper need at the greatest rates. What do diapers do? They strengthen DC families. We use a partnership model, and by leveraging our extensive network to secure diapers from in-kind donations, community drives, corporations, and wholesale purchases, we provide those diapers to our community partners for distribution through dozens and dozens of social service programs. In DC, Greater DC Diaper Bank works with 31 community partners and 6 emergency diaper need hub centers. All of these are local social service agencies and government agencies working with DC families. Working in deep collaboration with this extensive network of partners, we're able to distribute diapers for free to families in all 8 wards. I am very, very proud of our work in DC and throughout the region to help families parenting in poverty, but the need continues to grow. An adequate supply of diapers costs more than $100 per month for most of our families. Funding like the grant provided through the DC Diaper Distribution Program allows us to serve a greater number of families in DC so that they can focus their resources where they are most needed. Each family we serve receives between 50 and 100 diapers per month, which allows us to fill the gap between what parents are able to afford and the total number of diapers that their babies need each month. In closing, I want to thank the DC Department of Healthcare Finance for their support in FY23. I also ask that you would grant this funding in FY24 so we can continue to work together to ensure all families have the essentials they need to thrive. I'd be happy to take any questions. Thank you.
Thank you. And thank you to all of the public witnesses who are here and presented testimony. For some of you, we saw you last week. And so we appreciate your continued active interest in the various issues for the committee. Ms. Crossland, I wanted to start with you in terms of the discussion around medical respite beds. I've had this conversation with the Hospital Association and several hospitals, but also, you know, this has also come up with the Long-Term Care Coalition as well around individuals who we have in our hospitals who no longer need acute care, but we have no place else for them to sort of be discharged to at this particular point. If there was an expansion in terms of, you know, us providing this long-term care or something like that as an additional benefit for, say, Alliance members, do we even have enough beds available in the city to meet the need?
Definitely not. There are, as I mentioned, probably around 50 total, and we need
50 beds total?
50 beds total for the whole city. And we, as I mentioned, undertook just an informal survey of hospital care coordinators, as well as shelter staff and outreach workers, to find out kind of how often they're trying to access these services and are unable to. Based on that kind of averaged out over the year, we came up with the number of an additional 100 beds that would be needed. And I think that our experience during the pandemic and with the PEP-V program, which essentially allowed for unlimited medical respite beds, or at least an exponential expansion of medical respite beds through the isolation and quarantine. Essentially, anybody who was admitted with COVID could be considered a medical respite admission that avoided a hospital stay. Likewise, with the PEP-V program, hospitals were able to refer their highly medically vulnerable patients to this program to get the care they need. Some of those folks have been with us for a long time, which also sort of begs the question of the need for kind of a longer term, not short-term medical respite, which is what we think of medical respite as being a turnover of a couple weeks to a couple of months, but sort of a longer term, almost like a medically supervised shelter versus bridge housing, people for whom discharge back to the hospital, back to the shelter or the street would never be a viable option. Does that make sense?
Yes, yes. But I guess then my question would be, is this something, obviously it would be something, well, not obviously, but I'm going to assume this would be something that we contract out for, but are there companies that would be willing? I mean, there are additional costs here, right? Beyond just the reimbursement rate, but infrastructure, finding a location, et cetera.
Exactly. Yes. So we have testified before the Department of the Department of Human Services as well about this need. And I think that they are taking this to heart, especially with lessons learned from, during the pandemic. So obviously we need to get the beds to provide the service. And then once we have the beds, we need an improved funding stream through the Department of Healthcare Finance to pay for the services.
All right. Thank you. Thank you for that testimony. Thank you for being here. For everyone, if you haven't provided us with your written testimony, could you please do so? Ms. Cannon, it's good to see you. I don't think I've seen you since I went out to the diaper bank. And so I think in your testimony, it is so interesting and yet heartbreaking to hear. I think you said 63% of the families that you surveyed said that they had to decide between diapers and food or rent or other items.
Yeah.
And like you said, diapers are an essential component here. With the grant that you all received, were there, in addition to diapers, were you also able to secure formula as well?
So one of the things we're able to do with this funding is we were able to shift other funding to secure those products. So in our nursery and essentials pantry, we provide formula, period products, incontinence supplies, baby food, and we were able to put some resources toward baby food and formula, which are the things that are highest in demand after diapers. So these funds are also allowing us to secure other products by diverting funds that we had to use for diapers in the past. We're now able to use some of these other products.
Got it. Okay. Well, I'm trying to keep myself honest here and I'm over my time. But in this particular grant program, we had $500,000 in it for FY23. 100,000 of that was reoccurring. So we know at least that exists. We just have to find the other money.
And I'm confident we can do it.
Yes. All right. Thank you to all the public witnesses. Appreciate your testimony, and you'll be put back into the witness room, and then we'll call up the next panel of witnesses. So thank you. Okay, we'll call up our next 8. Sally White, Leah Casles, Justin Palmer, Sal Savego, Eric Scharf, Deja Williams, TJ James, and Fari Gamina Tupi. Again, for those who are just joining and I just called your name, you'll have to affirmatively accept our invitation in order to come into the room. Yeah. Sally?
Good morning, Chairperson Henderson and members of the committee. My name is Sally White. I'm working with the exciting new Edenbridge PACE program of all-inclusive care for the elderly at Skyland. As I testified previously, PACE is designed to meet the needs of adults 55 and older who qualify for nursing home care, but who want very much to remain in their own homes, in their own communities, living the best life possible. As the PACE provider, Edenbridge is responsible for providing all the services that each participant needs, including routine medical care, specialized care, therapies, assistance with activities of daily living, medication, socialization, transportation, and even hospital care when needed. It's the job of the interdisciplinary PACE team to seamlessly integrate Medicare and Medicaid benefits and to ensure that everyone in their care receives superior medical management and the care and support that allows them to live as well as possible in their own homes, while providing respite and other support to often exhausted family caregivers. For PACE participants who are eligible for both Medicaid and Medicare, there's no charge to the participant or their family members. We are extremely pleased that the beautiful new PACE Center, located at Skyland Town Center in Ward 7, and specifically serving residents of Ward 7 and 8, opened its doors on March 1st. I want to thank DHCF leadership and staff for working with Edenbridge PACE and others to improve the timeline for assessment through their vendor, Liberty Health. We are encouraged that the assessment process is moving in the right direction and hope that much needed improvements will be made in all areas of the enrollment process. I'm also here to address one aspect of the workforce issues that are having a huge impact on the availability of home health aides and other critical direct care workers. As you've heard from others, we, advocates and members of the DC Coalition on Long-Term Care, continue to advocate for these workers, home health aides and certified nursing assistants in particular, to be paid $24 an hour in 2024. Raising the minimum wage of direct care workers across all settings to a minimum of $24 is critical to their ability to remain in this line of work and consequentially to the care of our most needy residents. The HCF is planning to increase the average wage of direct care workers to 117.6% of the living wage by the year 2025. And the living wage recently was increased to $17 per hour. So at that rate, the 117.6% would bring the average, rather than even the minimum, up to $19.99 an hour. This will not result in wages near the $24 an hour needed now to train and retain workers. We can't attract the workforce needed without aggressive action. I know that it is, where can DC find the $40 million plus that we estimate will be needed to make this happen? I urge the committee to examine areas of unspent funds this year and last to see where there might be money that could be shifted to meet this need, and also to allocate remaining ARPA funds to this purpose. I know that it is daunting to put together a budget that meets the greatest needs in the city when so much federal support is ending, but the knowledge that thousands of older adults and younger adults with disabilities will be alone and neglected without the help they need because DC can't hire and retain the people to care for them is daunting as well. Thank you so much for this opportunity to speak before you today.
Thank you. Leah?
Good morning, Chairperson Henderson and staff. My name is Leah Castelas. I'm a policy attorney at Children's Law Center and a resident of the district. I'm testifying today on behalf of Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education and live in a world free from poverty, trauma, racism, and other forms of oppression. I appreciate the opportunity to testify today regarding the mayor's proposed budget for the Department of Healthcare Finance and its potential impact on children and families. My testimony today will focus on 3 ways in which DHCF's FY 2024 budget can improve access to behavioral health services for pregnant and postpartum people, children, and families. My written testimony will also address how we can invest in our current behavioral health workforce by offering competitive reimbursement rates to help create a health system that supports district families from pregnancy onward. Our first recommendation is for DHCF to establish the coverage and reimbursement of evidence-based home visiting under Medicaid. Home visiting programs connect families with a trained professional who's equipped to provide supports and resources that improve outcomes for both children and families in their homes. Despite the desire for and satisfaction with home visiting, this program continues to be under-resourced due to unsustainable funding. We must work to create a funding structure that meets the needs of this program. Currently, the district is leaving a potential source of funding on the table by not leveraging federal Medicaid dollars to support evidence-based home visiting. There are currently 37 jurisdictions that have or are in the process of having a Medicaid billing pathway for home visiting. The utilization of Medicaid dollars will not only provide a more sustainable form of funding, but will also free up local dollars, which can be used to increase access to more evidence-based home visiting programs or other services. After the establishment process, DHCF will need adequate financing to draw the federal match from Medicaid. We therefore are asking this committee for up to $450,000 to be invested into home visiting programs to support Medicaid funding once established for coverage and reimbursement. Second, we recommend that Healthy Steps be incorporated into DHCF's ongoing rate study. Although Healthy Steps provides a critical support for children and families in the district, its current funding structure is unsustainable. At this time, all Healthy Steps in the district must rely on local or philanthropic funds for its operations. These funding streams are often time limited or insufficient to cover the true cost of services rendered. The inclusion of Healthy Steps in the rate study will be a significant step forward in ensuring that Healthy Steps is billable through Medicaid and the district is best leveraging federal dollars to support children and families in the district. Sustaining Healthy Steps through Medicaid frees up local dollars to support other early childhood and family serving programs, as well as the expansion of Healthy Steps. Finally, I want to thank you, Chairperson Henderson, for your work in standing up the Perinatal Mental Health Task Force. We have appreciated your engagement with stakeholders in this work. We believe the task force is a step in the right direction to give much needed attention to perinatal mental health. However, as we testified to in performance oversight, the timeframe for the task force to complete a thorough public report that will inform recommendations to resolve inequities in perinatal mental health care, access, coverage, and coordination may be too limited. These concerns are shared by other task force members and leadership. We therefore ask this committee to amend the task force establishment legislation to extend the deadline for submission of the final publicly available report from October 1st, 2023 to December 31st, 2023. Additional months will provide necessary time to engage with the community and have important conversations while ensuring the task force works expeditiously and diligently to provide a public report to inform needed change and improvements to the systems that support perinatal mental health. We urge the committee to consider our recommendations with respect to the proposed FY 2024 budget for both DHCF and across all DC's health agencies. Building a behavioral health system that meets the needs of DC's children and families requires strong collaboration and communication across multiple agencies. Inclusion of these recommendations in the FY 2024 budget process will sustain and grow effective programs in the district and develop new ones that will support children and families in achieving optimal health outcomes, regardless of where they live, work, or play. Thank you for the opportunity to testify today. I welcome any questions.
Thanks, Leah. Justin?
Good morning, Chair Henderson, members of Community Health. My name is Justin Palmer, and I am the Vice President for Public Policy and External Affairs for the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Department of Healthcare Finance's FY24 budget oversight hearing. DCHA is a unifying force advancing hospitals and health systems in the District of Columbia. We are committed to promoting policies and initiatives that strengthen our system of care, preserve access, eliminate disparities, and promote better health outcomes for patients in our community. Our driving vision is to achieve an efficient and effective healthcare delivery system that supports a healthy, equitable, and vibrant community. Despite the revenue challenges, the Mayor's FY24 budget for the Department of Healthcare Finance continues to invest in the health and well-being of district residents. It does this while holding provider tax relatively stable across the board and investing $108 million in local funds to support increased expenditures in the managed care programs. As the department begins the redetermination process and winds down the PHE, it will be incredibly important to monitor the impact on patients and providers. The department's community engagement plan is very robust, and our members are committed to supporting DHCF in its efforts to ensure eligible beneficiaries maintain coverage without a break. Just as important is the need to monitor providers as they navigate the ending of the PHE. Several provider types received enhanced reimbursement rates during the PHE, which will end soon after the expiration. This may present challenges given the increased staff costs and overall inflation all sectors of the economy are facing. We know the department is sensitive to these challenges, and this will be instrumental during this transition period to monitor provider stability. Important to this budget year will be a robust oversight of the district's MCOs to ensure that providers are paid in a timely manner, that denials are minimized, and unnecessary prior authorizations are avoided. We are greatly appreciative of the department's openness to require MCOs to report or make public information provided regarding paid and denied claims, as well as prior authorization. This builds on the department's MCO accountability measures in place today. And we believe it is important, especially as behavioral health providers are carved into the MCO program. Finally, I would like to comment on a BSA subtitle that impacts several of our members regarding negotiated MCO rates. DCHA would prefer that this matter be handled through MCO negotiations with the hospitals and discussions with the department rather than the BSA. We continue to work with healthcare finance and our members to identify budget neutral policies options that might address this issue for everyone. In closing, I want to reiterate that DCHA looks forward to our continued collaboration with the department and the committee in advancing health system transformation in the district. Thank you for allowing me to testify today, and I'm happy to answer your questions.
Thanks, Justin. Sal?
Good morning, Councilmember Henderson. My name is Sal Salvaggio, and I'm a retired dentist and a member of the ONA Senior Services Citizens Advisory Group, Northwest Neighbors Village, and the DC Coalition on Long-Term Care. I've twice testified before you on our current lack of sufficient healthcare workforce, which is becoming amplified as DC's population becomes older and more in need of their services. I'd submitted to your office written testimony, but I'd like to deviate that a bit because of some thoughts and experiences I've had recently. I resubmitted this new testimony. From attending these hearings and listening to the needs of other groups who testify before you, I've come to appreciate the difficult and important decisions you and our other government officials need to make regarding how to spend our tax dollars. I'd like to suggest the following as a way to move forward on our issue. Have a point person. Addressing our workforce shortage will take a concerted and creative effort, which will require leadership willing to work across the many agencies that need to be involved to secure the necessary funding. We need a leader willing to spearhead that effort. As the chairperson of the Committee on Health, I hope you can be or can designate such a person. Use existing resources. The mayor's healthcare work task force included many stakeholders. They came up with a reasoned plan that can become a platform to build upon. Again, in order to do this, someone needs to take responsibility of evaluating the task force recommendations and implement a practical way forward. Work with the DC Coalition on Long-Term Care. They have real-world expertise from members involved in businesses, nonprofits, and groups representing the communities affected. The coalition can provide insights that can pull together the many moving parts and facilitate addressing this complex problem. Finally, yesterday at our Long-Term Care Coalition meeting, we were joined by James, a man who uses a wheelchair and requires care for 14 hours a day to help with his activities of daily living. He cannot negotiate his Adams Morgan apartment 9 steps to enter or exit without help. His regular healthcare worker canceled. He was unable to find a replacement. This has happened multiple times to him. He was asking for our help and also wants to become involved. So what is happening to him doesn't happen to others. His story, unfortunately, is not an uncommon one. I believe the coalition has given your office survey data from healthcare worker agencies that verifies that situation and situations involving people not being able to be released from a hospital bed to their homes because of our healthcare worker shortage that will become more common. Just speak to the hospital administrators. I think you have done that. Situations where nursing home and long-term care facilities being understaffed will become more common. Just speak to the overworked aides. I think you've done that also. Situations where children of aged parents will have to face the emotional and financial consequences of the decisions to stay at home and care for their loved ones or make a living. You can also just speak to them, and you probably have heard from them. Councilmember Henderson, you along with the rest of the council and the mayor have difficult decisions to make about our budget. I trust you will consider the impact our healthcare worker shortage is having in our community now and will have in the future, and then use it as a priority issue that needs to be addressed. Thank you very much.
Thank you. Eric? Oh, Eric is not here. Deja?
Hello, good morning.
Hi, good morning.
My name is Deja Williams. I'm Health Equity Organizer with Spaces in Action. I will be speaking on behalf of Esther Blackwell. She's a community member with us. So good morning, Councilmember Henderson and committee members. My name is Esther Blackwell. I am a mom, resident, and worker in DC and a student pursuing my undergrad degree. I am also a leader with Spaces in Action. My testimony today will focus on the public health emergency and the impact it has on Medicaid recipients and enrollment. My values are transparency, honesty, respect, and health. These values align with me through everything I have been through in my 39 years. These experiences, some good and some bad, make me who I am today. All my values deal with my health overall and help me to survive and thrive as a Black woman. The problem I am experiencing is miscommunication and navigation problems when accessing my healthcare. As a mom, ensuring my children have healthcare is a top priority. I had issues accessing healthcare through Medicaid, but could only get my children covered because of the pandemic. My child has autism, and the late diagnosis has affected his care. The everyday stresses of being a working mom and balancing my children's care tend to increase when I do not receive the proper communication and assistance from DC Medicaid. Occasionally, when I have never received mail detailing essential changes, managing healthcare as a parent requires me to navigate 3 different websites: DC Health Link, DC Healthy Families, and the website attached to my MCO. The problematic navigation with these websites causes significant issues when accessing my family's care. Unfortunately, my story reflects the reality of most DC residents on Medicaid. Communication issues like these will only make the recertification process tiresome for most families and could result in folks losing their coverage. Loss of coverage will increase when families no longer qualify due to the unwinding of the PHE. The solution should be to replace more value on communication and educating the community. Educating the community requires accessible resources about Medicaid enrollment, recertification, and the unwinding of the PHE. The next action steps for this council should be to protect our communities and healthcare. We call on the Department of Healthcare Finance to ensure that all Medicaid unwinding is as fair and equitable as possible. Contact beneficiaries using multiple forms of communication before considering purging them from the program. If they are deemed ineligible for Medicaid, refer folks to other programs, Affordable Care Act, CHIP, etc. We call on the Department of Healthcare Finance to comply with all federal CMS requirements for the unwinding process and maintain expanded Medicaid. Use funds to work with frontline organizations trusted by the community to engage and educate directly impacted folks. Use funds to advertise the Medicaid recertification. Folks need to get this information everywhere on buses, through mass text, etc., not just on the DC Gov website. Thank you, Chairperson Henderson and committee members for hearing my testimony. Again, this was testimony of Esther Blackwell, a Ward 8 community resident. Thank you.
Thanks, Deja, and thanks for lifting up Esther in her testimony today. TJ?
Thank you, Councilmember Henderson. Hi, my name is TJ. I'm the equity organizer with Spaces in Action. And today I will be proxying for one of our members with Spaces in Action. So good morning, council members and committee members. I am Deshaun Jones. I'm a Black man. I'm a brother. I'm an uncle. I'm a member of Spaces in Action, and I currently do not have a job. My testimony today will focus on the impact of the public health emergency on Medicaid recipients. My values are my family and my health. My family is my backbone and my health keeps me going. Both connect to who I am because my family has had health issues such as diabetes, oxygen dependency, and asthma. And I always feel short of breath when I go for long walks. I've never been diagnosed, but I make sure to eat healthy if I can afford to when I'm hungry. My values have been violated because my family has to deal with chronic illnesses daily with little to no assistance from the government programs. Makes it hard to have good health and to put food on the table at the same time. No one has a car in my family, so whenever I need to, or my family members need to see a doctor, we have to travel over 40 minutes just to see a doctor that's gonna take our Medicaid, and that's a problem. I live with my mom that can barely walk and my 2 younger brothers, aged 10 and 13. I am the person in the house that brings in the money, and we have moved over 3 times in the past 2 years, just of me losing my job and everything that was going on with COVID. I have problems paying rent, but Medicaid and SNAP have saved my life and my family's lives regarding the government programs. We call on the Department of Healthcare Finance to comply with all federal CMS requirements for the unwinding process to maintain and expand Medicaid. Medicaid should be given to all families, regardless of Medicaid should be given to all families making less than $40,000 a year, even if they do not have kids. It's hard out here and inflation is rising, making it even harder. Another solution is to let folks choose their doctors so they don't have to travel across DC just for a doctor's visit or something more serious. And lastly, as a result of the PHE ending, up to 15 to 17 million people may be losing their coverage, many due to procedural errors, understaffing, and insignificant resources devoted to this process. DC should ensure that no one loses care during the unwinding and use the IRA funds to expand care, because healthcare is a right and not a privilege. So let's act like it. And thank you for letting me speak.
Thanks, TJ, and thank you for uplifting Deshaun's testimony today. Fari? Sorry, if you're speaking, you're on mute.
Thank you.
There
Thank
we
you,
go.
Councilmember Henderson. Thank you so much. I'm Fariga Mina Tumpe. I'm with Spaces in Action DC, and I'm honored to serve as proxy for Ray Bridgewater. I'm Ray Bridgewater. I'm a healthcare leader in DC and a member at Spaces in Action. I'm currently leading the Assembly of Petworth, a council of community members in DC to organize around healthcare, environmental housing, and other local issues affecting the community. My talk today will focus on the impact of public health emergency and Medicaid recipients. My values are centered on the belief that everyone has inherent dignity regardless of religion, sexuality, financial situation. No one should fall through the cracks because of language barriers or financial barriers. We worked hard on HIV, asthma, men's health, prenatal care, and we've improved city policies here. We've helped bring medical mobile units into this region. We have the first telehealth dental mobile unit in this region, and now dental, mental health, hearing, vision, and the last frontier for healthcare services in this country. Folks don't have the jobs, transportation, money to pay for health insurance in this city and country. We have educational barriers too. The solution is to make sure that when we do health campaigns, we make sure folks have insurance, a primary care doctor, and a medical home, a clinic, or a hospital. This is the work we do in DC, and nobody should be denied these things because of cost. We need to protect as many people as possible and keep them insured during the Medicaid unwinding. Assembly of Petworth in Ward 4 of Washington, D.C. is working on multiple projects locally, and we believe in global health. Health problems do not stop at the border. Diseases don't stop at the border. We want to protect folks with Medicaid. The safeguards that were put in place during COVID should stay in place. We can't let anyone fall through the cracks. We also want to protect folks who are not yet citizens in the United States. We need to create safeguards for undocumented folks. We need to protect our communities and our health care. We are calling on the DC Department of Healthcare Finance to ensure that all Medicaid unwinding is as fair and as equitable as possible. Contact beneficiaries using multiple forms of communication before considering purging them from the program. If they are deemed ineligible for Medicaid, refer them to other programs, affordable care, CHIP, etc. We need to protect our communities and our health care. Thank you for your time. And again, that was on behalf of Ray Bridgewater. Thank you, Councilmember Henderson and the committee.
Thank you, Fari, for raising up Ray today in the hearing. I do have a couple of questions. Justin, I want to start with you. So as you know, in addition to just the numbers and cents of the budget, there is a Budget Support Act as well. There's a Budget Support Act title that's specifically relevant to the hospitals in terms of I think I will say it in layman's terms, a cap essentially on the Medicaid payment in terms of what MCOs will pay. Hold on, I'm pulling it up. Medicaid hospital provider reimbursement is what its title is, but it allows for the department to fund capitation rates at certain minimum levels. What are you hearing from the hospitals about this particular subtitle and the impact that it would have on services?
Thank you, Chair Henderson. So the BSA subtitle would set minimums and maximums on the MCO rates for hospitals. we have several hospitals that are impacted by this cap. So and others that are not. The ones that are impacted the most are significantly concerned about its impact. Overall, it's accounts for $11 million in local savings in the district, which put together.
Yeah, which is not an insignificant number. $11 million is not an insignificant number. So that's why I'm asking, like, what does this mean in terms of, obviously hospitals have, ethical considerations, right? Or requirements, if you will. They can't turn someone away for service. But if they know that whatever they're provided is capped, like, what does this mean for patient care?
I think that varies by hospital on what the impact is. It does for the hospitals that are impacted. It is not an insignificant amount. I know that there are members that will testify later. I think hospitals continue to care, but I think in this time of growing costs, there is a concern for those members that are impacted on what that would be. I think it is. I mean, it translates to about $37 million with that. So it's more than just the 11 million.
That's right, because of the federal match.
Yeah, it magnifies, and so when you're talking about that 37 million is spread across the hospitals. The way that when we went to mandated contracting with all the MCOs and vice versa for the hospitals, there was provisions put in place, and the minimums are set up where our fee for service, and there were no maximums. And some of the rate growth was related to when the fee for service outpatient rates were about 77% of cost. The minimum floor was 130% for the MCO rates, which equals about 100% of cost. But subsequently, the Department of Healthcare Finance did raise the fee for service on the outpatient side to 100% of costs, which our costs are district-wide average. So the hospitals that it tends to be more expensive to care for patients, let's say pediatrics, it's just a more expensive.
Good morning. How may I help you?
Sorry, you're not on mute.
So when you look at a district-wide average, that's how the fee-for-service rates are done during rate setting. So depending on the cost of the patients, it varies for the hospitals.
Okay, I'll follow up with, I think in the next panel we have a couple of the hospitals. So I'll ask them sort of what it looks like more specifically.
And we're happy to work with you and the committee staff as this process goes forward too.
Perfect. Thank you. Thanks to everyone else who testified. Leah, I appreciate I know we just extended the date for the perinatal mental health task force from August to October. And one of the reasons we were trying to do it until that, well, two things. One, the money for that person, we had to pay for it. But also two, it would be nice to incorporate some of the recommendations in the FY25 budget. And so we felt like we needed, if we waited until December in order to get recommendations and feedback back, that we would miss the window inevitably, especially given the glacial pace by which reports have been coming out from the Bowser administration at this particular juncture. I think someone else mentioned earlier, the healthcare workforce task force. I think Sal mentioned that. Still waiting on the report that task force did months ago. And I think now we were just told we shouldn't anticipate it until May. So, but thank you to everyone who testified. And if we don't have your written testimony, please make sure you submit it for the record. we'll go on to the next panel. Thank you. Okay, we're making some progress here. Louisa Freshberg Beckman, Tiffany Bukowski, Patricia Quinn, Mark Miller, Dr. Kurt Newman, Aldwin Lindsay, Toya Kinlow, okay, Fari presented the testimony for Ray Bridgewater, but Ray Bridgewater is also listed here. So it could be a different Ray, so we'll leave it.
It is the same Ray. He testified. I mean, he signed up just in case, but he wasn't able to make it so far.
Okay, great. All right. So we'll go to we'll also add Nisa onto this panel. Okay, I see Louisa, so why don't you go ahead and get started?
Thank you. Good morning, Councilmember Henderson, members of the committee and council staff. My name is Louisa Furstenberg Beckman, and I'm the Produce Prescription Program Manager at DC Greens, a nonprofit that advances health equity by building a just and resilient food system in the district. Our organization administers a produce prescription program that provides qualifying adults and children who are Medicaid recipients with $80 a month to purchase fresh and frozen fruits and vegetables. Produce prescriptions benefit patients by helping to prevent diet-related illnesses and reducing healthcare costs. They also benefit DC's economy by reinvesting funds back into local stores. Currently, our program serves over 1,300 adults and 900 children throughout the district. Access to produce prescriptions through Medicaid has grown substantially over the past 2 years, thanks to the support and investment from DC Healthcare Finance and their Produce Prescription Grant Program. In 2022, with financial support from DHCF, DC Greens was able to expand our program to 3 additional clinics, now allowing our patients to access produce prescriptions at 17 clinic locations across all 3 managed care organizations in DC. We were also able to increase our number of giant locations patients can redeem their prescriptions at to 5 out of the 7 DC locations. This year, with support from DHCF's Produce Prescription Grant, we'll be expanding our program even further to include other major grocers, such as Safeway and Walmart, as we transition to a more scalable program model. When Mayor Bowser's budget proposal was released on March 22nd, DC Greens was ecstatic to see that she recommended allocating $500,000 of local funds to support DHCF's Produce Prescription Grant Program in FY24. We're happy the mayor sees the value of produce prescriptions, and we urge the council to as well. Recently, DC Greens conducted an evaluation of our program. Results illustrated that of those who participated, 39% experienced a reduction in their hemoglobin A1C levels, 35% saw a reduction in BMI, 34% saw a reduction in blood pressure, and 75% reported an increase in their fruit and vegetable consumption. These are really great numbers. DHCF's grant program continues to provide critical funding to operationalize produce prescriptions in the district, and the budget of $500,000 will surely help thousands of Medicaid beneficiaries who are navigating their chronic conditions while also food insecure. However, we urge the council to recognize that current access to produce prescriptions remains quite low relative to the need in our city. And to meet that need, we must do more. Food is medicine programming spanning medically tailored meals, medically supported groceries, and produce prescriptions should be fully integrated into our healthcare system in DC. These programs are essential medical interventions that our residents need. By making these programs reimbursable services, we will create sustainable funding streams for food as medicine providers, will improve health and decrease healthcare costs. At DC Greens, we envision a day where access to nutritious food is part of our overall healthcare system in our city, and we know that DHCF shares that dream. We urge the council to support the mayor's budget recommendation while also considering the future needs of food as medicine programming in the district. Thank you for your time and consideration.
Thank you. Tiffany?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Tiffany Bukowski, and I'm the Government Affairs Manager for the Mid-Atlantic region of the National Service Office for Nurse-Family Partnership and Child First. Thank you for allowing me to testify on Mayor Bowser's proposal FY24 budget for the Department of Healthcare Finance. For those of you who may not be familiar with the Nurse-Family Partnership, I would like to provide a high-level overview. Nurse Family Partnership, commonly referred to as NFP, is a community health program with over 40 years of evidence that pairs registered nurses with low-income first-time mothers to provide home visits during pregnancy and through the first 2 years of the child's life. Specially trained NFP nurses provide home visits to help moms set goals to improve their health, their children's health, and their family's economic self-sufficiency. The first NFP program in the district launched at Mary Center in July of 2021 with a 4-nurse home visitor team. To date, the NFP program at Mary Center has enrolled and served more than 95 families throughout the district and is currently working with Martha's Table to expand NFP access to families in Wards 7 and 8. Successful NFP implementation at Mary Center was due to both council grant funding plus philanthropic dollars raised. The council previously committed $150,000 annually beginning in FY21, and Mary Center received $1.3 million in private charitable funds, with an additional $967,000 from the National Service Office. The incentive fund from the National Service Office and private philanthropic dollars end between March and August of 2024, therefore leaving the NFP at Mary Center and Martha's Table without sustainable funding. The vast majority of families who receive NFP services are enrolled in Medicaid or DC Health Alliance. With this knowledge, I am respectfully asking the council to leverage Medicaid dollars to support evidence-based home visiting. Using the Medicaid program's federal match will allow Mary Center to not only sustain its existing NFP program, but will allow a second team of 4 nurses to serve families in Ward 7 and 8 at a cost of only $187 per month per family. On an annual basis, the total cost to sustain the current program and expand the program in 2 additional wards is less than $450,000. Funding NFP and other evidence-based home visiting programs through Medicaid is not only cost-effective, but the district would see greater cost savings based on improved health outcomes of moms and babies. According to a Miller report, if Medicaid fully funded NFP in the district, each level of government would reap Medicaid savings that exceed its share of undiscounted NFP costs when the child was age 6. NFP yields an 8.1 to 1 benefit cost ratio, which means for every $1 invested in NFP, roughly $8.10 in future costs for the highest risk families will be saved. The return on investment for the district includes numerous health benefits, which I have included in my testimony. Medicaid dollars are currently being leveraged in 37 states to help fund evidence-based home visiting programs, including NFP. While payment structures and rates vary from state to state, utilizing Medicaid is cost-effective. For example, Alabama utilizes a targeted case management state plan amendment where the Medicaid benefit covers prenatal through baby age 2. Alabama reimburses via a monthly case rate of $765.47 with a minimum of 2 home visits expected. That amount, of course, must cover all home visits provided in that service month. Idaho utilizes a targeted case management state plan amendment where the Medicaid benefit covers prenatal through baby age 2. The payment is $250 per visit with no limit to the number of visits. Maryland utilizes targeted case management through a state plan amendment where Medicaid covers home visiting services prenatal through baby age 2. The reimbursement is $188 per visit with a maximum of 1 home visit per week. Oregon utilizes a targeted case management state plan amendment where the Medicaid benefit covers prenatal home visiting services through baby age 2. The benefit is based on model and client need at a cost of $460 per visit for the total FMAP, with a federal portion at about $307 per visit. The NSO would like to see the district leverage Medicaid dollars to not only support evidence-based home visiting, but use programs like NFP as an integral part of state strategies to address Black maternal health and disparities in perinatal health outcomes. Evidence-based home visiting benefits the district and provides an opportunity to support moms and babies within our communities. As such, we at the NSO respectfully request your support to leverage Medicaid dollars and to support evidence-based home visiting, sustain the current program at Mary Center, and expand the program into additional wards. Thank you for the opportunity to testify.
Thank you. Patricia?
Good morning, Councilmember Henderson. Thank you for the opportunity to testify today on the FY24 DHCF budget. I'm Patricia Quinn, Vice President of Policy and Partnerships at the DC Primary Care Association. Our biggest concern right now is the impact of the end of the Medicaid and Alliance continuous coverage provisions implemented at the start of the pandemic. The Geiger-Gibson program in community health at GW has done an estimate of the impact of those coverage losses on community health centers across the country. In DC, they estimate revenue losses for the health centers as between 12.9 million and 24.2 million. Those revenue declines could mean health centers experience staff reductions of between 78 and 145 FTEs, and therefore subsequent capacity to serve between 6,500 and 12,300 patients. The lower bound estimates account for the fact that some of those who lose coverage may gain other health insurance, either Alliance or commercial insurance. We asked for the committee's support for three strategies that could mitigate some of these coverage losses and their subsequent impact. One is to create a direct fast track access between health center staff who are supporting patients through the enrollment and redetermination process and the district staff who can assist them in addressing systems issues. This will maximize the human capital that we are all collectively investing in making sure our residents maintain coverage. Second, we want to co-locate the district employees responsible for managing Alliance and Medicaid redeterminations with community health center teams at community health centers. This was something that was utilized frequently pre-pandemic to increase efficiency and to improve service. Third, we asked that the committee monitor the rate of coverage losses and subsequent health center revenue declines and the impacts on health center capacity, and be prepared to put holds on removals from Alliance and Medicaid roles if it's the redetermination and enrollment system that is at issue in that lost coverage. Lastly, it becomes ever more important that health centers and other providers be able to effectively, efficiently, and timely be paid for the services through MCOs that they're delivering. We urge DHCF to improve the functioning of the MCO billing system, standardizing processes around billing, credentialing, prior authorization to limit provider burden and the subsequent delays in patient care. We believe we have DHCF support to utilize these tools to maximize capacity, protect health center patients, and maintain health center stability. I'm happy to answer any questions following this. Thank you.
Thank you. Mark? Mark's not here. Dr. Newman?
Excuse me. Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for permitting me to testify this morning. My name is Kurt Newman, and I am President and CEO of Children's National Hospital. I'm joined here today by two colleagues, Tanya Vidal-Kinlow, Vice President of Community Engagement, Advocacy, and Government Affairs, and Aldwin Lindsay, our Chief Financial Officer. We thank you for this opportunity to present testimony at the Department of Healthcare Finance's fiscal year 2024 budget oversight hearing. Children's National has long understood the importance of making high-quality healthcare accessible in all 8 wards, and we are excited to also be now the pediatric partner at the Cedar Hill Medical Center. We are testifying this morning because we are very, very concerned about a proposed policy change to cap inpatient and outpatient rates for Medicaid managed care organizations. This will negatively impact Children's National. We believe this policy will trickle force cuts in the reimbursement that MCOs pay hospitals. The proposed change is projected to save $11.3 million in District of Columbia local funds. However, because this is a cut to the Medicaid program, the city would additionally lose an estimated $26 million in federal funds. For Children's National, when you put those things together, of that $37 million, the policy change will create a $17 million reimbursement loss for Children's Hospital. As the healthcare safety net for district children, insufficient reimbursement rates would significantly harm our ability to sustain the comprehensive system of pediatric healthcare that we have created. In our opinion, the proposed $11.3 million savings far surpasses the significant loss of federal funds and the very negative impact on Children's National. We struggled to maintain financial sustainability throughout the pandemic and then the triple-demic. And Children's National, like many other healthcare providers, is still struggling under the skyrocketing cost of the increased staffing costs and shortages. In our humble opinion, this is simply not the time to make policy changes that would cut reimbursement to Children's Hospital. If forced to sustain a $17 million rate cut, we may have to do what I was proud we did not have to do during the pandemic: cut staff or reduce service availability. For example, we estimate that the projected policy change impact would equal the cost of between 150 and 170 nurses. I would hate to have to consider changes that would reduce services in our outpatient clinics in places like Columbia Heights, Shepherd Park, Anacostia, the Arc. Children's National is a vital safety net for all children in the DC metropolitan region and treats all children with all levels of healthcare needs. In fiscal year 2022, nearly 43,000 DC Medicaid beneficiaries received care from Children's National. Of the 43,000, 20% were enrolled in fee-for-service Medicaid, but 80% were with a Medicaid managed care MCO plan. We do recognize that these are challenging financial times and difficult decisions must be made. Trust me, our hospital faces similar challenges with escalating operating costs and diminishing revenues. But it is for this reason that we urge you to reject DHCF's proposal. We believe it will have a disproportionate impact on Children's National that will force us to make hard choices about how we maintain our high-quality, comprehensive system of care. We urge the council to oppose the Budget Support Act, subtitle Medical Hospital Reimbursement Act of 2023. And thank you for allowing me to testify today. And I and my team are happy to answer any questions you may have.
Thank you, Dr. Newman. Aldwin, Lindsay? Oh, are you presenting testimony as well?
Supporting Dr. Newman in this testimony. Thank you.
Okay.
And same with Ms. Kinlow.
Okay. I'll have some questions if you guys can just hang on for a sec. Nisa?
Hi, good morning. Good morning, Chairperson Henderson and members of the committee. I'm Nisa Hussein, Early Childhood Program Manager for DC Action, Chair of the DC Home Visiting Council, member of Under 3 DC, and Ward 1 resident. Today, my remarks will focus on our request for an investment in the Department of Healthcare Finance's FY24 proposed budget to leverage Medicaid dollars to sustain home visiting programs in the district. Home visiting is an evidence-based strategy that supports pregnant parents, new parents, and families with young children to navigate the challenging and critical early years of parenting. This service is a preventative public health strategy that can lead to reduced child abuse and neglect, increased school readiness, positive maternal and child health outcomes, and improved family economic self-sufficiency. DC home visiting programs primarily focus on families with low incomes and several risk factors and can connect them to other vital health services that the district offers that they may want or need. However, DC home visiting programs have been struggling with underfunding for years now. Local home visiting grants have not been adjusted for inflation since 2019, and programs have been unable to address home visitor turnover caused by low pay. Without adequate investments, programs will continue to lose home visitors to higher paying jobs and ultimately disrupt services to families who rely on them. In order to allow our programs to focus more on serving families with a strong workforce and less about stretching their limited funding, we recommend that the district leverage federal Medicaid dollars to support evidence-based home visiting. This pathway is growing in popularity across the country, and we hope to model after the other 37 successful state examples. Braided funding will strengthen the sustainability of home visiting programs staying funded each year and allow local dollars to address the remaining home visiting challenges. Additionally, the majority of home visiting families are enrolled in Medicaid or DC Healthcare Alliance, so there is already alignment with these programs serving Medicaid eligible populations. This idea can come to fruition if DHCF establishes the coverage and reimbursement of evidence-based home visiting under Medicaid. We recommend the establishment process involves collaborating with key stakeholders, including us at the DC Home Visiting Council and all of our partners. After this coverage is established, DHCF will need adequate financing to draw the federal match for Medicaid, which is at 70%. Therefore, we are asking this committee to invest $450,000 to DHCF's budget to support this Medicaid funding. If we as a district want to see sustainable improvements in maternal, child, and family outcomes, we also need to invest long-term. Leveraging Medicaid to funding home visiting programs is a cost-effective, coordinated approach to supporting DC families moving forward. Thank you so much for the opportunity to testify, and I welcome any questions.
Thank you. And thank you to everyone who testified. Nisa, let me start with you. I wanted to ask a question. Obviously, we heard some testimony from the earlier panel about the home visiting program as well. What % of DC home visiting programs would currently be able to meet the evidence-based requirement if Medicaid funding was provided?
That's a good question. I think right now we're focusing on the Mary Centers NFP program. I believe the Healthy Families model also would be eligible, but I would have to double check with my colleagues.
Okay, it would be good to know if more than just Mary Center would qualify. So if you could get back to the committee, that'd be great.
Yeah, absolutely.
Okay. Oh, yes. I guess that's a similar question for Tiffany, although Tiffany is representing sort of everyone for the Mid-Atlantic region. So I'll stick that one with you, Nisa. Sorry. Okay, so I wanted to follow up Dr. Newman and the Children's National Team. I think you raised an excellent point, is that it's not just about the 11 million on the local part, but there is also a $27 million federal match that would also be a cap as well. I guess I'm trying to understand best how to sort of explain this. I obviously haven't talked to Director Turnage about this particular subtitle just yet, but after. So let me ask this question. Are there any particular questions that if you could ask Director Turnage, you would ask him about this?
Well, we have asked him a number of questions about this, and I'll defer to my colleagues. I would say it's the timing of a Medicaid cut for our which disproportionately impacts our children and our children's hospital is, this just isn't the time when you see the expenses rising. So the big question I would have is, how do we make up for the services that we won't be able to provide given what the impact of a $17 million cut? I mean, we're a nonprofit. We've struggled to balance our budget. And so, so 17 million means jobs or, hours or locations that we would have to cut back. There's no, there's just no fat or wiggle room. So that's the question I want to know. What do you cut? I just, I know I sound frustrated here, but it's at a time when the needs of our kids are even more intense. If you think about the mental health crisis that we're facing, if you look at the passion of many of the other people that were testifying, I mean, we're there for these kids and families no matter what, 24/7, 365. Where do we cut back these services? What do we not do?
Right. So let me ask this question maybe of Mr. Lindsay or Ms. Kinlow. Obviously, Children's doesn't just serve DC kids. That's the bulk of your patient intake, but I'd imagine that you also serve kids from Maryland and Virginia and the region writ large. To your knowledge, are any of the other Medicaid programs, do they have this similar cap in place?
There are currently no caps, Councilmember Henderson, with regards to Maryland or Virginia that is being proposed at this time.
Or currently existing?
No, not existing at all.
Okay, so there are minimums, right? Like I would imagine for anyone, but the maximum is the new piece.
That is correct, and that is challenging for Children's, given that I think we have consistently been reimbursed at this rate. So it's not new to Children's National. And so this impact, as Dr. Newman articulated, would be very significant in terms of our ability to continue to provide care in our most challenging clinics across the District of Columbia, including Anacostia, Columbia Heights, the ARC, and others.
Right. And I know that at least for those locations, as with any of the healthcare workforce or anyone in the health space, finding nurses is really difficult at this particular time. And so when you say we might have to cut 150 to 170 nurses across the system, that definitely caught my attention. Because I think for some folks, it's not just the hospital, it's the clinics that you also have as well that provide great primary and preventative care services. Okay, I am over my time, but we've been joined by Councilmember Parker. Councilmember Parker?
Yes.
Questions for this panel?
Yes, thank you. It's great to see many of you again. Thank you all for your testimony. I'm going to start with you, Dr. Newman. Really compelling testimony in terms of the impact that these cuts would have on Children's. And I just want to make sure I'm both understanding the shift, but also what your ask is. I know generally you're saying reject the proposal of the budget amendment, but I want to just dig in a little bit more. So I'm reading the budget amendment, and it says there's two parts that I'm assuming you're taking issue with, and I just would love if you or members of your team could speak to it. One is a maximum outpatient reimbursement of 110% of the fee-for-service rate set forth in the state plan. What, if any, concern do you have around that? And you're muted.
Apologize for that. Thank you for the question, Councilmember Parker. And I think I'd defer that one to Mr. Lindsay, our Chief Financial Officer.
Thank you, Dr. Moon. So the NPO plans are risk-based plans. And so essentially, the cap that's being imposed on them is a limit to the amount that we pay in these plans. And so the district has historically not involved itself in negotiations between provider and health plan. Essentially, we're asking the district to continue that policy with engagement and allow the hospitals and the health plan to work through any negotiation without any caps or restrictions about rates.
Got it. And traditionally, so the proposal here is 110%. If there was a magic number, what would you say that number is? I'm hearing what you're saying, that you don't want to cap it all, but what is the magic number that would be more in line with what would be good for children's?
That's a difficult question to answer, given that we are continuing to see salaries escalate at 7% per year over the last 2 years. And so to say that that we could tolerate any reduction in reimbursement would be difficult to answer.
Councilmember Parker, pardon me for.
I'm sorry, 1 second, Dr. Newman. I do want to just ask one quick follow-up, Mr. Lindsay. Understanding that outside of the cap, you are able to negotiate a range of reimbursement rates. Can you give me a sense of where those reimbursement rates typically fall for children's?
Across the current MCOs or
yes,
general?
Yes.
Generally, I would say that we, on average, are probably closer to the 130 that the Hospital Association testified earlier in their testimony in terms of what the city had set in prior years as the overall reimbursement rate.
That is super helpful. Sorry to interrupt, Dr. Newman.
No problem, Councilmember Parker, and thank you for the interest. I think also the way I understand it is that these rates, when it says 110 or whatever, it's a blended rate, and so it doesn't take into account when you just talk about an average that the expenses, for example, in our case, taking care of children is much more expensive and intense than adult care. And so that's why sometimes these nuances, and I'm so glad you're delving into this, because these nuances are the critical pieces.
Yes. Thank you all for that. And I would just reiterate what Councilmember Henderson said. You know, the cuts that you're suggesting this will incur are concerning. And so this is certainly something I'm willing to look into with colleagues. I did want, in my remaining time, to come to you, Patricia Quinn. You gave several recommendations, and I just wanted to get a better sense on your recommendation of creating a direct fast track for the redetermination process. Like, can you speak more to that?
Sure. Excuse me. Before I jump there, we are looking at millions of dollars in loss to health centers as well. So similarly challenged as the children's team describes. So our recommendations are to try to mitigate those coverage losses that are going to have those kinds of impacts. A fast track line, right now, if a health center patient comes into a center and asks for help in enrollment from health center teams, and they're working with that patient to try to enroll them in coverage, if they hit a glitch in the system, they can't get past a screen, or they need to figure out why something's not working the way it's supposed to, the health center staff member gets in line with everybody else who is trying to get through to the call center, trying to get that assistance. We're not trying to jump line on anybody, residents who are trying to get care. But when we've got that capital sitting at the table with a patient really ready to help them, we need them to be able to get very fast resolution on what the barriers are for completing the enrollment. So we don't want them just in the queue, because collectively we're spending money on that person who's assisting the resident and the patient in front of them. So how do we expedite getting those problems solved when that interaction is already happening?
That's my time. Thank you again for everybody on this panel testifying.
Thank you, Councilmember Parker. Dr. Newman and your team, I just want to ask one follow-up question. Are you all is Children's considered a specialty hospital under the state plan?
No, we're not.
Okay.
We're an acute care pediatric hospital under the state plan.
Acute care pediatric. Okay. Thank you. If possible, Ms. Kinlow and Mr. Lindsay, if we could follow up with you guys offline with some further questions, would that be okay with you all?
Council member, we are looking forward to an opportunity to follow up with you. in more detailed fashion, and we'll work with your team to schedule that.
Okay, great. Thank you so much. Thank you to this panel of witnesses.
Yeah.
Okay, we have our final panel for healthcare finance. Just to plot where we are going here for folks, we will likely take a 10-minute break after this panel is over. So just begin, I want to telegraph that for the folks who are signed up for DMHHS. After we finish this panel, we'll take a 10-minute break. All right. Last few, Donjale Williams, Gibran Eubanks, Ebony Silver, Marie Morlis Black, Claudia Schlossberg, and Dean Brenner. Okay, I don't see Donjale Williams. So Mr. Eubanks, or my apologies, I pronounced the wrong. Gibran, there you go.
Yes, Gibran Eubanks. How are you doing?
Good to see you.
Henderson. Thank you all. Good morning, Chairperson Henderson and the members of the committee. Thank you all for the opportunity to testify at this budget hearing. Again, my name is Gibran Eubanks. I'm the political organizer for 1199 SEIU. We represent 400,000 workers across the healthcare continuum up and down the East Coast, with thousands of healthcare workers in hospitals, clinics, and skilled nursing facilities in the District of Columbia. I'm here today to testify on behalf of our members and of all the district's healthcare workers who are struggling to make ends meet on low wages and are unable to provide necessary care to consumers due to severe staffing shortages. We know we're facing staffing shortages in many different industries throughout the nation, but since the pandemic, shortages in home health aides and certified nursing assistants have caused a crisis in the workforce. These workers, who we call essential workers, are now feeling even more underappreciated than ever. According to PHI, a leading advocacy organization advancing policies to transform elder care and disability services, the District of Columbia is projected to have over 3,000 new job openings for CNAs and 3,000 new job openings for HHAs between 2020 and 2030 to meet the needs of an aging population. As our senior citizen population drastically increases, so will the need for qualified direct care workers. When considering the normal rates of work turnover, there will be over 23,000 new job openings for CNAs and HHAs during this decade. The Department of Healthcare Finance is using American Rescue Plan Act funding, which has increased the average wage of home health aides to about $18.50 an hour. This is not enough to address the staffing shortage, nor is it a living wage in District of Columbia. As we know, everything is going up, from rent to gas to even groceries, increasing by 11% from January 2022 to January 2023, but wages have stayed the same. Simply put, District of Columbia residents cannot afford to do this work and still live here. When speaking to our members regarding the challenges they face, their main concern is always for the patients. They're upset and frustrated that they cannot provide the patients with the quality of care that they deserve because they're responsible for looking after so many patients at once. In the workplace, workers are typically responsible for up to 15 patients, but due to staffing shortages and high turnover, workers are now caring for 20 to 25 patients each. They share stories of residents who get bed sores because they have not been flipped due to not having enough nurses to assist with the physical demand of moving the resident. These patients are then sent back to overpopulated hospitals to be treated for new injuries, causes a seemingly never-ending cycle. We hear stories of the mental burden that the job has when workers are constantly being called in to work on their day off to cover a shift, stripping them of sometimes the only day off that they have to handle their own personal needs. Also, many providers are no longer accepting new patients because they don't have enough workers to properly care for them. When we consider the solutions, the district must follow the lead of other jurisdictions to make a greater permanent investment in these jobs. Projections show the number of adults over 65 in the district will increase by 25% within this decade. Our members in skilled nursing facilities have experienced changes in their day-to-day due to an increase of residents with higher needs, such as dementia care, wound care, or residents with ventilators. 1199 strongly supports efforts to ensure workers receive all the training they need to find success in this extremely difficult work environment. Everyone from cooks to housekeepers have crucial responsibilities when it comes to upholding a high standard of care. Our healthcare system is often viewed in silos: hospitals, clinics, nursing homes, home and community-based services, when in fact, all these care settings are deeply connected. Hospitals must be confident that they're discharging patients into settings where they will thrive. For too long, long-term care has been an afterthought in our healthcare system. And last but not least, this is not just a workforce crisis, but it's also an equity crisis. Over 87% of our direct care of direct service workers in the region are people of color. Most of the workforce is constituted of Black women. 1 in 5 direct service workers in DC live in poverty, and 63% rely on public assistance. As someone who's had a family member who battled Alzheimer's for 12 years, I fully understand the importance of home care work. My aunt, who is bedridden and could not do anything for herself, needed a home health aide and personal caretaker. Our HHA, Miss Sylvia, became more than just a worker, she became family. The care that she provided to my aunt could not be duplicated by just anyone. You have to have a certain type of character to do this work. When I think of what a superhero is to me, I think about the dedicated people in this workforce that make countless sacrifices to care for the less fortunate. We need to show these people that we have their back and that we truly appreciate the work they do, because no one plans to get sick, but we can plan to care. Families like mine depend on us to center the needs of the elderly and disabled residents. Thank you, and I'm happy to answer any questions.
Thanks, Jabron. Ebony? He's not here. Marie?
Good morning, Chairperson Henderson, members of the council. Thank you for the opportunity to testify at the Department of Healthcare Finance Budget Oversight hearing. My name is Dr. Marie Rose Black. I am the CEO of MBI Health Services. And I want to take this opportunity to tell you a little bit about us. We are a large Medicaid provider in the district, serving residents in our home health agency, intellectual or developmental disability programs, homeless prevention and permanent supportive housing, supportive employment. And last year, we opened the first urgent care clinic east of the river. And we operate from 7 a.m. to midnight, 7 days a week. We are the largest behavioral health agency in the district, serving over 6,000 adults and children and families. And overall, we touch just about every human service agency, providing services to approximately 10,000 district residents. We are committed to serving our residents and provide excellent customer service, high quality care, and achieve positive outcomes and results so that our residents can live their best life. I want to thank Deputy Mayor Turnage and the leadership of the Human Service Agencies, Director Baswan, Zylanger, Director Bird, Director Reese, for their leadership through the pandemic during their weekly meetings. A special thank you to Director Bird and her staff for her ongoing participation at the Thursday weekly meetings during the pandemic, which has now moved to monthly. And it has been extremely informational and really helped providers like me who remained open to pivot based on the information shared by from Mayor Bowser and of course, former Director Nesbitt. I know we're moving from the pandemic, but I want to thank all of those folks for helping us survive the last 3 years. I know we're moving beyond COVID, but I also want to thank them for continuing those meetings, and they have moved them to monthly, and I hope they continue to do so or move it to quarterly because the information shared is very helpful. MBI remained fully operational throughout the 3 years of the pandemic, but it was not without its costs. Many of our staff resigned, opting for full virtual position or less risky positions. And we are still grappling with and recovering from the workforce shortage, not uncommon for many of my colleagues that you have heard throughout this testimony. I want to thank Director Turnage as well as Bird for supporting the retention of many of our direct staff and for the enhancement in supporting the living wage for many of our personal care aides and direct care professionals. And we hope that it continues and it's not a one-time thing. I am asking them to also provide automatic cost of living adjustment for all of the Medicaid rates, including behavioral health, to have providers like MBI to keep up with increased cost in salaries and inflation. The last rate study for DBH, for example, was completed in 2016. I'm grateful for the little bit of over 6% of inflation rate that DHCF has provided to the DBH network this past year. However, it has not kept up with inflation and the cost of living. It leaves us with a gap of 17% inflation rate. The salaries for clinicians alone have gone up by 25%. And we obviously need them to continue to supervise and provide quality services. So we recommend that the rate study can take those things into consideration and hopefully provide us a result of that rate study and the rate increase within the next 90 days, if possible. The DBH network is also being transitioned to the MCO. We are only 6 months away from that transition because it's supposed to happen by October 23, and there are still a lot of unanswered questions. We are asking support from the Bowser administration and the council to let us know what services will be continued and to ensure that we get paid timely once that transition occurs. We are currently being paid weekly, and we want those payments to be no less at a maximum within 14 days in order for the network to continue to survive. I am a member of the DC Medicaid Advisory Committee, and I chair the subcommittee on health system redesign. I want to thank all of the district for continuing to look at how to bring services into Medicaid. And several has been done, that is in my testimony. And I also want to make sure that those local dollars are invested within the human services. I know I'm out of my time, I'm almost done. MBI is committed to providing excellent district services and ready to continue to work with DHCF and the MCOs to continue to provide quality care to the district residents. Thank you, Chair Anderson, Councilman Parker, for all of your work. And I am open to any questions. Thank you.
Thank you. Claudia?
Thank you, Chairperson Henderson, and I apologize for my voice and appearance. I am under the weather today. And also let me thank members of the Committee on Health for the opportunity to testify regarding Mayor Bowser's proposed FY24 budget for the Department of Healthcare Finance. I'm here today as convener of the DC Coalition on Long-Term Care, which, as you know, brings together consumers and advocates, providers, provider associations, and organized labor to improve access to high-quality care for district seniors and people with disabilities. As we have seen in the budget presentations from the Department of Healthcare Finance and the data they have shared, DHCF, we have seen significant enrollment growth in Medicaid and the DC Healthcare Alliance during the COVID-19 pandemic. Today, DHCF is responsible for funding the healthcare costs of nearly half, 48% of the district's population. Notably, in the Medicaid population, the fastest growing segments of the population are the elderly. According to DHCF, between FY 2011 and FY 2022, while the overall Medicaid enrollment growth was 43%, the growth rate for beneficiaries between ages 60 and 85 was 111%, while the oldest those over age 81, grew by 28%. While aged and disabled individuals only account for about 20% of Medicaid enrollment, they are most costly, representing 56% of total Medicaid spending. In reviewing the proposed budget against this backdrop of a growing population of older adults with high cost needs, several issues of concern come to the forefront. First, provider payment rates, and I think you've heard a number of other witnesses testify regarding these points. For the past 3 years, several classes of providers received enhanced rates to address the increased costs during the pandemic. These rates ranged as much as 15 and 20% above normal rates. We are pleased that DHCF has agreed to maintain these enhanced rates for assisted living providers until a new rate methodology can be developed that reflects true costs. However, other providers, including ICF, intermediate care facilities for individuals with developmental disabilities, nursing facilities, home health, and personal care assistance providers will see their rates revert to pre-pandemic levels. As noted in the chart below, the timetable for these rate reductions varies depending on the authority that was used to authorize them. However, when they hit, they will have a significant impact on the ability of these providers to meet current operating costs and most especially their increased labor costs. Second, the direct care workforce, which you've heard me testify about on several occasions. The proposed budget reflects that DHCF is implementing the Direct Support Professional Payment Rate Act of 2022, which Council passed last year. DHCF is using a portion of the nearly $99 million in ARPA funds to incrementally raise the average wage of direct care workers to 117.6% of the living wage by January 2025. As a result of this initiative, last month, Medicaid-funded home and community-based service providers received a supplemental payment, and with that are directed to maintain an average wage of $18.15 an hour for their workers effective January 1 of this year. So it's retroactive. Critically important to understand is that this average wage is only 10% above the current minimum wage and is only 65 cents an hour above the advertised starting salary of a target cashier. And I have attached a screenshot, which I will provide for you in my written testimony. Our coalition has consistently and persistently stated that such small incremental increases in the average wage of these direct care workers is insufficient to attract and retain the number of workers needed to meet the growing demand and need for direct care workers across the spectrum of our healthcare system. As PHI International's researchers have concluded, DC wages for direct care workers fall significantly short of the median wage for all other occupations with similar or even lower entry-level requirements by over $5 an hour. DHCF's response, which was shared in the agency's budget briefing a couple of weeks ago, is that DC pays direct care workers more than Maryland and Virginia. That is true, but the wage differential between DC and the surrounding jurisdictions is not driving more job seekers to become direct care workers or to come to DC for work. In fact, Maryland and Virginia are also facing a severe shortage of direct care workers. This is because, like DC, the wage rates for these workers are too low. And like workers in the district, Maryland and Virginians can make more money in other jobs that are less demanding, less stressful, and require less skill and training. As we've testified previously, raising the wage to 110% of the minimum wage this year and an average of 117.6% next year does not adequately compensate direct care workers for the difficult and essential job that they do and is insufficient to attract thousands of workers needed in the field. Further, when coupled with the provider rate reductions of 15 and 20% that eliminate reimbursement for overtime and staffing agencies, we anticipate that many more seniors and people with disabilities will be going without care. In my written testimony, I see I'm out of time. I do talk about a personal needs allowance, which I've testified about quickly. I'll wrap up. We did note that the mayor included $744,600 as an increase in the P&A. And in trying to find that money in the budget, it turns out it is in the Department of Disability Services and apparently is designed to raise the P&A to $150, but only for individuals with developmental disabilities. So one of our questions is we are unclear why this amount was chosen. And secondly, why this is only for a very small segment or a particular segment of the long-term care population that would benefit from an increased P&A. I will stop there and I'm happy to answer any questions. Thank you.
Thank you. Dean?
Hi, good morning, Chair Henderson and Councilmember Parker. My name is Dean Brenner. I'm a DC resident who's a volunteer. I'm testifying on behalf of the 10,000 DC residents living with Alzheimer's and the over 14,000 family members struggling to take care of them. For reasons that scientists just can't explain, Alzheimer's disproportionately affects women, African Americans, and Hispanics, and the monetary cost of Alzheimer's is astronomical, $126 million in DC Medicaid costs alone in 2020. In many cases, DC residents who are unpaid family caregivers struggling to take care of a relative with Alzheimer's or another form of dementia rely upon home health care aides whose pay is funded under DC's Home and Community-Based Services waiver in the Medicaid program. These home health care aides perform absolutely essential services, often on a 24/7 basis, in one of the most difficult jobs imaginable. It's not surprising at all that we have a shortage of home health care aides, just given how hard the job is. But that's not the only reason, or even the main reason why we have the shortage. These aides are woefully underpaid. The Alzheimer's Association estimates we will need a 25% increase in home health care aides by 2030, just to keep up with the projected needs of so many DC residents and the unfortunate growth of Alzheimer's. That's why the council passed the Direct Support Professional Payment Rate Act of 2021, a law that promised on average to pay them the greater of either 117.6% of the DC minimum wage or 117.6% of the DC living wage. Just the history here is very important. In last year's budget, the council didn't spend a nickel, no local funds to implement their 2021 law. Instead, in the financial plan, DHCF stated that although they weren't required to do so by law, they would ensure that by FY 2025, the provisions of the 2021 law would be fully implemented via a 3-year phased-in plan. Under the plan in FY 23, DHCF would solely spend ARPA federal funds. In FY 24, they would spend 50%. They'd fund 50% of the increase from ARPA funds and 50% from local funds. And in FY 25, when the law would be fully implemented, the final costs would come entirely from local funds. I've never seen this where someone's promised by law a raise, and even 4 years later, it's uncertain that they're going to get it. So it's, again, not surprising that under those circumstances, we have this dire shortage. Now, I've heard the testimony from Ian Paragol and from Claudia Schlossberg, but I do have to say, and I heard Jenny Reed answer a question about this at the council briefing, but I actually don't understand the FY24 budget proposed by Mayor Bowser and the supporting materials don't say a word about this issue. It doesn't say whether DHCF will use ARPA and local funds to increase pay for direct care workers consistent with last year's financial plan. And it does not say there in the current financial plan, it doesn't say that next year there will be local funds to fully implement the law. So it's absolutely essential that the funds promised in the FY23 financial plan, which again, DHCF says isn't required by law, but that is 14 million from ARPA funds, 14 million from local funds, be included in the FY24 budget, at least to cover this 3-year phase-in. But that funding is not nearly enough to pay these workers fairly and to stem the shortage. But of course, without that funding, we're just going backwards. I realize how many needs compete for every dollar in the DC budget. I heard compelling testimony from Children's Hospital and others. But in a budget of $19 billion, it just would be unconscionable to turn our backs on these essential workers who were promised a raise unanimously by the council in 2021. And now we're saying, well, maybe it'll be funded in 2024. The district needs to pay these workers $24 an hour, both because we'll never attract enough workers without doing so, and because it's fundamentally fair. Thank you very much for hearing the concerns of the DC Alzheimer's community on this important issue, and I'd be happy to answer any questions.
Thank you, Dean, and thank you to this panel of witnesses. I do have a few questions. Marie, I wanted to ask you about something in your testimony. You said, at this point, we still don't know what services will be continued in terms of the transition. What did you mean by that? What services will be continued?
We know that for behavioral health, we are moving from currently the services from DBH to the managed care organization. As of today, we have not received any affirmative information whether all of the current services for DBH will be adopted and continued by the MCOs, if the MCOs are going to put in place a different continuum of care. That particular information, we have not received any correspondence in writing from DHCF or from DBH regarding what the system will look like once we transition from the MCOs. Okay. We've heard information, but we have not received anything.
Okay. And you also haven't heard in terms of payment, because I think you mentioned you're now paying once a week, but I imagine that will not be the case going forward.
That's correct. And what we're asking is that if we send our claims weekly, that the MCOs at a maximum pay us at least twice a month so that we can continue to keep the system operating. And I think that if we are looking at reimbursement monthly and sometimes up to 60 days with some agencies, it would really provide some adverse impact to the network, who often have to meet payrolls and pay folks on a regular basis. So I think that that would be a real challenge and can have a devastating impact on the network.
Yeah, I have to say, I'm a little concerned that you're saying that you haven't heard anything yet, given even when we asked both DBH, Healthcare Finance about this during performance oversight, they explained that communications have already begun, planning have already begun, they meet weekly, and they're pushing out information as they have it, as they set up the rules of engagement. But you're saying that's not the case.
We have received information from the HCF and from DBH, but we have not received any formal communication regarding what the network would look like. And that's what I'm asking for.
Got it. Okay. Thank you for that clarification. And if we can't get an answer from Healthcare Finance today, Dr. Bazaran and DBH will be before the committee tomorrow. So we can follow.
And Chairperson Henderson, and as you know, if it's not in writing, it doesn't exist.
No, I know. Yes. We cannot operate systems such as this on good feelings. And you know, like friendship shakes. I totally understand. You want documentation so that we can verify and everybody sort of be on the same page. So nothing that you're asking for is out of the ordinary, I would say. So thank you for being here. Ms. Schlossberg, thank you for being here, but also for, you know, answering our random questions in between hearings. I would want to ask about the P&A. So you said, how did we pick this particular group of individuals? And my understanding is because this was the particular group of individuals that had not yet reached 100. So they were still at 70, 50.
Actually, actually, it's unclear. So my understanding, and it wasn't, I didn't hear this directly, but my understanding is from someone else who reached out to find out what this money was for, that it is for individuals with developmental disabilities in ICFs, in intermediate care facilities, and those who are in residential habilitation programs. So it's just an odd sort of way to target a personal needs allowance, since it does include both institutional and community-based residents, but it is only for people with developmental disabilities. Now, I could be wrong about that, and perhaps it's an area where you could get a better answer. That's what I was told.
I think we have some questions for that for the director, because in the materials that was sent to us, it wasn't necessarily clear about that, but also to knowing what we've heard over the last couple of months around, I guess, when you sort of tier independence, right? For the most independent groups who are in assisted living facilities, but who might want to go out to eat to dinner or go see a movie or, I don't know, buy some clothes, that the $100 is truly limiting.
Yes.
In comparison to other facilities who might cover toiletries, medications, and some of these other things 100%. So,
yeah, it's also a barrier in the sense that homeless individuals or people coming out of the permanent supported housing system who might need assisted living are really balking when they find out that they can only keep $100 of their own income, because that's not the situation when they're in a permanent supported housing situation.
Right. Okay. I'm over my time. Councilmember Parker.
Yes, Dr. is back. I hope I got that right. I wanted to circle back on the transition and the concerns that you raised. Something that I've heard from some other providers is around data management and concerns where some systems are sunsetting. In particular, I believe it is the data Wix system, and a question that many have whether or not it's possible to delay that sunset. Can you just speak to in addition to the questions you have around the MCO transition, any concerns you have around data management and maybe even DataWix in particular.
Actually, I may be I may differ from some of my colleagues. I'm happy DataWix is sunsetting.
No, that's helpful. And so I'm just trying to get a sense of where different people are.
I do think that it's a challenging system to really operate our SUD programs. And however, I do know that allowing some funding for those who rely on that system that the district was paying for to help providers move to a new system that they now have to incur the costs would be very helpful.
Okay, that is helpful. And then you also talked about how rate increases haven't kept up with costs. That is something that we've heard repeatedly, and it's a concern. The salaries that you've talked about increasing, I believe you said up to 25%. Can you just speak to, at the current rates, what impact that might have on you as a provider in the short term, but also in the long term? If you can give more numbers associated with that, if there's any cuts that you will have to make.
So, for example, Councilman Parker, we used to be able to hire a LICSW for the high 70s, and now they're commending 100,000. 90, 100. We are seeing, because of the telehealth, we're competing sometimes nationally for the people that are licensed in the district. And the district, and I know you've heard a lot of testimony around our licensing process. I know that there's some discussions around some reform of that. That also creates some barriers for folks who are master's level people to become licensed, which also contributes to the workforce shortage. So I think the rate, because they have not kept up, really makes it hard for providers like myself and my colleagues to be able to afford those new salaries that went from high 70s to 100 now.
No, that is helpful. And then one more follow up, and then Ms. Schlossberg, I'm going to ask you a similar question. If you had a magic wand and you could name the rate that would allow you to remain competitive, where should we be?
So we have, the position that we have is that the hourly rate should be $24 an hour. And that's based on looking at the Massachusetts Institute of Technology real living wage for a person living in the district, as well as the research done by PHI International. And we do have a witness from PHI International who's on, I think, the next panel, or perhaps the panel after that, who can speak to that.
I guess the rate, if you could just speak to what
I'm
would
sorry,
allow you to.
You broke up. It was hard. I didn't.
Yeah, I was asking a similar question of Dr. Marilis Black, just around rates and what would allow you to remain competitive.
I think that if the rates catches up with the inflation, right now we still have a 17% gap in the rates. And I agree with Claudia Schlossberg in regards to the rate of the direct care professionals. $24 an hour would go a long way to help us to recruit direct support professionals and PCAs, of which MBI also provide those services.
Okay, thank you. I'm going to use my remaining time to thank the rest of you all for sharing. And Mr. Eubanks, I really appreciated your moving testimony and the value of those that are providing care to so many. So thank you all.
Thank you.
Thank you. Thank you.
Thank you to all of the witnesses. That concludes this particular portion. As I sort of telegraphed before, we're going to take a 10-minute break, and then we're going to come back and we will do the public witnesses for DMHHS. So Ashley, if you set 10 minutes on the clock, and we'll be back. Thank you. And we're back. Thank you all for your patience. So we'll move on to the public witnesses for the Office of the Deputy Mayor for Health and Human Services. Once again, for folks who are joining us, you'll have to affirmatively accept our invitation to join as a panelist. But I'll call the first 8, Fernanda Ruiz, Felix Hernandez, Ishan Haru, Beverly Jackson, Robert Warren, Reginald Black, Amy Robbins, and Jesse Ramanowitz. Okay, we're still bringing folks in, but I see Fernanda Ruiz, so why don't you go ahead and get started?
Will do. Thank you so much, Councilmember Henderson. Good morning, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Fernanda Ruiz, and I'm the Home Visiting Director at Mary Center, a member of Under 3 DC and the DC Home Visiting Council, and a district resident from Ward 4. My colleague Felix and I intended to testify as witnesses for today's hearing for the Department of Healthcare Finance, and seems our registration had a mix-up, so please bear with us, Chairwoman Henderson. I am here today to provide testimony regarding Mary Center's implementation of the Nurse Family Partnership Program and how Medicaid can be leveraged to help sustain and grow these and other evidence-based home visiting programs to better support district birthing process and their children. Mary Center was founded on ensuring access to high-quality, culturally humble health services for women and their families. Providing these services for almost 35 years, we have grown as a federal qualified health center with our capacity to provide a robust perinatal and early childhood system. That system, internal and external to Mary Center, includes understanding of a need for a continual support of diverse home visiting programs. These programs and services are designed to be participant-centered and respond to families based upon their needs. Home visiting programs are designed to support families with complex needs who are at risk of poor health outcomes due to the accumulation of risk factors they experience. Using a trauma-informed perspective, they address the parent's history of trauma and current or previous challenges related to substance abuse, behavioral health, and/or domestic violence. This skill set makes them well-positioned to support families in these extraordinarily rough times. Home visitors are trained to support families through crisis, and today they continue to be the lifelines to many of our families. NFP is a widely researched and proven evidence-based home visiting model that supports first-time mothers facing financial barriers. DC Council and DC Health made this possible in fiscal year 2022 through seed funding with a total amount of $150,000. Mary Center has secured additional $2.2 million through private foundation and NFP to pilot NFP in the district for 3 years. The community has received the NFP program, and we're happy to report that to date, we have supported 95 mothers and welcomed more than 50 healthy births to date. We hope to continue to partner with the district in offering NFP to more mothers and their children in the district. Our NFP program, as our other evidence-based programs working with perinatal participants, is working with the same DC community members served by Medicaid and DC Alliance to achieve and support improved maternal child health outcomes. In more than 40 states, NFP and other evidence-based home visiting programs are funded through a mix of both private and public dollars. At least 37 states cover evidence-based home visiting programs, including NFP through the Medicaid program, and that list is growing. Earlier today, you heard my colleague Tiffany Bukowski from the National Service Office of NFP list some of these examples. While rates and payments structures may vary on the methodology used, we know that leveraging Medicaid dollars to support evidence-based home visiting is cost-effective. For example, based upon our current NFP projected program costs, in Medicaid funding was used, the cost per family per month is $187. To sustain our current program and expand capacity for more pregnant persons in wards 7 and 8, the total local cost would be $450,000. Funding NFP and other evidence-based homeschooling programs through Medicaid is not only cost-effective, it also promotes better coordination of care and services for pregnant persons and babies who are enrolled in managed care. Thank you for the opportunity to testify today. And Chairwoman Henderson, earlier today you asked my colleague Nisa Hussein about which other programs would be impacted if Medicaid reimbursement were to be available for home visiting programs. Besides Mary Center, there's other agencies implementing currently evidence-based programming. For example, HFA, Healthy Families America, is the other model that is widely supported nationally and is currently being implemented by Community of Hope and Healthy Babies Project, as well as Mary Center. So this is just one example about how other evidence-based programs are being implemented in the city and through other agencies as well.
Thank you. Felix?
Hello. Good morning, Chairwoman Henderson and members of the Committee on Healthcare Finance. Thank you for the opportunity to speak to you all as you conduct this budget oversight hearing for the committee. I am Felix Eduardo Hernandez, and I'm the Advocacy and Fatherhood Program Manager at Mary Center, and am a member of the Home Visiting Council. I'm here to share some considerations and feedback that focus on home visiting and the budget. Specifically, I am here among all my colleagues seeking an investment of $450,000 into DHCF's budget to leverage federal Medicaid dollars to sustain home visiting programs in the district. As I'm sure you all may know, families in need will continue to look for support to meet their basic needs, and as a home visitor can attest to their dedicated work towards stabilizing and achieving their family life goals. Families seek support from home visitors to access resources that we all have a right to, should we need. However, many of our neighbors in the city have not been able to access home visitors, primarily because the care and support workforce is seeing an incredibly steep turnover rate, something that the pandemic has magnified greatly. The primary factor and driver of this trend is due to the high administrative burden coupled with a salary that does not support them or their families. We need an immediate response to increase funding streams in the direction of home visiting services, and the $450,000 investment to support Medicaid funding of home visiting services will set up a durable support to these services and the workforce. The interruptions to the services we provide to families due to low wages has a negative impact on the folks we hope to partner and support. The gaps in the workforce due to exiting home visitors forces interruptions to our services, and families ultimately has a negative impact on the efficacy of our work. Partner programs, for example, are at half capacity because hiring has been difficult. How can our programs succeed with weak short-term investments? I urge this committee to ensure the federal funds are leveraged in support of our expectant neighbors, families with children 0 to 5, and the workforce that provides early intervention and prevention services to families in need. You've heard many of my colleagues also share that not leveraging federal Medicaid dollars is a missed opportunity. I'm sure you've also heard that nearly 40 other states have already established a Medicaid billing mechanism for home visiting services. I'm trying to keep the time, I'm sorry. Just as I am confident that the mayor was able to find $750,000 for a pickleball court, I am confident that the council can find the resources to sustain and make durable home visiting program investments and provide that support to families who are navigating the journey of parenthood. This investment will only set up an infrastructure of durability and not one that will address equitable, thriving wages. Please expect DC home visiting teams and our partners to advocate on April 10th and April 11th at the budget hearing to DC Health and CFSA. The asks we'll be making regarding increases to home visiting grants managed by DC to have an increase of $1 million to ensure that thriving wages make their way into the direction of our programs. I'm at time. Thank you for your time and consideration, and I welcome any questions.
Thank you. Ashan? It's not here. Beverly Jackson? Okay. Robert Warren? Okay. Mr. Black?
Good morning. Can you hear me?
Yes, sir. Good morning.
All right. Good morning, Councilmember Henderson, members of the committee, District of Columbia residents. My name is Reginald Black. I'm a Ward 4 resident and also the Housing Advocacy Director for Serville City Ward 6 Mutual Aid and the owner of Velocity. I'm here today to support the acts of the People for Fairness Coalition, which is a grassroots group comprised of homeless and formerly homeless men and women who look to end housing instability in the District of Columbia through their outreach, advocacy, and peer mentoring, and support their call for more than $1 billion investment to end homelessness in the District of Columbia. In Washington, D.C., there may be over 100,000 people that are homeless, formerly homeless, or public housing residents, veterans, and returning citizens. Their forward progress is oftentimes stymied because of a severe lack of case managers. With regards to numbers and quality, the aforementioned groups and clients need individual case managers who can assist their clients directly to achieve growth and development in all areas of activity, economics, education, health. This is why we are demanding that the city invest, included in this $1 billion acts to end homelessness, $100 million to hire 2,000 case managers of lived experience. Unfortunately, there is one case manager for 30 clients. We're proposing that the field core of the 2,000 case manager auxiliaries be arranged in the ranks of military veterans, formerly homeless persons, returning citizens, and these individuals should be selected and trained based on their personal growth of their finances, education, and political growth, post their homelessness or incarceration. Just as U.S. Army medics are trained for 16 weeks, these auxiliary case managers will be trained in extensive medical techniques to save lives on the battlefield of ending homelessness, and allow them to individually help and fast track their clients to physical health, financial literacy, and vocational preparedness. This 2,000 grassroots auxiliary case management corps trainees and graduates would be trained and funded through at least $150 million budget, with this case manager auxiliary corps earning no less than starting salaries of $50,000 per year. We know that case management and lived experience are best used to help our people through experience. And many of us, we specialize and study to provide the services that we never got. And I take that quote from my dear friend, rest his soul, Mr. Walden Adams, who worked with Pathways to Housing. But thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Amy?
Hi, good morning. Thank you so much for the opportunity to be with you today. My name is Amy Robbins, and I'm the Director of Advocacy at PHI. We are a New York-based national nonprofit that works to transform elder care and disability services by promoting direct care jobs as the foundation of quality care. Like Fernanda, my comments are relevant to the Department of Healthcare Finance, so I apologize for being a little out of order on the witness list. I have provided detailed written testimony for your consideration, and in the time that I have this morning, I'd like to just highlight a few key points. As you've heard from several other witnesses, the district has a direct care workforce crisis. More than 14,000 direct care workers assist older adults and people with disabilities in the district every single day. The vast majority are providing care in home and community-based settings. This sector will add over 3,000 new jobs in the next decade. When accounting for positions that will become vacant as existing workers leave this workforce or exit the labor force altogether, nearly 24,000 total job openings will need to be filled by 2030. Home care agency providers and individual consumers are already experiencing high rates of turnover and struggling to recruit and retain workers. Without action, this problem will get worse. Second, The crisis is really driven by poor job quality as a result of low pay in the sector relative to the high cost of living in DC. 31% of this workforce live below 200% of the federal poverty level. 33% are housing cost burden. Nearly 75% of the home care workforce access some form of public assistance in order to make ends meet. And just over 1 in 4 hold employer or union-sponsored healthcare coverage. As Claudia noted earlier, our research shows that direct care wages in the district are not competitive with other occupations with similar or even lower entry-level requirements, including retail sales, housekeeping, warehouse workers. In fact, the district ranks last in the country for wage competitiveness, with a $5 an hour wage differential between the median wage for direct care and the median wage for competitive occupations. Maryland and Virginia are unlikely to contribute to a solution, while the district's median wage for home care is higher than in either of those states. It is not higher than the median wage for competitive occupations in those states. The lack of transferability of direct care worker credentials across state lines further impacts this. This means that workers in those states have more accessible employment options for greater pay closer to home. Finally, investing in home care and direct care offers broad benefits. A living wage could lift existing workers out of poverty and financial precarity, while also helping to address the structural intergenerational inequities that impact the women, people of color, and immigrants comprising this workforce. Reducing the percent of workers in the district who rely on public assistance by raising wages not only enables the upward mobility of those workers and their families, but it also saves the district money that can be used for other investments. Higher wages are essential to making these jobs more attractive to new job seekers, which could help providers see a reduction in the high cost of recruiting new workers, managing turnover, and paying contract staff, and instead enabling them to spend more on job quality and care quality. A more stable and sufficient workforce would help overcome service gaps and ensure continuity and quality of care for consumers. Finally, investment in this workforce could stimulate consumer spending on food, housing, healthcare, transportation, personal items, and other necessities, helping to generate new jobs in other sectors and bringing tremendous benefits to local economies. While the financial constraints on the district are notable, the direct care workforce deserves an investment that improves their financial security and stabilizes this workforce at a critical time. We urge the district to help create a robust care infrastructure that will meet the needs of older adults and people with disabilities for years to come. One significant step forward would be amending the DC Living Wage Act to establish a living minimum wage of $24 an hour for these vital workers. Thank you. I welcome any questions.
Thank you, Amy. Jesse?
Good almost afternoon, Council Chairperson Henderson and members of the committee. My name is Jesse Rabinowitz, and I am a proud Ward 1 voter, and I work at Miriam's Kitchen, where we work to end chronic homelessness. Miriam's Kitchen is one of DC's 3 coordinated street outreach teams. Our amazing outreach workers cover 33 square miles of DC and see firsthand that both housing ends homelessness and that evicting encampments harms our clients. My testimony today is informed by in-depth conversation with our outreach team, people's lived experience of homelessness, myself witnessing more encampment evictions than I can remember, and my year as a homeless street outreach worker social work intern. Before I dive in, I do want to recognize how great it is that DMHHS and the mayor's budget funded significant reductions in medical debt. Medical debt is a huge driver of homelessness, and we see this as a big step forward. As we've made clear, the Bowser administration's response to homeless encampments, which can be characterized as eviction for all and shelter for some, is harmful. Continued evictions mirror the mayor's proposed budget, and that they both prevent DC from meeting our shared goal of ending homelessness. I'm not going to relitigate this, since I and many other local and national experts, people with lived experience of homelessness, and members of the council have made our position very clear. I will say, however, that it is alarming that the council allows DC's criminalization and harassment of our unhoused neighbors to continue unabated. Since 2016, neither the council nor the public has been privy to spending associated with DMHHS's approach to encampments, despite continual commitments to the council to release this information. A major role of the council is to serve as a check and balance on the mayoral administration. By continuing to allow DMHHS to obfuscate and avoid transparent cost data sharing, the council is not meeting this obligation. It's often said that encampment evictions involve many funding streams and therefore are difficult to track. Why then was DMHHS able to share a public cost document attached to my written testimony, which showed agency costs, including DHS, MPD, DDOT, DBH, and DMHHS, and detailed over $170,000 in spending to clear encampments between 2015 and 2016. Since this data was released, the pace of encampment evictions has dramatically increased. Encampments are often evicted weekly, and at least 4 have been evicted this month. How much does that cost? The council has a responsibility to find out. DMHHS has stated that encampment evictions use existing government and nonprofit staffing and that there's no additional cost. Is there not a cost when MPD harasses people instead of addressing violent crime? Is there not a cost when DHS must devote significant resources to encampments instead of implementing housing vouchers? Is there nothing better for DBH or DOH to do with their time than evict people just trying to survive? Is this the best use of DDOT's time and resources amid a rise in traffic violence? What resources from DPW are being used and to what cost? Mayor's budget as it stands jeopardizes the progress the DC has made towards ending chronic homelessness. She insists the budgets are tight. This must compel the council to determine if evicting encampments is the best and highest use of DC's scarce funds. This cannot be done without knowing what and how many resources DC, under the direction of DMHHS, uses to evict encampments. Aside from the huge financial costs, there are other costs associated with encampment evictions. There is certainly a cost to outreach workers who must pivot from getting folks housed and instead reducing the harm and trauma caused by continual displacement. And to be sure, there is an extreme cost, financial, physical, and emotional, to our unhoused neighbors whose safety is being sacrificed to acquiesce to the wishes of a small yet vocal minority who want to disappear them. During the performance oversight hearing of DMHHS, we heard statistics about how well the CARES program worked. I want to add some additional information. To be clear, from the start, we supported the portion of the CARES program that got folks into housing quickly. We opposed the creation of no tent zones and encampment evictions. Moreover, we were and continue to be concerned, as DMHHS now is, about the fairness and policy implications of providing folks who live in certain encampments housing before those living in less politically volatile encampments, those living without tents, and the over 1,300 people living in shelter. However, we must be honest that the numbers presented do not represent the entirety of encampment residents, as many residents were not included in the by name list. Miriam's Kitchen began working on the CARES pilot program in September 2021. Today, a year and a half later, 7 out of 50 clients are in permanent supportive housing. 7 out of 50. Many of the others are in housing with limited wraparound services, but this is not permanent supportive housing. Many are considering leaving their housing due to the valid uncertainty and the longevity of this less than transparent housing intervention. In fact, we have removed one of our outreach workers who is now providing wraparound case management services in lieu of PSH, meaning that we have one fewer person conducting homelessness street outreach. DC has a coordinated entry system and the vouchers needed to markedly reduce homelessness. We must focus our energy there not on continued displacement. DC's approach to encampments goes from 0 to 100 without any attempt at mediation. If the concern is human waste, why did the mayor's budget zero out funding to create public restrooms? If the concern is drug use, why does the mayor's budget not include 24-hour harm reduction centers? If the concern is moving people into housing, why does the mayor's budget not fund more PSH? And if the goal is preventing homelessness, why does the mayor's budget gut ERAPT and Project Reconnect? We need to address the root causes of encampments, the lack of housing, and not be content to focus on displacement. Thank you for the opportunity to testify, and I look forward to answering any questions.
Thanks, Jesse. We also promoted Donica Hawkins. I know, Jesse, you intended to testify in concert. Donica?
Hi, yes, thank you for allowing me to testify today. So my name is Danica Hawkins, and I'm a Ward 4 voter. I've worked in homeless street outreach for over 5 years, but I am here testifying in my individual capacity. So we have seen the harm and displacement caused by high-profile evictions. So these full cleanup engagements like McPherson Square, NOMA, New Jersey and O. But what we're not seeing is DC's routine and often twice weekly evictions of smaller encampments. And these occur far from the public eye and with even less scrutiny and accountability. I have seen a marked and troubling increase in immediate dispositions. They follow their own destructive protocol. So rather than the mandated 2 weeks notice and regular justifications that are used for large-scale evictions, immediate dispositions occur when an encampment is deemed a health and safety hazard. Once this decision is made by DMHHS, they often allow less than 24 hours notice before destroying a person's home and all of their belongings. And we all want our community to be safe, but what constitutes a health and safety hazard has been left undefined by DMHHS. And based on recent actions, this lack of definition is very much intentional. What is the difference here between a hazard and an inconvenience? So for instance, the week of March 13, there were 4 immediate dispositions declared. So that's 4 encampments that were raised simply because they were in DPR parks. Their very presence in the park was considered adequate justification for a hazard to be declared. So whose health and safety is really being risked? Residents and service providers are given at most 48 hours notice for immediate dispositions. So that leaves outreach workers and unhoused residents to completely scramble. And there's a disconnect that's created when a resident is displaced, a disconnect from home, community, service providers, that's medical, mental health, housing, and otherwise. How can someone put their trust in the very people who are ripping away one of their few sources of security? Not only is it difficult for outreach workers to physically locate individuals, but the trauma displacement evokes can be irreversible. And let's be clear, to be robbed of one's belongings, one's community, is a trauma. And we have fought full-scale cleanups because we, as a community, recognize them for the traumatic events that they are. And DMHHS has taken notice of this. But rather than step up and work closely with residents, service providers, and the rest of the community for everyone's benefit, DMHHS has simply found a quieter, more insidious means of accomplishing their goals without sparking community pushback. Immediate dispositions are nothing more than a means of allowing continued displacement of our encampments to occur under the radar. The results are the same. DC continues to evict our neighbors, destroy their belongings, and damage or even sever ties to community and service providers. Health and safety sure has a nice ring to it, but only if you're not the one being deemed a health and safety hazard. Thank you.
Thank you. And thank you to this panel of witnesses. I know we had some folks who were missing, and then also some folks who intended to be on for healthcare finance vote. Again, we appreciate your testimony. And, you know, I'd asked some questions previously around the home visiting program. Sorry, had a complete brain fart there. Jesse, I wanted to ask, to your knowledge, if we've made, whether it be DMHHS or DHS, any progress towards increasing the number of case managers to sort of clear the backlog that we currently have?
I think so. We're hearing from DHS that they expect that all of the FY22 and 23 vouchers to be matched by the end of fiscal year 23, which is great. I will take this as an opportunity to note that means that no one will move or be matched into PSH vouchers in FY24 unless the council acts. We are hearing today some troubling rumor mills that DHS is phasing or getting rid of the signing and retention bonuses that we really saw help hire staff. So I am concerned about how that will impact our system. And then we continue to see long delays in people getting matched to a voucher and working through the DCHA process.
Okay. That's the thing, is sort of the multiple steps. I have been working with Director Zeilinger. We had a meeting, and then we had an idea, and I emailed Director Zeilinger and said, hey, can we talk about this? Whereas we have some organizations who have direct impact and already relationships and care with folks who might be unhoused. And they have social workers on staff and their own version of case managers, but obviously they're not like pathways or things like that. But can those individuals serve as a proxy to help get folks through the housing lease process? And Director Zeilinger said, yeah, we could totally do that. And she sort of saying, like, are there more organizations who could be. So I'm sort of trying to think outside of the box of like who already exists within the ecosystem that can help someone go through the housing process without having to sort of wait on the case manager.
Absolutely.
I don't know if you had any.
Well,
Yeah.
to see if Reggie had thoughts. I mean, I really agree with his idea of hiring people with lived experience with homelessness. I don't know if Reggie, you want to expand on that at all?
Yeah, definitely groups like People for Fairness, some of the mutual aid groups have those direct connections. And for the most part, we want to try to put in people who have that lived experience to help liaise and to help with some of these bottlenecks with the housing searches, with walking through the DCHA process, with walking through the matching process. These things are what groups like People for Fairness and some mutual aid groups are able to do. And also through the Interagency Council on Homelessness, its consumer engagement work group are also places where people of lived experience can get this kind of training and be able to assist with that. Also the Youth Action Board. So we want to make sure that we champion people who know what case management services are needed and have the direct experience to say, okay, these are the services we didn't get, so this is how we're going to provide service. This is why I go back to that quote from Walden. He would say to us, I give the case management that I didn't get. And that's the same way that I approach my advocacy and working with people. I give them the service I didn't get.
Yeah, I mean, I think that begs the overall question of, do we have qualification requirements from a credential standpoint for some of these positions that don't need to be? So for instance, do you need to be a licensed clinical social worker in order to perform some of these functions? I don't think so, but for whatever reason, that's where we are currently. Danica, sorry. I don't know if you want to jump in on this conversation. I have last few seconds here.
Yeah, I think my particular organization has really opened up and lowered some of those qualifications and definitely tried to hire more peers, and it's been highly effective. We have an amazing team right now. As for, we simply need more case managers, lived experience and otherwise. We have outreach doing the job of housing case managers, and we're simply not trained for that, and it's a disservice to our clients.
Yeah. Mr. Black, I appreciate your testimony this week and then also last week as well. Although I have to say, in the realities of where we are in our budget process, the price tag of your proposal is such that we ain't got it at the moment, or at least I don't have it within the cluster of the health agencies of, I think it's 100 million or so. But thank you all so much for your testimony. Let me see if Councilmember Parker, can you just hang on for a second? Let me see if Councilmember Parker has any questions. Is he here? Councilmember Parker, if you're talking, you're on mute. Okay, he might have stepped away for a call. But thank you all so much for your testimony, and we'll go on to the next panel. Thank you.
Thank you.
Okay, I will call the next 8. Reagan Dunham, Newton Lennon, Hillary Kaser, Janelle Baldwin, Emily Carnival, Michaela Friedman, Clay George. Oh, sorry, Gregory. And Andrea Jones. I'm actually gonna keep going and just call everybody else since there's only 2 people.
Newton Lennon here.
So Jeff Gilbert and Carla Reed-Witt as well. Okay, before folks get started, I just want to also telegraph where we're going to go, just so everyone has some expectation setting. So once we finish with this panel, we'll take a 30-minute break, and then we'll have the government witnesses who will be on to testify. That gives them time for their teams to get over to the Wilson Building, and also gives us a little bit of time to eat before we head into that. So I just want folks to be prepared for that break. Okay, Reagan. Okay, no, Reagan. Okay, Newton, I did see you.
Yes, Newton Lennon here.
There you go. You can go ahead and turn, if you want to turn on your camera, but you can present your testimony.
Take my camera. Council member, Chairman Henderson, my name is Newton Lennon, CFO for Newland Early Childhood School Readiness Center. We are a child care center that is operating, and my task here today is to talk about or to encourage the continuation of the healthcare for our child care services that we provide. As a child care provider and a small business, our funds are limited, and thus we cannot easily provide healthcare for our child care workers. Now, our funds, that leaves us really further behind the curve in order to help to provide for our children that are in the district. The assistance that is given through DC Link provides my staff and their family that cushion that they can progress and move forward in terms of how they cater for their families and for all their loved ones. As you know, a healthy workforce is a more productive workforce. Productivity through attendance. Without healthcare, they are home sick most of the time and not able to provide for themselves and take care of themselves. A healthy workforce also is a more vibrant workforce, and a healthy workforce also provides less turnover, which we need in our child care service here in the district. I want to encourage that we continue to provide that financing that will help our teaching profession. And this too will guide and help those who are on the outside of the society to come into the profession that we have. Because with families that are healthy, children are healthier. I'm sure Dr. Newman, as a CEO for Children's Hospital, will see less of our children, and therefore will give more space to those who need more health care. My task, as I said, is to encourage the funding of this program so that we can move forward in educating our infants and toddlers and preparing them for the society in which we live so that they can be more productive and provide for their families and themselves. Thank you for listening to me, and I hope we will continue this funding.
Thank you. Hillary? Hillary, if you're speaking, you're on mute. There you are.
There we are. Sorry about that. Just struggling with the technology. Thank you, Council Member. It's an honor to be here today. I'm here talking. My name is Hillary Caxer, and I'm talking about the diagnosis that was defined by the American Psychiatric Association in the 2013 edition of the DSM-5 behavioral health disorders. They defined it as hoarding disorder. That's HOARDING. It's something that is surrounded with shame and stigma, which we know are blockers to getting assistance. So I will refer to it by the acronym HD. Sometimes I will say collecting behavior, hoarding and cluttering. There was a Washington Post article, and as I say, I'm struggling with my technology here with apologies, but the article, it was called Hoarding is a Serious Disorder and It's Only Getting Worse. That was in the Washington Post, and they gave this estimate of 6%, which is a clinical estimate of numbers of people living with this disorder. So that's where the figure of 40,000 people come from. In 2006, the Metropolitan Washington Council of Governments put out a paper called Hoarding, a Dangerous Secret. Councilmember Gray on this committee when he was mayor, fortunately, Deputy Mayor Turnage, I don't know if I'm supposed to be addressing you according to the rules, but council members, if you can, Deputy Mayor Turnage is a successor in the office that was created by Vince Gray during his term as mayor, and they were working on this. And I can appreciate my sense, I don't even remember the name of the person who came on after BB Otero, who was the first deputy mayor for Health and Human Services, and they were giving a lot of attention to this issue. But unfortunately, it's a very thorny issue. And my sense was that when Mayor Bowser came in, what I would have done in her position is, if I had seen my predecessor struggle with something like this, I would have looked for things where I could get results for my constituents quickly and efficaciously. Now, I heard testimony about people working in the field, and the DBH community support workers are still working remote, but they were at least in the home. You won't know necessarily that a person has this condition if you don't get past their front door. Deputy Mayor or Council Member, Committee on Health Chair Henderson, can you please draw to the attention of the Deputy Mayor for Health and Human Services that this is a serious service gap and unmet need? You also mentioned about price tag. For approximately $25,000 to $30,000, we could get a co-author on a clinical paper about this condition to talk to us about peer response teams. And I would be grateful for any questions. Thank you so much. Glad I can see the clock.
Thank you. Janelle Baldwin. Okay, I don't think Janelle is here. Emily.
Good afternoon, Chairperson Henderson and members of the committee. My name is Emily Carnival and I live in 16th Street Heights in Ward 4. I'm a community organizer with Jews United for Justice, a community of thousands of Jews and allies committed to advancing social, racial, and economic justice in DC. JUFJ is a member of the Way Home campaign. My testimony today will focus on reallocating the funding currently being used to evict our unhoused neighbors to instead fund sustainable, humane housing solutions. As a neighbor and resident of the district, I'm deeply concerned for my unhoused neighbors who are being overlooked by the mayor's proposed fiscal year 2024 budget, and the council has a responsibility to make this budget a moral one. Looking out for one's neighbor is one of the foundational commandments of Judaism. Whether you're Jewish or not, having safe, stable housing is a human right and should not be seen as a luxury or something that someone needs to earn. One should never be penalized for struggling in an unjust world that often puts profit over people. My Jewish values are not the only reason why I'm here today testifying before you. I also bore witness to the recent McPherson Square eviction. On February 15, 2023, Deputy Mayor of Health and Human Services, Wayne Turnage, and the National Park Service evicted unhoused neighbors living in McPherson Square. There were around 70 people living there permanently, 70 people who lost their homes that day. How is that okay? That day, I saw employees of the National Park Service, members of our government, dressed in hazmat suits, laughing and having conversations like this is normal. Maybe this is their normal, but it shouldn't be. Kicking people out of their homes should never be a norm. Instead of investing in destroying homes and lives, the DC government should invest in housing programs that can help save lives. According to WAMU reporting from March 28th, just 19 people who used to live in McPherson Square have moved into temporary housing or shelter of some kind, and only 3 more have signed leases for new apartments. That means that nearly 50 people who were evicted are still without a home today. I'm asking the committee today to provide robust oversight of the Office of the Deputy Mayor of Health and Human Services and to reallocate their funding for encampment evictions to programs that actually support our unhoused neighbors. Unfortunately, it has been unclear to us and our partners how much money is spent on encampment evictions due to the deputy mayor avoiding questions surrounding this. Chairwoman Henderson and members of the committee, JUFJ and our partners urge you to hold the Deputy Mayor of Health and Human Services accountable and find out what that number is, so we can use that money to fund programs that support our unhoused neighbors rather than harming them. As we all know, the mayor insists there is not enough money to fully fund important housing programs, such as emergency rental assistance program and housing vouchers, but any penny that is going toward encampment evictions is being grossly misspent. Thank you, Chairperson Henderson and members of the committee for listening to our concerns today. I hope you will craft a DC budget that provides support and resources for our unhoused neighbors rather than punishing and criminalizing them.
Thank you, Emily. Michaela? Michaela is here. Clay?
Good afternoon, Councilmember Henderson, Councilmember Parker, and Deputy Mayor Turnage, and all who are present. I'd just like to say hello. My name is Clay Gregory, and I am Chief Operating Officer of United Counseling and Support Services, doing business as Metalworks Behavior Health. My wife, Christine Gregory, who sits next to me, is a licensed professional counselor and serves as our CEO and is the co-founder of our agency. We live in Ward 5 near Turkey Thicket with our family. I'm also a native Washingtonian and a product of DC Public Schools. My father, Henry C. Gregory III, was pastor of Shiloh Baptist Church from 1972 to 1990 and led the church to build a $5.5 million community center named the Family Life Center in 1982. My grandfather, Henry C. Gregory Jr., and my great-grandfather, Henry I, were all men who served their communities and the communities that they lived in. Since the inception of our small agency in 2016, it has grown from a single individual practice to a health clinic that employs 45 full-time therapists, social workers, doctors, nurse practitioners, supported employment specialists, community support for professionals, administrative staff who serve vulnerable families and individuals. We provide many community support services and programs that I won't list for sake of time, but all of our programs are accredited through CARF International. Taken from CMS.gov or the Centers of Medicare and Medicaid Services website from Section 1865A1 of the Social Security Act, permits providers and suppliers accredited by an approved national accreditation organization to be exempt from routine surveys by state survey agencies to determine compliance with Medicaid conditions. Because we have been awarded our second 3-year accreditation through CARF, we are given quote unquote deemed status by the CMS, which means that we not only meet but exceed expectations for a particular area of expertise. Our area of expertise are, and not limited to, mental health services, substance use disorder, evidence-based mental health modalities. We provide a ton of services around reentry, transitional age youth, medication management, and the list goes on and on. We not only specialize in these areas, but are required to operate in a competitive Maryland market that's required us to cultivate customer service and quality assurance practices to survive. But there's one place that we cannot serve and compete, DC. The city will not accept our application due to a moratorium on new MHRS mental health rehabilitation service providers that's been in place for 3 years and counting by the DC BHA. I know this because I've emailed to inquire 8 times in the last 36 months. When competition is limited in any economy, prices go up, companies and owners become bloated, technology and innovation goes down, customer service goes down. And with limited competition in the mental health space, wait times to find a therapist and doctor get longer. Clients get the bare minimum. Government agencies don't get the transparency necessary to assure compliance to the regs, and the entire community suffers. We have shared our circumstances with our council member, Zach Parker, and have submitted a copy of the statement to him. That being said, that's pretty much the written statement that I have. But as I live and breathe in DC and walk around, I see the need for our services, and we are looking for. We want to make sure that our statement is recorded, and we request that someone look into the lifting of the moratorium. Thank you.
Thank you,
And
Clay.
I'm around if anyone has questions. Thank you. Sorry about that.
Thank you. Andrea? I think Andrea's here. Jeff? Okay. Jeff is not here. Carla?
Okay, hello, Councilmember Henderson, Councilmember Parker, and the rest of the Health Committee. My name is Carla Reed Witt. I'm a Ward 7 resident in education, disability, and mental health, as well as a literacy policy advocate and co-founder of Decoding Dyslexia DC. I'm here today to highlight the interconnection between literacy and health. Literacy does fall under the purview of the Committee on Health, the Deputy Mayor of Health and Human Services and Medicaid, because it improves health outcomes. Funding literacy initiatives is funding solutions which improve health outcomes. Low literacy is a contributing factor to health inequities, and combating low literacy should be a part of our arsenal of weapons to vanquish it. Literacy is distinct from health literacy, which has been defined as the degree to which individuals and organizations find, understand, and use health-related information and services. Research indicates that limited language skills and low literacy skills are associated with lower educational attainment and worse health outcomes. Limited literacy is a barrier to accessing health information, becoming health literate, proper medication use, utilization of preventive services. Individuals with limited literacy face additional difficulties following medication instructions, communicating with healthcare providers, and attaining health information, all of which adversely affect health. Research has also shown a positive correlation between limited literacy skills and chronic conditions, including diabetes and cancer. Making things even more difficult for those who struggle to read, Medicaid is a complex and confusing system to navigate. Given that the city does not have complete control over the Medicaid system and its regulations, I believe that even if DC Medicaid made all possible improvement, Medicaid would still be a difficult system to navigate for beneficiaries. There are mountains of paperwork to read and filled out in different parts of the government to navigate in addition to MCOs. Success is highly dependent on one's level of literacy. What I'm saying is improving the rate of literacy proficiency in DC will improve the functioning of DC Medicaid, our health systems, and eventually decrease cost. We can do this by correcting our decades-long failure to teach DC students to read. There is so much about Medicaid that we can't change. Whether DC Medicaid beneficiaries are literate is something we can change. Literacy and health costs go hand in hand. Children who struggle to read suffer greater rates of anxiety and depression. We need funding to train more teachers in the science of reading and structured literacy, to support schools to purchase and implement structured literacy curriculums, to reduce the number of low literate middle and high school students, and to immediately put into effect the recommendations of the DC Literacy Task Force when their report is released in September. Please do not wait until the next budget cycle to fund improvements to literacy. We have about 95,000 DCPS and charter school students, 69% of whom struggle to read. A disproportionate number of these students live in Ward 7 and 8. Our kids rely on us to prepare them for the world. They have no control over how good a job we do, and we're not doing a good job. We cannot continue to send our kids out into the world knowing that our education system may very well be a contributing factor to a future in which they may be unable to fully access available health care. Literacy is an important non-medical component of the solution to our healthcare and DC Medicaid beneficiary challenges, and worthy of funding. Thank you for your time.
Thank you, Ms. Reedwit, and thank you to all of the witnesses on this panel for your testimony. Ms. Kaser, you had testified during the DBH hearing. Dr. Bazaran is before us tomorrow, but we can certainly ask some questions of Director Turnage from the perspective of his DMHHS hat around what is our strategy and or plan around hoarding. And I mentioned at that at part one of our DBH hearing that this has also come up in sort of conversation with FEMS around what happens when they get called for service. Let's say that there is a fire that breaks out. When there is that amount of things in a home, it either forces it. The fire burns much more quickly, which shortens the length of time for them to be able to respond, but also it impedes the ability of rescue workers to get into a home if there is some type of emergency to be able to get to, a resident who is in need of help. So thank you for raising this again.
Thank you.
Thank you to the others who have testified. Mr. Gregory, we inquired with DBH earlier this year around the moratorium. As you know, it has been in effect for quite some time at this point.
3 years.
Yes. Yes. And so we really haven't gotten a full answer yet of why. It's just sort of, oh, well, they can apply for, if you just wanted to do substance abuse disorder services, that's available to you. But this particular category is what they call limited moratorium, but limited to me is like 3 months, 4 months, not 3 years. Director Bazaran, as I mentioned, is before the committee tomorrow. So we can follow up with her specifically on that, but I'm happy to raise that with Deputy Mayor Turnage, although he probably will refer me to DBH. So just to let you know on that front, but thank you so much for being here. I don't have any other questions for the other witnesses, but thank you so much for your testimony. If we don't have a copy of your written statement, please make sure that you provide one for us. I'm going to turn to Councilmember Parker to see if he has any questions for this panel of witnesses.
Yes, thank you all for sharing. Emily, Carnival, and I'm seeing Jesse. I believe you're on the previous panel, but since you are here still, I'm going to take advantage of this opportunity to say there was a recommendation to reinvest money that is currently being used on encampment clearings to housing more of our unhoused neighbors. Are there specific areas you would encourage us to look for, to reallocate? Not to say that we can do that, but where should we be looking?
Thank you for the question, Councilmember. I think a few things that come to mind are permanent supportive housing. The mayor added no new funding for PSH in FY24. The mayor also slashed ERAP by 80% and Project Reconnect DC's program to prevent homelessness for single adults by 50%. We also see short-term non-congregate shelters similar to the PEP-B program is really integral to this. I'll also add that I think one of the reasons people focus on encampments is the lack of restrooms. Yet paradoxically, the mayor's budget removed all funding for the creation of public restrooms. And I think that money could be redirected from the proposed redevelopment in Farragut Square, which is at its heart a goal to displace homeless people from Farragut Square who are now living there because they were displaced from McPherson Square. So I would look at the money for that park redevelopment to see if we can fund some restrooms and ERAP as well.
Thank you. Emily, anything you would add?
I just want to lift up everything Jesse said. Great.
Okay, thank you for that. Clay, Gregory, and Christine, it's great to see you all both as neighbors, but also just really compelling testimony about the services that you could be providing. And one of the things that we hear as a committee or just hear, whether it's in the context of children or juveniles across our schools or juveniles across the city, is we need more mental health support. We need more capacity. And here we have a provider that wants to provide that capacity, but is running into a roadblock. I just want to unearth some of the things that you have been hearing, because I know you all have been in constant communication with DBH, among others. What are some of the responses you've heard, if any, when you inquire about the moratorium?
Yeah, thank you for that question. We're just told that that it's not open. And, we're never really given a specific reason why there is a moratorium on the licensure. I believe that early on when we initially applied, the reason is because there were they had just gone through an influx of bringing in new providers, and that they wanted to measure and just make sure that they had sufficient providers at that time before bringing in new providers. But since then, and since the moratorium, I am aware that there have been several providers that have closed down and closed shop. There are a few licenses that are open for us to apply. But it's almost like if we were opening up a hamburger shop and we were being told that, yes, we can sell hamburgers, but you can't sell fries and you can't sell milkshakes. You're really just damaging our ability to just be sustainable. And so, or hindering our ability to be sustainable. So
can you say more about that? So what type of license might you be able to get, and how might that impact what you're able to provide? I'm assuming that means you could provide some services, but it wouldn't be the full suite of things you currently offer in other locations.
Correct. So currently the DBH will receive applications for pretty much all services related to substance use disorder. So if you have a substance use disorder diagnosis or a need, then new providers who offer those services can support you. But what happens oftentimes is, an individual doesn't just exclusively have a substance use disorder without there being some form of a mental health co-occurring diagnosis as well. So the vast majority of individuals who do receive substance use disorder receive it from agencies that treat that as well as mental health.
So what I'm hearing you say is you could apply and perhaps provide substance abuse services, but not mental health services because of the moratorium.
Correct. And
Yes.
I think that right now there's a tremendous missed opportunity for new services that are available. There are a number of innovative therapies and treatments from biofeedback therapy and quite a few that we've invested tens of thousands of dollars into. And I'm not aware of whether or not that's being offered in the district. I believe it's not. So
yeah, I'm at time. Thank you all. Two things I would just say. It's super compelling that we have a young, vibrant Black family here that is wanting to give back to DC, a native Washingtonian that is forced to provide services in Maryland because you can't get past the moratorium here, which is a little ridiculous to me. And so as Chairwoman Henderson mentioned, we will lift that up. But secondly, it may also be something that we need to look at legislation. Hopefully it's easier than that. But I really think you made a great point and impact here today. So thank you for sharing. And thank you all for your testimony during this panel. Carla Reed-Witt, I am forever grateful for your unyielding advocacy, and I really appreciate what you had to say as well.
Thank you.
Thank you.
Thank you, Councilmember Parker. And thank you to all the public witnesses for your testimony and for being here and for adhering to your time, because that's always, it works for us. And so as I sort of telegraphed earlier, we're going to take a 30-minute break to allow us to stretch our legs, get some lunch, and be fairly well and fueled to welcome our government witnesses to the table where Deputy Mayor Turnage and his team. So we're going to set 30 minutes on the clock, and we are recessed until then. Thank you. Okay. We are back. Maybe they're hearing me. Oh, great. Now before us, we have, okay, who has their, okay, okay. I'll call up Wayne Turnage, who's at the table, Deputy Mayor for Health and Human Services and the Director of the Department of Healthcare Finance, to provide testimony. But before you begin, as customary now for this council period, I will ask you and your team, so anyone who we feel like may possibly come to the table to answer a question. So for those who are not here in person, there's a crew here. If everybody can raise their hand, the right hand, and we'll take the oath. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. Please begin, Director.
Good afternoon, Madam Chairwoman. It is a pleasure as always to sit before you to present the budget, first DMHHS and then DHCF. I know you like to get to the question and answer portion of the meetings quickly, so I will move real quick through the first presentation because we have such a small agency from a budget standpoint for DMHHS. If on slide 2, which they're showing DHCF and not DMHHS, we have like 4 core functions that typically comprise the issues that we address. For some reason, we don't have the DMHHS slides. I'll keep moving. This is pretty quick.
Are you sure? Okay.
Yeah, we have 4 functions that sort of are funded through our budget. We have a policy team that is led by Brian Harrison on my right. We have 8 friendly DC functions, Gil Cohen. We have an encampment response team that is led by Jamal Weldon, who is not here this week, but he does an amazing job. And this chart also shows the ICH, the Independent Housing Council. But they don't really report to me. They're independent. We don't give them direction. They are a think tank. And we do provide them with monetary assistance. But they have a more direct line to the city administrator. We rely on them for strategic analysis and input, but I don't direct their work. Our budget is a small budget, $2.5 million. Incorporates 13.75 FTEs. We did give up 1 FTE in the mayor's budget process. We also have funding from 2 other agencies, DHS and DHCF. DHCS pays for outreach services for residents who are experiencing homelessness, and DHCF does the same. Those services those MOUs govern $635,000 in services. Really the only forward-facing or frontline staff that we have really is the encampment team. Their work is considerable, as you well know, and they have a number of activities that they are involved in, including getting persons who are experiencing homeless DC-1 cards. They work to house residents. We do a lot of work through CARE. And then we work closely with DHS once the CARE project has ended, and they coordinate the bulk trash removal and encampment cleanups with DPW. So that sort of summarizes our budget presentation for DMHHS, and we can take questions now, or you can, if it's your desire to roll all the questions into one session, we can move into the presentation for DHCF. However you prefer us to proceed, we will do.
We'll do the DMHHS questions first.
Okay.
Just to,
Sure.
clause the line. So thank you for that. We will do 10-minute rounds. Ashley. Councilmember Parker is also here. And he'll pop up on the
Okay.
screen. Okay, so all right, let's start. At the UMC budget hearing last week, we discussed the concern about placing patients in long-term care who will not qualify to be transferred to Cedar Hill for inpatient care once it opens. How does DMHHS plan to assist UMC in placing those patients in long-term care as the hospital is closing?
Well, that is really the function of two different agencies. One, if they qualify for Medicaid long-term care, then DHCF will be intimately involved along with DHS to make sure that they have processed their eligibility and that they qualify for some non-acute beds somewhere in the city. Once a hospital closes or announces its closure, Department of Health is intimately involved in the winding down of hospital activities, and their key focus is on whether or not patients are treated appropriately as you move from one facility, as you close one facility and then potentially open a new one. It's not intuitively obvious to me why someone who needs long-term care would be at UMC and not in a long-term care facility. One of the things that we have to be attentive to is whether or not those persons who are in acute care beds in the hospital do qualify for long-term care beds. But that is there's a system of eligibility that we run through DHCF and through DHS. And we can certainly, as we get close to wind down, the board, I'm on the board at UMC, and as we get close to wind down, we will bring all of the regulatory agencies before the board to let us know, to give a presentation to us on what we should be doing, and also certainly deal with any service coordination.
All right. Before I go to the next question, they're having trouble hearing you online. So if you can move maybe the mic closer to you or adjust. There you go.
So I guess I should take the button that I had said cut online audio out. I should cut that on.
No, I think they can hear you. Are we good now? Okay. All right. At the DBH, at part one of the DBH budget oversight hearing last week, we heard from ANC 8E that they had been working with the UMC board, in theory, to discuss moving the methadone clinic that's currently on Good Hope Road to UMC. Yet when we talked to UMC CEO, Dr. Payne Borden, she said she wasn't necessarily aware of conversations moving forward on this. Have you been involved in any of these conversations, or what would you say to the residents who live around that clinic as they've been raising lots of concerns around safety and quality of life issues as a result?
The CEO, her statement puzzles me. She is very good, first of all. I wish we had her on at UMC long before now. She's excellent. But I'm a little puzzled by her, what she means that she's not been involved in the conversations. What she has been directed to do by the board, most especially Angel Jacobs, the board chair, is to do the due diligence to bring back to the board a proposal. And she can say once she presents the proposal that she either accepts or rejects the proposal, but her role will be to inform us of of all the results of her due diligence work, make a recommendation to the board if she wants it, then submit the proposal to the board for a full vote. We thought that was going to happen at least I thought it was going to happen at the February meeting. It did not. Our next meeting is this month, at the end of the month. I will certainly let, in fact, I spoke to Chairwoman Jacobs about this last week, and I asked her where we were going to have the official presentation. And she said, I thought, and she can correct me if I'm wrong, that she thought that the CEO was still working on her due diligence. She had trouble getting in touch with some people, mostly at the clinic, who were that could provide her with some of the information she needs to make a full report. But I fully anticipate that some meeting, hopefully the next meeting, if not, certainly in May, that the UMC board would take a vote on whether or not the clinic should be considered for a move to UMC's campus.
Okay. So we'll follow up on that in May. In the pre-hearing responses, to the committee, you all stated that the decision on the future of the care program is on hold while DHS is processing the existing cases of residents matched to vouchers awaiting case management. Will the DMHHS-led encampment response team still conduct closures of encampments in FY24 at the same pace of 23?
I can't speak to the same pace. There will certainly be closures, primarily because, and we have a meeting coming up with NPS where we are expected to express our position on how they should move forward with closures where they would like our assistance, and we certainly are willing to help them in whatever ways we can. That meeting is Monday with NPS, and they will give us probably an adjusted schedule for closing those areas that are federally run to future encampments. As for the encampments that are not on federal property, it is whether or not they are closed is entirely dictated by the city administrator's protocol, which is court approved, by the way. And it lays out the circumstances under which an encampment receives a cleanup or an immediate disposition. And then from those activities, whether or not we believe an encampment should be closed will come from an analysis of our encampment team and advice from our legal counsel as to whether or not we can legally close the encampment.
Okay, so the budget that you guys have for the encampment response team is pretty much the same?
Yes.
Okay. So what is the role of the two FTEs? They're called program analysts encampments employed by DMHHS through an MOU with healthcare finance. What do those folks do?
Kiana is my chief of staff. She runs the office. I have an office over at DHCF, and I try to stay out of the Wilsonville. So yeah.
Okay, well, shadow deputy mayor.
Yeah.
Good afternoon, council members. So the two folks that you're referring to, they are encampment navigators. And so we have and I think it's helpful to go over the structure of the whole team. So Jamal's the deputy chief of staff and provides oversight to the encampment response team. And then you also have an encampment coordinator, Kian Blakely. And so Kian coordinates and visits multiple sites, but then we also have two navigators. And so the navigators, we actually just had somebody join last week, Trina Robinson, and then Tony Smith. And so they have different areas that line up with the housing provider Ketchum areas, and then they provide services. And so to the DM's point, while we might not be having a closure, if there is a regular bulk engagement or if they're delivering other services, that's what the funding is tied to, but they're paid through an MOU via DHS.
Okay, so hold on. So I have in your budget the 6 FTEs for encampment outreach navigators.
So
and then there are 2 program analysts for encampments.
So the program analysts are really the navigators. And so they show up, they might show up on the Schedule A as analysts, but those are the 2 navigators.
Okay, so the 6 FTE encampment outreach navigators, it says employed in DMHHS through an MOU of DHS. So what do those folks do?
So those are the navigators that I just described. So the encampment team in total are those 2 navigators, encampment program coordinator, and then also the deputy chief of staff. But if you're referring to, and our AFO did join, and Adrian, feel free to add on to this, but if you're referring to the analyst, that might also be the ICH. What question are you looking at specifically?
That's how it's titled, program analysts encampments. But the point being is I'm asking about 8 people, and I think you've only told me about 4.
Right, which is why I think you might be also alluding to the ICH, because those are also paid via MOU with DHS.
Would they be titled under the budget as encampments though? Oh, sorry. Good afternoon. If you could introduce yourself, you could turn on your mic.
Good afternoon, council member.
Good night.
Yes, so I will look at the budget schedule and lay out for you how they are titled if you give me 1 second. So the MOUs with DHS, they're titled Outreach Services and Engagement Coordinators, Program Manager, Special Advisor. Does that answer your questions?
Yeah, I think there might be a difference between what we have in the budget books versus what you guys have there. So it might be helpful if there is some sort of crosswalk that exists that you could provide us with that, because what we are showing is that there are 8 individuals who work on encampments within DMHHS, 2 from healthcare finance and 6 from DHS.
No, that's not correct. So the budget book doesn't line up with what the Schedule A has, so we can provide you with the Schedule A where you'll be able to see the breakdown, but we don't have 8 people who are working on encampments in our office.
Okay. I'm not here to give new ones. I'm just, we gotta get an accounting for who exists. I'm over my time. But I think that would be helpful just for us to know. Let me just ask this one other question. How many FTEs in total are at DMHHS? Plus your MOU peeps?
13.75, right?
That's right.
13.75.
13.75, okay.
So there are 13.75 that are funded by DMHHS, but the total is actually 20.75 when you add the MOUs.
And that's inclusive of the ICH.
Yeah.
Includes ICH, okay. All right, I'm over my time. Councilmember Parker?
Thank you. And it is hard to hear everyone except for Deputy Mayor Turnage at this point. And so if folk could do whatever he did, that would be great. I will be repetitive. I just want to make sure I'm clear what I'm hearing. So if it's not 8 FTEs, what is the response of how many FTEs there are working on encampments?
So the total FTEs working on encampments would be 4 individuals, but then the MOU doesn't fund all those 4. The MOU only funds, with DHS funds 2 people, and then 1 other person on the encampment team is funded via DHCF.
Okay. And how much in total is spent on encampments and the proposed 24 budget compared to the 23 budget?
So I could get the comparison for you, but I think it's a little hard to do. Are you alluding to day-to-day operations? Or are you alluding to the FTE costs associated with encampments?
More of the day-to-day. And I'm thinking, like, I'm assuming you have a budget line item that may not be super clear for us. And I'm seeing you shake your head. No, you don't have a budget line item. So if you could give us a sense of what was the cost in 23 and what is the projected cost outside of just paying the FTEs for encampment clearance?
Well, the way that process works is, we basically, through coordination with sister agencies, request services that are governed by a contract, like bulk trash pickup, so we can get the cost of those contracts. But some of those services, if the cost extend beyond the contract, they are provided sort of in kind by the agencies. But we can get you all the contracts that we have that are used to purchase services from other agencies.
That would be helpful. And specifically, if there could be a sort of a crosswalk, as Councilmember Henderson requested, from 23 to the proposed 24 budget.
Sure.
Councilmember, I will add though that there is a budget line that will say the supplies in DMHSS. The supplies is inclusive of everything from printing paper into the office, but then also if there are hand warmers, for example, during hypothermia season. So we could also provide you with that breakdown, and then in addition to what the deputy mayor referred to.
Okay, thank you. In terms of encampments near Ward 5, the one nearest New Jersey and can you provide an update on that? It was closed now, what, a couple of years ago? Is there a date when we can expect that park to be reopened to the public, or is it slated to remain closed?
No, I would certainly direct you to Department of Recs. It was closed because they had scheduled a complete rehabilitation of the park. Somebody informed me 2 weeks ago that they had not started, which was a little surprising because we did close it under the assumption that it would start in the fall, the spring following the closure. So when I heard they hadn't started, I was frankly caught off guard. So we will check with Department of Recs and we'll get back with you tomorrow on, what's the day, Friday? We'll get back to you tomorrow on what the status of that park is. in terms of the scheduled rehab.
Thank you for that. And then also the highly controversial NOMA clearing a few years ago, where now there are concrete barriers. Can you give a status update there? Are the barriers to remain? Are they slated to be removed?
The that's an executive level decision. The barriers will be moved sufficient to put back in the bike racks. But I believe there is some concern about removing all of the barriers while we have a glut of vouchers that we have not been able to move into housing. That was one of the more difficult closures that we have done. And I don't think anybody wants to revisit a situation where we have to close NOMA again. And so I'm pretty certain the concern is if we remove those barriers too quickly, then we may be back there within a year contemplating closing this site for the same reasons we closed it in the first place.
Yeah. I would just say, and I don't want to eat up too much of my time, anecdotally, I walked through that area last weekend on my way walking to the mall and then back, and was with a friend who isn't really into the weeds of the politics. And they noted that the new development there with the hotel and the new restaurants, they essentially suggested like, oh, this is why they had to put these barriers here and clear folk out. And so it certainly suggests that the public sentiment, at least among some, is that those barriers are there to protect the interest of some neighbors and not others. So I'm just throwing that out there in terms of just what the sentiment is, even from someone that's not intimately involved in the politics of all of this. I want to shift gears a little bit, and I believe Councilmember Henderson wants us to focus on healthcare finance in a different round. But one of the things that we heard from residents that testified is about the moratorium that is in place here. They are a mental health provider, yet they cannot get past the limited moratorium that is in place here in the district. Do you have a sense of why this moratorium is still in place, and if there's a timeline to lift that moratorium?
I don't have a sense. I asked that specific question when I heard the question in the hearing. I don't favor the moratorium. I also don't favor CONs, but they are across the country and not going anywhere. I believe in unfettered competition, even in human services. But I have asked Director Bazran by phone, what is the purpose of that moratorium? I understand from my staff that when it was established, the understanding was that it would be only for a very short period of time. That time has long since passed. So
yes, can you share what Dr. Bazran's response was?
Well, I was looking for, I told her if she didn't text me the response, I was going to throw her under the bus in this meeting. She has not.
Dr. Bazran will be before the committee tomorrow. Councilmember Parker, Deputy Mayor.
I would be sure to ask her, and I know you mean that in jest. But it is curious to me that that is a pattern, that there doesn't seem to be a clear directive. And I just want to make sure I'm clear. Is this something that could be coming down from the mayor's office? Or do you believe this is a decision that is in-house at DBH?
I think that's a program decision. I can say that nobody in the mayor's office has communicated to me any direction about the moratorium. And I don't know if, I guess, Kiana, have they spoken to you? So I think this is as is often the case when you have large human services agencies, they make program decisions every day as would be necessary, unless you would bring their operations to a grinding halt. So this sounds like a program decision that's based on some rationale that has yet to be explained to me. But as Chairwoman Henderson said, Dr. Bazran will be available tomorrow to offer you all a fuller explanation. I say out front that unless there is a tremendously compelling reason to keep a moratorium in place, I wouldn't support it, especially in areas where I think we need more providers.
Absolutely, absolutely. And I'm glad to hear you say that. And I'm looking forward to getting more clarity. In my last minute or so, just the parameters of this budget and knowing that it's a tough budget year, we have a decrease in ERAP, we have a decrease in DHS services, no new voucher investments. So can you just speak to what is the vision or the plan to get more people into permanent housing over this next fiscal year, where a lot of contingent metrics are decreasing?
Yeah, I respectfully, I would respectfully point you to talk to Dr. Laura Zeilinger. She is an outstanding administrator for our homeless services programs. I do know from where I sit that the immediate focus is on trying to remove the backlog in vouchers where we are not aligning people with their housing choice as rapidly as we need. So the focus in the immediate is identifying the bulges in the system, finding out the underlying cause, and removing those impediments to a more expeditious matching of persons with the houses that they select. There's also a push at DCHA to improve the housing stock by addressing the units, the public housing units that are either in complete disrepair and they're not being used, or they are in such disrepair that they shouldn't be used. And so those things are the immediate focus. The long-range vision for how do you increase the number of people or decrease the rate of homelessness in the city at a time when we were faced with an enormous budget gap over the next for this next financial plan. How do you close that gap, but continue to move forward with your efforts to house people? Is a question that I would leave for Laura Zeilinger to answer, because she has her fingers on every ounce of this homeless system, and she does a great job trying to help us figure out, how we move forward when we have such constraints.
Thank you.
Thank you, Councilmember Parker. We'll do I have one more round of questions on DMHHS, and then we can switch over to, the deputy mayor then becomes director, and we'll do that presentation, and then we'll ask some questions on that. So Director, in listening to your comments to Councilmember Parker, you said you should talk to Director Zeilinger, but at Performance Oversight, you said that your office was working with DHS to work on a plan to process the backlog. What is that plan? Especially considering, I got a response last night from the city administrator's office about a list of reports that we have been looking for. I included CARE among that, and they said, essentially, we won't be releasing the CARE pilot report until we determine next steps after we get through the backlog. And so
You asked who made that response? Who gave you that response?
the city administrator.
Okay. Well,
Yeah. And so if I'm not going to get the report until we know what the next steps are, then what are the next steps or the process?
Yeah. Well, I was responding to the council member's question. What I thought his question was, what was the vision for the system in the future? And that is more a Laura Zeilinger question. If you're asking, what are we going to do to reduce the backlog? That backlog does cut across CARE and the encampment. So we do talk to DHS on a regular. We have asked for several presentations. We just got one that is very good, that sort of lays out the beginnings of their thinking about how we get through this process. I think we have another meeting coming up soon, and there's a work group also being established in response to a request from Councilmember White, Robert White, about this very issue. What are you all gonna do about these backlogs?
Right.
So those things are underway. It would be, I'm not sufficiently informed to tell you exactly what the strategy will be, but we will have that information in short time. And as soon as we develop a strategy that is approved by the CA and the mayor, I will make sure that it'll be in your inbox that day.
Okay. So I have to imagine, though, whatever that strategy is, will have to be budget neutral, because we won't get it till after we pass this budget.
Yeah, I mean, the issue with vouchers, as I understand it, is, there are clearly enough vouchers to to basically pay for.
Right. It's a people question on the
it's
other
a
side.
people question, and I'm not certain that the dollars for the people aren't there. It's the fact that we are having extreme difficulty getting case managers to do this work.
Yes.
So, except for those positions that may have been swept, during the, considerable effort to close this gap of $1.7 billion, agencies with case manager positions that are still vacant, those are funded positions. So the money would be there for those. Now, if Laura comes back and says, look, we can't move forward as quickly as we would like without being able to fill X number of more FTEs than we have, then that is something that, as a case that she would have to make to Jenny Reed. And there's, you can look at a number of funding sources during the year that you could probably tap, but we have to wait to see what Laura says about, precisely what her needs are on the human resource side, as opposed to the, capacity for the current vouchers.
Sure. I would say probably one of those is pay, if we're just going to keep it real, right? If I look on, I'm not even gonna call the organization out, but one of the CBOs that does case management and outreach, if you're offering me 50,000 with a master's degree, the X number of hours of supervision, plus having to be licensed, but Children's National, which testified earlier, is offering 75 for the exact same position, except for I get to do it from a hospital office.
Sure.
Right? I'm going to go with Children's every time.
Absolutely.
And so I think that has to be part of the conversation, is whether or not salaries are competitive enough to get people to do this work, or we need to relook at the credentials that we are asking for people to have for these particular jobs. Because as folks testified earlier today, if we want more people with lived experience to be able to help navigate this process, many of them would say, I want to deliver a case management experience better than what I had. But then we say you need a master's.
That's correct.
We're blocking.
I agree with you. And we've had this conversation at the agency level. And I think there was some concurrence. There's also some resistance, but I'm with those who say we need to look very hard at credentialing to make sure that we are not excluding people who could legitimately help us on the case management front.
Great. Good to hear you say that. A couple of other questions in terms of the encampment piece. Oh, sorry, Kiana.
I was just going to add to Councilmember, DHS is doing that on a smaller scale, but to your point, the amount of people that they're actually able to recruit and retain is not going to address the gap, but we can also provide that to you in our follow-ups.
Yeah. And I'll say this, right? As I've talked to Laura, she's been incredibly a good thought partner. When I come with a crazy idea, she's like, let's kick the tires and see if that can work. And so I think we're all just kind of need to put our heads together on this front. A few more questions. Why doesn't DMHHS track or publicly provide public information in terms of the housing status of the individuals affected by the encampment closures? If I recall, at one point, there used to be some sort of dashboard. Maybe it was last summer, if I'm thinking correctly, but my understanding is it's not on your site or updated at this point.
The dashboard from the pallet should be up and still live. I know I came down one time and we asked why was it taken down, and they said it was a mistake. So that should be back up.
Okay, the same link. We'll check it.
Yeah. So that should still be up. Now that we also at a program level, street level, for lack of a better term, we track where members are, where residents are who were in encampments or those who've even been placed. And we have to be a little careful about providing information on individuals because you don't want to violate privacy. Right. But we should be able to provide a response in the aggregate about what happened to X number of people who weren't housed when a particular encampment was closed.
Or in process, right? Like, oh, are you still in the leasing process? Have you been leased, et cetera?
We should be.
And I would imagine, because you still have staff that are sort of working in this vein, but also the case managers and caseworkers, at some point, we're gonna have to determine whether or not it worked.
Right.
And what is the definition of success around?
I know care worked. I heard one of your public witnesses complaining that only a small percentage of people that we identified as receiving housing did actually have a voucher. That is true, but it's also splitting hairs. If I was sleeping on the street and now I'm in an apartment, I don't care a whole lot about whether or not the voucher has been yet processed, because if the city has said, this is your place, the funding source may change, but you're here. And you're here to stay if you would like. That's what really matters. Now, we have to figure out how you get them from a local funding source to the PSH. And we have to do that with all due speed. But to suggest that a program failed because of the 101 people they place, many of them are still on a local funding source as opposed to a federal funding source, is misguided in my judgment.
Right. And I do think that getting folks to PSH is the goal here, mainly because we know we have instances of individuals who are been placed in housing, but without the wraparound supports, they are unsuccessful in being able to sustain.
It is the goal. But the first goal is to get them off the street, to get them out of the elements, to get them away from danger, and to get them in a place that's safer. I will say, because I asked Jamal this question the other day, how many of the placements that we made in care have blown up? I don't think he said, I don't think any of them have blown up. So I don't know if that speaks to the sufficiency of wraparound services, or that we may have been placing a lot of people who didn't need wraparound services. But he told me, and I remember, and I'll double check, but I said, give me the number of placements that have blown up that people either had to be taken out of the apartment because of, a mental health episode that required treatment or whatever. And he said the number was infinitesimally small. I thought he said maybe one or two people max, and we placed over 100 people.
Okay. In that sort of a follow-up in terms of what you're saying around placement. So according to the pre-hearing responses, out of the 145 individuals cleared from encampments in FY 22, 23, and 23 to date, 59 have refused services. Now, I'm not sure if that includes McPherson Square or not, but my question is, for those who are refusing services, are we asking why?
Oh yeah, we always in fact, when I give these reports, X number of people said they didn't want service. It's the first question I ask, why? And if they can't tell me, I said, well, you need to go find out why. And they come back and tell us.
What's the number, like, what's the top two reasons?
Well, it depends on who you ask. Some people say it's lack of trust of DC government. And I've seen some of that because I've talked to some residents who would not accept services, particularly when we were closing Noma and New Jersey Avenue. I said, look, why would you not accept? I'm telling you right now, you can go into a hotel today and we'll get you in an apartment as soon as possible. And their response was typically, I don't trust, I don't want to deal with the government. Now, there are other reasons as well. Some people obviously have some significant mental health issues, and it makes it difficult. Sometimes they can't envision taking on that responsibility, and they just prefer not to deal with it and they walk away. But our outreach teams are persistent, and they will continue to keep in touch with those persons who have rejected services, with the goal of always getting them to change their mind and come into housing.
I'm over my time. Councilmember Parker.
Thank you. So many more questions that I want to dig in there, but I will likely just follow up offline to delve in more deeply. One thing I did want to probe on was just the continuation or the lack of continuation of the CARE program citywide. And it seems as though there are a number of folk that are, there are a number of folk that are in the continuum. And so as you all are not looking to invest more resources there, what happens to the hundreds of individuals that are in flux?
These are the people who are still, who are in care or who are in the homeless service system but don't have housing.
Right. So I guess the question, let me rephrase the question. Are we still working to expedite housing for those individuals? Or what happens if, let's say somebody is in temporary housing,
sure,
and has not yet gotten to permanent housing?
Yeah, I understand your question now. The CARE program has ended as a pilot. It was there to test the question of whether or not a program that offered immediate housing, whether it be bridge housing or a voucher, to persons who were experiencing homelessness on the streets, whether or not that program would demonstrate some efficacy in moving people into housing. We feel we've answered that question. And the other piece was, well, the CARE has several questions. One of it was, will a large number of people accept your offer? Can you move them into housing at a faster rate than is witnessed in the larger homeless system? And is it feasible to close down certain encampments following a CARE engagement? And so we answered those questions, and I think we answered them very well. So that has ended. But for the folks who either rejected services, did not get housing, we are still working with those individuals as a part of the regular homeless system housing process. And our team on the ground follows them, engages with them at every chance they get. DHS, through its system, is working to secure housing for those persons, but they're doing it in the context of the larger system, which includes almost 1,500 people who are living in shelters.
Got it. And so just to make sure I'm tracking, so does the program have efficacy?
Oh, absolutely.
Yes. And were we able to expedite housing for individuals through the program?
Absolutely.
And I forget the third question you were testing, but
was it feasible to close those encampment sites that were targeted for closure because of any number of health and safety reasons? And the answer to that question is yes as well.
So if and while the matter of the folk in shelters and the tension that is caused there with the CARE program, running up against access for folk in shelters, that is a point well made and taken. So if we are saying we've answered yes to these questions, why then sunset the program rather than scaling it and continuing it moving forward?
Because you touched on it. One of the inside debates we used to have about CARE with DHS and the outreach community. How is it fair that you target housing to persons who are living on the street when who may not even have been there for 3 or 4 months, and we have people in shelter who've been waiting for housing for years? How can you, in good conscience, jump the line to allow them to jump the line to get housing, leaving other people in shelter? And what we said at the time was, look, we need to test whether or not this process works, because we have heard enough stories about people who live on the street do so because they don't want housing, which I always question. And so we said, we're going to test that. But now that it's tested, the question is, how do you draw from the lessons learned from that and implement a successful housing connection program in the context of the larger homeless system? And that's what Laura and her team are trying to do. And the reason we stopped CARE was because there was a legitimate backlog of persons with vouchers who were not able to get in the apartments that they selected primarily because they didn't have case managers. So we thought, and as the CA has indicated, it would be unwise to continue to push CARE in the environment where people actually with housing vouchers are not able to get places because we don't have staff to case managers to staff their housing, their choice of housing. So that was the reason we slowed down CARE, and we got to the point where I asked DHS, and they submitted a very rational and responsible plan to do both: focus on persons who were in encampments without denying services that could lead to housing selections and placements for those who were in shelter. But once they, almost coincidentally to their submission of that plan, which basically said we could clear street encampments in 9 months, coincident with their submission of that plan was the observation that we had a backlog in the voucher program that was pretty sizable and stubborn. Okay. So we said, okay, we got to fix that.
Okay. I do want to switch gears just for the sake of time and come to the subtitle proposed in the mayor's budget, which essentially would put a cap on Medicaid reimbursements. We've heard many today testify, and I would argue pretty compelling testimony from Children's Hospital around the devastating impact that this would have on that just one major resource for the district. And I think the benefit, if I'm looking at this fiscal impact or financial plan impact for that proposal, it would save the district $11.3 million in Medicaid savings and $26.4 million in federal Medicaid savings in fiscal year 24. So if I'm doing the rough math, that's roughly what, 37, almost $38 million. Can you justify the costs versus the proposed savings? Because it seems to me the costs that we heard from many providers today far outweigh $38 million in savings.
Yeah, well, I would first of all, we execute savings initiatives when there's a systematic problem in the city's budget. Given our druthers, we wouldn't have submitted any savings initiatives. But that's not reality. Now, there's a logic, a compelling logic to our work that none of the public witnesses touched upon because it doesn't put them in a good light with respect to why we did it and what would be the cost of not doing it. Now, I can go through that logic, but that was going to be a part of my testimony on DHCF. And so my preference would be to, rather than to cherry pick and get away from and not present a full picture, is to give you a full picture, but do it in the context of the DHCF briefing.
Okay.
If that's,
I think, yes, I hear you. I think I know the answer to this, but those savings are, I imagine, dispersed in the general fund in the mayor's proposed budget. Is that correct?
Dispersed in the general fund. Those savings,
in other words, or are they dedicated to a line item there that we can find where that $38 million in savings is now redirected or reprogrammed?
When you have a situation where you have a gap, in this case, 1.7 billion, that was a function of collapse in revenue in the out years of the financial plan, plus historical spending levels from the pandemic that could no longer be funded because your revenue collapsed. It's going to be very difficult to tie a particular reduction to a line item in the current budget. It's not going to line up like that.
That is in part the challenge. One more question with my remaining time. We heard from another provider just a lack of communication as it relates to the MCO transition. Can you speak to what role, if any, you and your office is playing in being a liaison of sorts with providers during this transition period?
There's a process. We have responsibilities and the providers have responsibility. We don't get involved in contract negotiations. We're not allowed to get involved by federal rule. So we don't get in and arbitrate contract disputes. We do look at whether or not people are negotiating in good rates and we can make decisions. Negotiating in good faith, and we can make decisions about contracts based on whether or not we see that. But our job in terms of the MCO transition is to communicate to the beneficiaries what the MCO choices are, to give them the opportunity to tell us that they will accept the assignment that we make, because once a new plan comes in or more than one plan come in, we have to reassign members from the plan that's leaving to the plan that's coming in. We do that reassignment. Then they have beneficiary choice. And so we have to have a mechanism in place to facilitate their choice. If they elect to say, I don't want to be placed with plan A, I want to go to plan B, then we have to execute that. We also do normal communication around, the community notification that we have a new plan, this is the new plan, and this is how you get enrolled. And we encourage all providers, obviously, to, under our universal contracting provisions, to develop contracts with all of our plans. Now, beyond that, and again, some of my DHCF folks can speak to it in more detail later. That is the gist of what we're doing. And we have a much more expansive communication role associated with the Medicaid recertifications that are now required because the pandemic the public health emergency has ended, and we have to stop allowing people to stay on the program if they're no longer eligible. There's a massive number of activities that have to be conducted to make sure that that is fairly and effectively done. And we are at the very beginning stages of making that happen, not without some bumps in the road, but we have a plan.
Okay, that is my time. I'm likely going to need to jump to another hearing, but thank you all for your testimony.
Okay.
Thank you, Councilmember Parker. So Deputy Mayor Turner, just so we can close out the DMHHS ones, I have one more question and then I will so we can all be on the same page of the DMHHS relevant follow-ups, and then you can present on healthcare finance. For back to the FTEs for ICH, are there 4 FTEs for ICH?
So there are a total of 6 people in the ICH, but the issue of why we have the MOU was because the funding that was, I believe the funding for the positions went to DHS instead. And so that's why there's an MOU to fund those positions, but you have the executive director and then you have the advisors, but that's why it might be showing up if you're looking at the ICH.
Okay, so follow-up one, some sort of crosswalk in terms of your positions. Because even remind me of your name.
Yes, I'm Adrian.
Adrian, right. So Adrian, when you said 13.7 for DMHHS FTEs and then 20.75 to include all the MOUs in ICH, that's still one less person than we have.
Yes, because we're not counting the FTE that was reduced for FY24.
So there was a position that was taken as a part of filling the gap for the $1.7 billion. So that FTE showed up on the DMHSS side of the budget, but that's not reflected in that number.
Oh, I see. Okay, so right now in FY23, you have 1 vacancy.
Correct.
In FY24, it is proposed that that will no longer be a person.
Correct.
Okay. All right. So then some sort of update, I guess, in terms of DMHHS's efforts around what are we doing to clear the backlog, whether it's credential requirements, et cetera. I know you have that proposal. And then the status of people who are currently placed in housing through care or other encampment closures to the perspective of after X number of times, are they still in housing? So that question that you have for Jamal, who's not here, but in terms of
we'll get you that day.
Okay, great. All right. So we'll put some time on the clock and then you can present, or I think there's a second presentation for DHS.
Yes.
Okay. And I will just say this, if there are other council members who come who might, they will likely not respect the split. So you're gonna have to answer questions.
I was more than willing to do it, but I didn't want to take up, so much of the time, given that I know you were interested in getting to DHCF.
Yeah. All right.
And I'm more than willing to meet with the council member to walk him through how we got to if he's not going to be on this session, if you can let him know that I can come to his office and walk him through how we arrived at the savings decisions on the hospital.
Okay. He might be back. Like I said, one of the hearings today, they'll be here all night. So he might be back, but all right, on to you.
Thank you, folks. Other than that, I'm fine. Mm-hmm. Oh, you ready? I thought we were gonna get 15-minute Mountain Dew break.
Do you need a break?
No, I'm just kidding.
Okay.
I would like a Mountain Dew though. Mountain Dew. That's it. Oh, yeah. Yeah, they do. I shouldn't be drinking, but yep. Madam Chair, I am joined by some members of my executive team and our AFO, and we have some of our key senior staff members who are all instrumental in developing a very complicated but equally responsible proposal for the mayor's consideration in what was a really, really challenging fiscal time for budgeting. Our senior deputy budget director, Angelique Martin, who was critical in helping us put this together, had a medical appointment and cannot be here today, but she is listening she's watching the hearing, and she's available for questions if we can text her if there are issues, but she's almost invaluable. Now, the high level takeaway from DHS perspective, given all that was done to close a $1.7 billion gap, is that the mayor's commitment to funding healthcare services through DHCF's budget for Medicaid and Alliance is clearly evident. If you would go to slide 4, you will see, I guess there's a timer in there that blocks part of the graph. I don't know if that HHS in general, the cluster is 32% of the mayor's of the proposed operating budget. But DHCF, just on local funding alone, has almost a $1 billion budget that which is a significant portion of the $10.6 billion that is spent on local funding for programming. That almost $1 billion draws down, a total of a grossed up figure of over $4.3 billion for healthcare services that almost half of the city benefit from in terms of the number of beneficiaries. If you go to next slide 5, I just want to move through this rather quickly. There's a brief discussion of our agency policy and budget structure to give you a sense of what the mayor's budget is paying for. Then there's a high-level overview of our budget proposal and a very brief discussion of the hospital budget that is emerging from the ground as we speak. If you go to slide 7, there were some comments during the public testimony about DHCF, making sure that DHCF does what it is supposed to do with respect to recertifications and making sure that we are as aggressive as can reasonably be with respect to ensuring people are eligible. From a eligibility standpoint, DHCF has the highest Medicaid eligibility levels in the country for some subgroups. If you look, we are the only state, and I repeat, the only state that allows incomes of more than 220% of the federal poverty level for adults who have children. Alabama is the next closest at 160%, and then most other states are at 138%. If you look at Medicaid eligibility levels for childless adults, which is a very, very expensive population, we have the highest Medicaid eligibility level in the country for persons who are childless and they have incomes that are below 215% of federal poverty level. Most other states are around about 138. We're at 215, and 11 states do not even have the program. For infants and children, we rank second at 324% of poverty. In terms of our program structure, we are bifurcated into managed care and fee-for-service. Very important that you remember this as we work through the rest of the presentation quickly. Right now, about 85%, close to 85% of the 300 and some thousand people who are in the program have been assigned to one of 4 managed care programs. The others are in fee-for-service. And why is that important? If you look at this next slide, fee-for-service beneficiaries, though much smaller in number, are almost more than 3 times expensive as expensive than persons who are in managed care. And I need you to remember that critical point. Fee-for-service members at $29,000, almost $30,000 per year, are much more expensive than MCO beneficiaries at $8,800 per year. Although they're only 16% of the population, with MCO beneficiaries being 84%. Next slide. You know, we put this slide together back in 2011, and we've tracked the growth in the enrollment on this slide ever since. And as you can see, since the during the public health emergency, aside from the period where they manually moved everybody from the Medicaid, from the Alliance program, who would be eligible for Medicaid under a new set of guidelines. Aside from that period in 2009 to 2011, the 6% growth that we are seeing since the pandemic is the highest this program has ever seen. And I would call that more natural growth, because the growth from 2009 to 2011 was generated by a significant change in eligibility. So now that is where we are with respect to the impact of the pandemic. The next slide shows you that these numbers will normalize. Enrollments will drop. Even if we do a perfect job on recertifications. I mean, if we are absolutely pitch perfect, which will be tough to do because it's an administratively complex issue, you're going to see significant numbers of people roll off the program because they're not income eligible anymore. And so there will be a lot of noise and friction around the fact that people are losing their health coverage. There are options, but those options are no longer free. If you're on Medicaid, you don't pay a dime. You don't pay co-sharing, you don't pay deductibles, you don't pay any premiums. Co-payments, I don't think they may be on the books, but nobody enforces them. So you'll go from a situation where you're paying nothing for extremely valuable and comprehensive health care to a point where you have to go to the exchange and pay a significant premium and deal with cost sharing co-payments as well. So there will be some people who get upset, but that is a federal prescription. There's nothing we can do about it. So I want people to understand that. You know, we're not throwing people off because the city says throw them off because we don't want to pay for them anymore. Federal government says we have to throw them off because the public health emergency has ended. How we got to our budget of $986 million is articulated on slide 13. It's an iterative process with the executive office of the mayor. The first thing they do is take out all one-time funding from the previous year. That was about $62.8 million. That gives you a revised baseline. Then they ask the agencies to hit a mark. Our mark was, we hit a mark of $73.5 million. Then the mayor looks at all this stuff and says, you know what, I don't want to do some of this. I'll do some of it. I don't want to do the others. And then they restore. The mayor restored $166 million, which is more than we gave up initially, to create an adjustment, a positive adjustment to our budget of $93 million. Then we got on top of that a $1.7 million enhancement to get you to the $986 million that you see. Slide 14 is put there merely to show you how efficient we are with respect to how the money is used. 94% of it goes to provider payments. We have a nice sized staff, but we're not bloated. And most of the admin money is spent on contractual services. We have an infinitesimally small percentage spent on hard FTEs, personnel in the agency, and the federal government reimburses about 45% of those FTE costs. So this is a program that largely puts money in the hands of providers to deliver the care that the beneficiaries so desperately need. If you go to the next slide, this gives you, we did have to, as they said, church up with some savings. And how do you do that when we are largely blocked from doing eligibility changes because nobody wants to lower eligibility, when you don't want to reduce benefits because nobody wants to do that, and when you don't want to have major cuts in provider rates because nobody wants to do that. So what's left? Well, we have a team that's pretty skillful in maximizing revenue through cost shifting. If we have excess funds in this case, the dedicated tax fund, we use some of that money shift to the cost shift on local costs. We had administrative savings that were a reduction of 16 FTEs that generated about $2.3 million. And then the one that everybody's talking about is the program efficiency savings of 11.3 million based on a payment ceiling that we put in on the rates that MCOs can pay hospitals. Now, how do we get there? I will say, you know, I would like to take credit for all of it because it's very well done, but I can't take credit for the hard work that went into figuring out if we can do this and if it would be fair. That would be the work of Angelique. That would be the work of our actuary, Joe. Joe, raise your hand. We have a newly minted actuary that is, we have two staff who score probably perfect scores in math on the SAT, our AFO and Joe, our actuary. And they're surrounded by math challenged people, so they get frustrated all the time. So they did a lot of the work to answer the question of can we and should we cap MCO contract rates for some of the services they provide. And so we oppose the cap that's in the Budget Support Act. And these are the things that need to be known that were not articulated by the public witnesses. The cap rates that are in the Budget Support Act are still above Medicaid costs for MCO hospitals. In other words, those rates are set at a level that's more than the cost that the MCOs incur when they negotiate contracts with the hospital. The rates reflected in the cap incorporate pediatric what we call pediatric adjusters on the fee-for-service side of the budget. Remember I told you the fee-for-service costs are higher than the MCO costs? Well, the way we set the rates for the range and MCOs, we use the fee-for-service rate as the base level. That means you can't pay lower than the fee-for-service rate, which is already higher than MCO costs. So they're starting at a point where they're getting paid more at a minimum rate, and nobody gets the minimum in DC. You know, there's not one hospital that will, when you see a rate range of, if it's from 5 to 10, nobody's gonna do 5. They're gonna do something between 5 and 10, and some of them will do at 10. So they're starting at a rate that's above their cost, that reflects pediatric adjusters, and Children's neglected to inform you of that. The complaint that we are making it difficult for them to meet certain margin targets across their system is not relevant to us. Medicaid is not funded to drive or to support certain profit levels for any provider. In fact, for some providers, we can't pay more than cost. But we can't be responsible for if a hospital says, 2 years ago, I was making an 8% margin, now I'm down to 5%. You need to get me back up to 8%. That's not what Medicaid is funded for. And if we tried to do that, well, you'd break the city. The city couldn't afford it. So, you know, I don't have any particular sympathy for an argument that is, we can't meet our margins the way we used to because you're paying us above cost. That argument doesn't resonate well with me. Now, if it's the council's wisdom to remove the cap, you're probably gonna have to find more than $11.3 million, because once the other hospitals hear that they're no longer, that this cap is removed at 110 because somebody wants to pay Children's 130 or 140, whatever the number, I think their CFO said they need 130. Let me say that real slow. He wants 130% more than cost, and he wants Medicaid to pay for it. If that is the will of the council, if I'm MedStar, if I am GW, if I'm Howard, I'm saying, you got to pay me that same thing. And then because our MCOs are faced with a requirement from DHCF that says, if you don't contract with every hospital, we're going to throw you out of the program. Now that's unfair to the MCOs because it takes some of their leverage in negotiating away, because the providers know that they have to get a contract with them. So how do you do that without the vendors, the hospitals breaking the budget? Well, in this case, you put a cap on it that says, this is as far as we can go. And so that's how we got there. And if you look at that slide on that's in front of you, if we had not set a cap, the actuarial adjusted rates that we would be paying are 132% of cost. So with the cap, we're gonna see $11.3 million in savings. And if you look at the 110% rate in what year was that? 110%. Children's rate was 105%. So this rate was higher than children, but children were still above cost at 105%. So I guess the point is, we don't like to set caps, but sometimes you have to, particularly when you're trying to close a $1.7 billion budget. And every other agency in the district is contributing to closing this gap. And there's no reason that the DHCF, despite our important mission, all the agencies believe their missions are vital. There's no reason we shouldn't have to contribute to that as well. But I think we've done it with the help of some pretty smart people in a very responsible way. And I cannot believe, and you notice there were no other hospitals here to complain about this. That ought to tell you something. There was no other hospital in the hospital association has what? MedStar, Georgetown, GW, they have Howard. They all like high rates too, but how many of them had public witnesses here today to complain about? None of them. That to me speaks to the inherent reasonableness of what we proposed. Because believe me, if we had done something irresponsible or unreasonable, you'd have Jackie Bowen sitting here telling you that we were crazy. You'd have Howard, MedStar, GW, Georgetown sitting behind her saying she's right, what they're doing is unfair, but none of them are here. And there's a reason for that, because the work that Angelique, that Joe, and all the other staff, James put in on this were long hours, and it was very complicated and very, very well done. So with that, I will move to where we are with the new hospital. I'll ask Ben to come up, and James, you rotate and let Ben in. As I have said in the past, I think we are getting close to one of the proudest moments in the city with respect to healthcare delivery with the new hospital. Now, I told Ben my only role, once we got the financing done and the contracts negotiated, my only role is to get out of his way and let him make sure that this gets built. And I told him to only let me know if it's on time and on budget. And if it's not on budget, what does it take to get it on budget? But then he has to explain to me why it's not on budget. So I'll let him give you talk through 2 slides real quick, and then we'll take your question.
Thank you, Deputy Mayor, and good afternoon, Chairwoman. So the next slide here just gives you a high-level overview. The hospital is on schedule for its construction to be completed in December of 2024, opening to patients in early 2025. To date, the overall project has remained at 2.5% inflationary costs. Nationally, not just hospital construction, but construction generally. And as you know, all of our purchases day to day have seen significant inflation. In construction specifically, we're seeing anywhere from 20 to 30% inflation since the start of the pandemic. On the next slide. So the mayor's budget proposes adding $22.6 million to the hospital budget. These funds are specifically already earmarked in a way that will help us complete the project on time, and will be used for specific construction costs that we are seeing, increased costs in the cost of medical equipment, increased costs in IT equipment. And it is our goal that with these funds and by moving back $10 million that was allocated in FY25, we'll have the funds we need to complete the hospital on time in December of 2024. What you see in front of you here is just a short overview of the funding since the start of the pandemic. This hospital was budgeted pre-pandemic at $375 million. Now the district fund is at $412. UHS, our partner, has added $17 million on their own, and the federal funding is about $4.7 million. So when you add that all up, we've added close to $60 million. Of that total amount, 7% has been to make the hospital bigger. That includes a 4th floor so that we can have 48 additional beds. It includes an expanded diagnostic and treatment area. The remaining 8% is to address The additional costs that we have seen over the past 3 years, in addition to some of the very specific requirements we were faced to meet by the United States Commission on Fine Arts, and some site complications we ran into, as St. Elizabeth's is a very old historic site, and we found some very unique things out there. So I'm happy to go into more details, but we're very excited about where we are and where we've been able to maintain the project budget.
And Madam Chairwoman, that concludes DHCF's presentation. It is a rapid walkthrough of a very complicated budget.
Right, we're gonna get into it.
Okay.
We're gonna get into it. Everyone settle in. Thanks for that, Deputy Mayor, Director Turnage, and thanks, Ben, for the update on the hospital. And thank you for hosting myself and my team out at the site for a bit more of a deep dive into the budget, and just being able to see things out of the ground and cranes in the sky. So, but I'm going to go back to DHCF, sort of administrative nuts and bolts, to try to dig into a little bit of that. Okay, so I'll start with what I'm referring to right now on IT is in agency management, or that is what has been sort of provided to us. We've seen a large IT budget increase over the last couple of years, from $7.5 million in FY22 to $16.2 million in FY23 and $19.4 million in FY24. What's going on? Why are your IT costs going up so much?
It's primarily DCAS, I believe, and I'll let Darren.
But this is separate and apart from DCAS.
Oh, data warehouse. Oh, well, Darren gave you the details, but if it's data warehouse, we have probably the best data warehouse in the city. We can churn out almost any report, any analysis in a very, very short period of time. That costs.
I don't know if y'all want to go ahead and put that out there as a telling my colleagues that you can produce any report in a very short period of time.
I welcome it.
Okay, so in the agency management, the IT costs are relevant to the increases around data warehouse?
I mean, that's the primary project. It's the contracts line that's going up, and there are several contracts, but they are all related to, in one way or another, the Medicaid data warehouse.
Okay, you mentioned in your testimony that the federal government subsidizes our quote technology system design and development projects. Can you speak to that a little bit and specify how much the feds are contributing into which projects? If it is for the data warehouse, are they giving to that, and what percentage? I'd imagine they're giving some to DCAS as well.
Yeah, Darren can give you the numbers. I can tell you that when the federal government has several requirements. One is that we refresh our management information system every 5 years, I believe, and they pay 95% of that cost. And those are very expensive.
95%.
Yes, they pay 95% of that. 90% of that
90.
cost.
Okay.
And we submitted the data specs for the data warehouse to CMS. And I can tell you at the time, they said this was one of the least expensive projects that they encountered of this nature. And it was one of the most impressive. You know, Darren can give you the details on what those numbers are beyond what he's already discussed. But the federal government has a huge role in making sure that, and the reason they put this match money out there, because they know that states, if left to their own devices, would not spend that kind of money on IT. They would feel that it was not that good of an investment. But the federal government wants to know how we're using their dollars, who's being served. They want to know what utilization looks like. They know what they want to know what costs are. And so they know that we have to have top-notch data systems to do that. And so they give us a massive incentive coupled with a requirement to build these systems.
Darren?
I am unfortunately not going to be able to give you the precise number sitting here.
Okay.
But I can follow up on that. But the director is correct. We get 90% federal reimbursement on IT, design, development, implementation. And then for certified systems, we get 75% federal reimbursement for operations and maintenance.
Okay. We'll put that on the follow-up so we can dig into that. I have a couple more IT related questions. There's been a 122% increase in the other services and charges that I understand is driven by enhancements to IT hardware maintenance and IT software maintenance. which is correlated with the budget for IT acquisitions and the equipment budget.
Yes.
So it looks like there's some IT acquisitions that are expected for FY '24 that are also going to require ongoing maintenance. What are you guys buying?
Those are licensing, as I understand it, mostly licenses for our existing data systems. In fact, I was just having a conversation by phone with Angelique this morning, and I didn't write down what she said, but I do remember because I had questions about the same growth in expenditures, and I was told it was primarily licenses, and somebody has more information you can add in.
Yeah, we did do an equipment refresh as well. So that's part of the increase in costs, like refreshing the laptops for the agency.
Yep.
And other just equipment that has design obsolescence. But that's the bulk of it. I can provide further detail to the extent that you desire.
Okay. The proposed budget has increased about 2 million for accounting operations. That's a 40% increase from existing budget with no additional FTEs. Do we contract out?
So accounting operations, as you might guess, is part of my budget. And it consists of both the accounting staff who, do all the accounting functions for the agency, but it also includes an audit. And the auditing is all contracted out with private audit firms. The increases are due to auditing various Medicaid provider cost reports. And we don't audit every provider every year. We audit, it's based on the state plan and when we need the data, because we use the audited cost data in the rate setting process. And so rate refreshes can be every 3 years or every 5 years, and others can speak to that more expertly than I can. And so we do the auditing to have the audited data to support that process. So it can be a little bit lumpy, where there are some years where we need to audit numerous provider types and other years where we audit fewer.
And that's the reason for the change in cost.
Yes, and so I can give you the breakdown by provider type if you're interested. Are you interested? Or not?
Okay, we'll follow up
Okay.
on that
Sounds
front.
good, yeah.
So in terms of the audits, they're not one time, but some years the volume may be more than other years.
Right, because they're not every year, even though they are recurring.
Okay. All right, let's talk a little bit about DCAS. I think we talked a little bit about this at Performance Oversight as well. The third release was set to be fully implemented by March 2021. Did that happen? Ah, there she is. Can you just introduce yourself for the record?
Good afternoon, Tamika Fitzgerald, the director. Good afternoon, Tamika Fitzgerald, the director of the DCAS Access System.
Okay, so the third release, was that done on time?
It was
Okay,
November 2021.
okay. How many other programs use DCAS? So we know of Medicaid, SNAP, and TANF, but are there other programs that are integrated into the system or that we hope will be integrated into the system?
So those are our primary agencies, Department of Human Services, and we also partner with the Health Benefit Exchange. We have also been we provide support to other agencies in the cluster, for example, OSSI, Housing, CFSA. So there are functions that we support on, and we're continuing to move in that direction. But right now, our primary agencies are the Health Benefit Exchange and Department of Human Services.
Okay, so do they send you all money for this? Or are you cost
do have-
paying it out alone?
No, we do have MOUs with Octo, we have MOUs with Health Benefit Exchange and DHS that we fund, but those are the primaries.
Okay, and approximately how many people do we say are processed through DCAS each year?
So I would have to go back and get you that number.
Okay, I'll ask more of a budgetary related. So if the third release is out, you said November. The $7.2 million of additional funding, including $4 million for quote organizational change and $4 million for IT management. What is that money for?
Yes. So that was more so a restructuring of our, the way that we utilize the DCAS's budget. So we are primarily in operations and maintenance. And so now that's moving from a 75, from the DDI that we had 90-10, as we were talking about earlier, now to a 75-25 breakdown. And so as we are aligning that, we are having more costs on our operations side. We also had 2 procurements that we were implementing. And so we had to, what I did was keep our independent contractors as well as our vendors budgeted for both of those being on board almost at the same time so that we could have a seamless transition. Unfortunately, we did do that for our tier 1 call center, and that worked out successfully. But our O&M vendor, we did not.
What does that stand for?
I'm sorry, operations and maintenance.
Okay.
I apologize. For our huge, it's a IT procurement in which we were going to have one vendor oversee the majority of our IT work, operations and maintenance. And so I budgeted for the independent contractors that we had for us to transition over time so that we can hand over, so that we will not have an interruption in services while we were making that change. Unfortunately, that was not successful. We had to vacate from that contract, but we are planning to do that again. And so that's why we still have a large amount inside of that budget line.
Okay, to make that transition. Have we started that process? Like, I know you said the first one was not successful. You had to vacate that contract. So have we put out an RFP for?
Yeah, what we're doing now is working with independent contractors, and we're working with our office of contracts and procurement to ensure that we have a solid RFP that's going to go out so that we do not have the same issues that we had previously.
Okay, so we're doing this switch for efficiency to move from independent contractors to just one person?
Yes, because we currently staff about 100 independent, 125 to 30 independent contractors on top of having
just for DCAS, 130.
We also have independent vendors that we are working with to also provide some of our IT staff. They're not all IT. We have other, our organizational, as you were saying, change management, our project management office. But we do have a lot of independent contractors. And so in order to make it more cost effective, more efficient, to cut down on that oversight, we are hoping to go to one vendor to hopefully, to decrease that in moving forward.
Okay, so in order for us to get to a more cost-effective, efficient system, we have to spend $4 million more dollars.
No, so it's not $4 million more dollars. The money was shifted out of other categories. So we did a shifting. When I came in and became the director, I looked at our APD and I saw how the money was in different buckets. And so in order for me to organize it better, I just moved the money into what I would see as the correct bucket. So it looks like
I see. Okay, so
but it's not.
It's a moving in terms of line items.
Yes.
Okay, so did DCAS have? Got it. All right.
Angelique says we had 2.7 million in savings for FTE year over year.
Yes.
Okay.
And we're having savings now, even as we're moving from DDI and O&M, we are still seeing savings from 2020 to now that our budget is going down consistently in this area from looking at all the efficiency, looking at areas that we could be more efficient and effective in.
Okay. Can I,
just one thing to your question about total number of individuals that DCAS touches or processes through. It at least processes every Alliance and Medicaid beneficiary. So that gets you to at least 320,000 people,
we'll have some duplications with other programs like SNAP and TANF, but that from at least a Medicaid perspective, which should be probably the largest group or population, you're covering well over 300,000 people are receiving some, interaction with the DCAS system.
I mean, I think because we have so many individuals, as you said, I do see the value and importance. I guess my overall question is, when we first envisioned DCAS as this system to speak to other systems and things like that, are we there on the vision?
No.
Okay.
And, probably get in trouble here, but when I came to the district in 2011, I think we just getting ready to start DCAS because I think it was October of 2011 when it was funded as a part of the exchange. And the goal then was to do just what you described, have all these programs, one entry point, and the development of that system. We didn't have the IT infrastructure at DHCF that we have now. In fact, all we had was people who could basically set up computers for us. We didn't have the IT expertise that we have now. And so we farmed the whole thing out to other agencies. There were some significant starts and fits that ended up costing a lot of money. We probably spent, we were talking about it in the rooms earlier, probably over $600 million on that system over a period of 10 years. And as Darren pointed out to me, the reason it's so high is because we probably paid for some of the same components twice, because when they were first implemented, they were done wrong. Sometimes not done wrong because of the contractor, sometimes done wrong because the contractor was following the instructions that they were given. But we couldn't clap back on the contractors and take their money because they did exactly what we told them to do. We weren't running it. Then the responsibility for the system shifted across October to another agency. Then finally the CA asked DHCF to take it over. And we did in 2017. And we can show you the cost to get to finish. I think we did a really good job. I know I'm too now home, but I think we did an excellent job. Not that we were perfect, but we certainly drove the cost down and got us to a finish line. We were, for a couple of years there, we had spent a lot of money and the system was not operable.
Oh, no, it was a line item. Oh, that's for the DCAS. We can't take it. But it's just sort of like, okay, what is DCAS and why is it this thing that nobody knows how to use yet? So overall, how much money have we spent on this thing so far?
All over 600 million over 10 years. More than the cost to build a baseball stadium. Let that sink in a little bit. A lot of money. But IT is expensive, and this is a very complicated system. You can do a lot on it that you couldn't do before it was constructed. But it probably should have cost substantially less than that if we had been mistake-free as a city, mistake-free in executing it.
Okay. Okay, I'm gonna let that sink in. But as a note from as we speak about IT, all of you need to move closer to your mics or move your mic closer to you because the good people on the TV can't hear you. Wonderful. All right.
Good idea.
Last question in terms of DCAS. Are other states using the same software or technology or have they moved on?
It varies. I think North Carolina is the closest to us. Some other states use completely different systems. I think we have one of the better systems. We have one of the systems that there are a lot of states where they've spent as much money or comparably and the system's still not working. There were some real big disasters. I think Maryland ended up taking the vendor to court, suing them for millions because they said they spent all that money and it didn't work. We have a working system at the end of the day, and I think it's one of the better in the country.
All right. I mean, I'm just still saying, we spent $600 million.
It's a lot of money. It's a lot of money.
On a software system.
Well, it's a little more complicated than that.
No, okay, sure. But like if we pull back the layers, that's what we're talking about here, right? It runs reports, I'm assuming.
Oh, yeah. You can do
Yes, it
a
does.
ton of stuff.
Yes,
Are we maximizing its functionality and potential?
Not its potential, but we're certainly a lot better than we were.
we have We definitely are working and moving in that way. We have our online, we have our mobile application. Our user experience is getting much better day by day. We are taking all of that in and we are making the necessary changes so it could be more efficient. But where we are, I just want to point to in our budget is now, as we're being very efficient and cost effective in our budget, we are at the same, similarly to when it was only one program in DCAS, just Magi Medicaid. Now that we are functioning all programs, integrated eligibility, we are at the forefront in the district of having an integrated eligibility system, meaning that you can get your Medicaid, SNAP, and TANF and other benefits in one system together when you're applying. We are doing very well in that area, and we're continuing to move that, to push that envelope even further on how we can ensure that is a great user experience for the district residents. And our budget is now showing how efficient we are being, in that we are at the state about the same proximate where they only had that one program in here. Now we're running all of these programs in here around that same budget.
I would also add, I mean, from my perspective, DCAS is just eons better than our legacy HC system. And I am not a technical person. But the other thing that I think is crucially important, this is the kind of thing you'll never see from the front end, but DCAS is a rules-based engine. So so everything that's conducted is based on the rules that has been programmed. And that to me adds a certain level of integrity to the program that, quite frankly, we weren't rules-based before. And so that's not something you're going to see on the front end, like I said, but I think it's something that's extraordinarily important to just the overall integrity of the program, and to what Tamika said about the overall efficiencies too. So we are light years above, beyond where we were with our old legacy system.
And if you want to appreciate the complexity of the system, go grab a DHCF long-term care eligibility manual. And then think about all the rules that would have to be written to make that a reality in terms of a system.
Funny that you bring up long-term care, because that's what I was going to talk about next.
Okay.
Okay, so when we look at the long-term care support services line item, thank you, Tamika, under that division, why are we seeing such wild fluctuations? And I'm using rough numbers here, but in FY21, there was $16 million. In FY22, it was 12. Then big jump in FY23 to 23 million. And now we're seeing another reduction in FY21. What's causing this variation?
Yeah, so most recently, going from 23 to 24, there's a reduction of 2 FTEs. So that makes part of the drop. But additionally, we procured 2 contracts, one for our community transitions, and the other for our PDS, or participant-driven services. So we had to do similar to what Tamika described for DCAS. We had some side-by-side processing time for the 2 vendors. So it made the budget look a little higher in 23, but it drops back down in 24 as we have this new bid, and the bids did come in lower for those particular contracts.
Okay. The mayor touted a roughly $750,000 budget increase to increase the personal needs allowance for individuals with disabilities. Now, we heard testimony this morning from witnesses that believe that this is to fund the increase to $150 for individuals with developmental disabilities living in intermediate care facilities, and that this funding was under the Department of Disability Services. Is that correct? Or are these $750,000 in funds to increase up to $100, which was already implemented effective February 1? So who got the increase?
Good afternoon. I'm Catherine Rogers. I'm the Director of Long-Term Care. There are 2 different, I would say 2 different increases, and I believe one is in DDS's budget, and that's for those folks living in ICFs and folks living in residential supports under the IDD waiver. That is one bucket. There were other.
Do you know what their increase was to? I know that's not.
I believe their budget request was from 100 to 150 per month.
Okay.
Per person per month. The one that was effective February 1 mostly impacted our nursing facility and ICF residents. Our previous PNA for people in healthcare institutions was $70. And I think you noted this among the public testimony this morning, bringing them up to $100 where we had other community settings already at $100.
Okay, so the 750 that the mayor was talking about is not in this budget, it's in DDS. Or was that a combination of the two moves? The one that happened in February and then the one that is supposed to happen?
I think it's DDS. We'll have to confirm with DDS, but we're pretty confident that 750 is DDS.
Okay.
Yes, and I just got a text from my other chief of staff, said DDS. Not her, she's DHS, this came from Kiana.
Okay. All right, so are there any Medicaid enrollees who have a PNA of less than $100 at this point? No, okay. So Medicaid enrollees who are in assisted living facilities or certified residential facilities, which we understand are more independent settings, were previously allowed a larger PNA than everyone else. So I guess when everyone else was at 70, these folks were at 100. Now, was this because DHCF acknowledged that individuals in those more independent settings had a higher personal living costs associated with greater independence?
I'm not sure there was an explicit acknowledgement of that particular sentiment. That probably predates my exposure to the PNA policymaking piece. But I've certainly heard the public testimony about the relative personal expenses that come from whether you're in an institutional or, you know, something like an ALF, which we expect to be a more independent residential setting.
So right now, what we have is everybody's getting $100 minus what's going on in DDS. So let's just talk about the ones that you control. Everyone is getting 100, whether or not you're in an independent setting or you're getting all your meals, all your care, all your toiletries, everything, and you are fairly not as mobile. That's not, we can't be. Like, that doesn't make any sense, right?
I'm sorry, what that they only getting $100?
Yes.
But if every other need is paid for?
No, if you are at an independent facility, right? So if I'm at an assisted living facility.
Right.
And I need assistance, but I still can go to a movie or want to go out to eat or purchase my own clothes. $100 a month is extremely low, especially for our area. Have we done any cost setting adjustments to see, or studies, I guess, to see how other jurisdictions similarly poised as ours in urban areas are handling this?
We haven't, but my sense is that they are not, maybe not even as generous, but we can certainly take a look at that.
Okay.
And I'm trying to, so that when you do a PNA increase, how do the funds flow? What does whose responsibility is it? Does the provider pay out of, how does that work?
On the most recent PNA increase, it was among our institutional facilities, and there are different Medicaid rules for institutional Medicaid spending versus our home and community based. And so I know that this mid-year change in February 1st, the PNA was increased and DHCF made up the balance to the facilities. So since they
100%.
It was the $30 difference between 70 and 100%, $70 and $100. DHCF changed what it was paying to the facilities to say, we know you're getting $30 less from SSI on that side, so we'll make up the difference.
Okay. Oh, was it federally matched? The February change?
Yes.
All right. In the pre-hearing responses, you all provided a helpful table of the enrollment numbers for the residential placements and their PNAs. Do these numbers reflect the total population or just those residing in facilities within the district? So my understanding is that we have some folks who might be at facilities in Maryland. Do those numbers encompass them too?
Yes.
Okay. All right. So for folks who are in other states, are they subject to the same P&A requirements? Or limits?
My understanding that yes, I would note that we have folks in nursing facilities in other jurisdictions, our ICFs and CRFs are licensed by DC Health, and I believe they're all located within the district.
Okay. You mentioned in your testimony a program enhancement for long-term care eligibility processing staff transferred from DHS to DHCF. And that was 1.8 million minus the 500,000 for Produce RX. Oh, okay, I see. All right, so let me back up. In the information that we have, you all said that there was a program enhancement of 1.8 million for long-term care eligibility processing staff and for Produce RX. What is the breakdown of that money?
Produce RX is like 500,000, I think.
Okay,
Yeah.
just want to confirm that that was the,
Yes, and the 1.273 million is the local share of the staff who were transferred.
okay, and how many people are moving?
22.
It's 22 total. That breaks down to 5 MSS, 17 CS staff.
Have you met our policy director? He just comes up and starts blurting in the mic. I'm
Sorry.
Hello.
Can you introduce yourself for the record?
My name is Eugene Sims. Hello.
Hello, Eugene. Okay, you use some acronyms there, Eugene, so we gotta break it down.
So 17 career service, those are like our union staff, our frontline social service representatives, and social service representatives process cases and DCAS and other systems. And 17 MSS, our managers who oversee the CS staff. So
Career
career
service
service staff.
Okay, all right. Will there be any change in service delivery or processing time as we move those people? Like, are they physically moving? Are they physically detailing? Do they currently sit at DHS and they're moving over?
Yes, so effective October 1, 2022, they moved from the 8th Street location to LaFont Plaza. They currently sit on the 2nd floor of the same building where our DCAS team sits on the 5th floor. And that will continue. So that's the detail, effective October 1, 2022 to effective October 1 of this year. The staff will fully transition. They'll remain located at LaFont Plaza.
Okay, so they were originally detailed and now they are coming to you permanently.
Correct, effective of the fiscal year.
Okay. Can you give us an update on the assessments for which DHCF contracts with Liberty Health?
I'll send that back to Catherine.
Sure, and while Catherine is walking up, since I think we last spoke in February, Liberty has continued to bring on more nurse staffing, nurse assessors to address the backlogs. I think we had discussed beforehand that we resumed in-person assessments back in November, I think it was. Between returning to in-person and then just some staff turnover at Liberty, they were down a few nurses. They have brought on 4 to 8, or they're coming on board over the next few days or a few weeks, and Catherine can speak to that. But we are monitoring their total request and capacity week over week. And Catherine can
Okay, and Catherine, if in your response, can you, I guess, give an update on the wait time piece? Because when we last talked, it was roughly 60 days. I'm hopeful that that has dropped.
So just the only thing I would add to what Melissa already said, they do have, that the process of onboarding new nurses took some time to get folks get a response on recruitment, but they had 2 new assessors begin this past Monday. They have 2 more starting next Monday. There are, I think, a total of 9 people, inclusive of those 4 in the hiring pipeline along the way somewhere. I think by the end of April, we'll have more than 5 new assessors, which is like another 50 or 60% increase over the FTEs we have assessing right now.
Okay.
I'm sorry, I just wanted to answer the wait time question as well. Melissa mentioned that we track a number of things on a weekly basis. We get a weekly report from Liberty, and there are things that we're looking at ourselves at LTCA. The average time is 28 days. That is higher.
That's a
than-
drop.
That is higher than we would like it to be still. Prior to November 1st, the average was 2 days. So we are aiming to get back to that by sometime this summer. With all these new hires, I think we're in really good shape. It really feels with the new hires that we're in a good position collectively to resume. You know, I think that 2-day turnaround, that was sort of a nationwide best. That's at least what we heard from our stakeholders who operate in multiple jurisdictions. So we're aiming to get back to top of the list.
Okay, so how are we working this out though, as we think about Medicaid redeterminations? Are all patients going to needing recertification going to also have to do, like, are we going to see an influx of assessments?
Not above and beyond what we already have. We have this is another thing that we track on a weekly basis
Okay.
is the request for assessments, only a subset. And it's a pretty small subset. It's really our EPD waiver and nursing facility residents for which their eligibility redetermination requires that they meet the nursing facility level of care and the PACE program, I should say. I'm unused to having a PACE program. It's only a month old. But those individuals will require an assessment. We encourage all of our partners to begin the redetermination process 90 days in advance of the cert date. So month-long wait for an assessment, and that the long-term care application can actually be submitted while they're awaiting the assessment. So we're encouraging all of our partners to maximize the timelines where they can, and that we don't expect the assessments to slow down our redeterminations if we triage things correctly.
Okay, thank you. It would be great if we can get back to our two-day. So we'll follow up on that later this summer to see kind of where things are. I want to talk about home health and home visiting. We heard from several witnesses this morning about the importance of wage increases for direct service providers. And we discussed this a little bit during performance oversight. How does this budget support the wage increase for direct service providers? It doesn't seem as though we have accelerated the plan from before. Are we just going to keep on track with those planned increases across the financial plan?
That is the plan as of the moment. We, given the challenge of, having to close that kind of gap citywide, and given the cost of trying to accelerate what we have proposed in previous budgets, which we believe is an excellent proposal. And given the flexibility that providers have in moving along their range that we have funded, we didn't see the necessity to try to expedite the proposed implementation to get to the range of 525 quicker than that. I mean, FY25 quicker than we ordinarily would.
Okay, but we're going to continue to move forward with the original plan.
That's correct.
Okay.
With the understanding that the original plan, the original plan had us meeting that final number in fiscal year 25, and it will be implemented or ready for January 1, 2024. So in that respect, we may meet that milestone earlier than we originally anticipated, but so a year prior to what we originally anticipated. So the providers will be at that average of 117.6% by January of 2024. Now, for that year-long calendar period from January through December, the providers will still receive that payment, that enhanced payment, through a supplemental payment versus it being built into their rate. Starting sometime after January 2025 is when they will see it built into the rate, which builds on the work that we're doing for the home health rate study and being able to incorporate it as a final piece into the rate instead of a supplemental payment.
Okay.
And I would simply add that when you look at that range, certainly when you get to 25 and more people are funded along that range, you'll have some workers, direct care workers, making over 20-some bucks, or more than $24 an hour, which is, I got to believe, probably will be one of the highest in the country.
Hopefully that helps us recruit some folks, some good people.
Yeah, I don't know that it will. It's a very difficult. The district is in a very very difficult spot when it comes to direct care. The cost of living in the city is obviously extremely high. And, you know, if you come in from Maryland or Virginia, then you have to deal with where you're going to park while you provide care. So it's a challenging job on its face. And then you add the complexity of having to negotiate a commute.
Public transportation is fantastic.
Oh, it is, but if you are working and you're getting off at midnight,
Sure.
then it becomes a problem. So it's I don't think it's just a wage issue, but if it is, you know, by 24, I think we'll be at 2380. And by 20, it's as the upper end of the range.
Right.
And then 25, I think it goes above $24, $25.
Well, I think we can assess at that point. I mean, I with anything, right? Is it, you know, there's this ongoing conversation around teachers in the workforce. Some will say it's pay, some will say it's respect, some will say it's flexibility. Like there are any number of things, but it doesn't mean that I think at the crux of the issue of people feeling like their pay is somewhat near their worth, given the type of work that they do. And again, I think we talked about this at performance, right? If I can go work at Starbucks, where the most stressful part of my day is from 7 to 9 when people are coming in to get, you know, their morning hit and then their afternoon hit, I'm going to choose Starbucks over having to physically lift and do all of those things every time.
Sure.
From a funding standpoint. Sort of adjusting a little bit and talking a little bit about home visiting. We heard from home visiting programs such as the Nurse Family Partnership. They're currently funded through DC Health, the grants and private philanthropy, but their deep desire is that Medicaid cover evidence-based home visiting programs. Where are we in that process?
I'm sure we don't currently have a Medicaid reimbursable service for home visiting nurse programs such as that. Obviously, you know that there is funding through the Department of Health. However, that doesn't preclude Nurse Family Partnership or other providers for engaging with our managed care plans. We do have new value-based purchasing requirements in our contracts. Given the outcomes through their evidence-based research, I think they can certainly make a strong argument with the plans of how they would be able to support and show better outcomes for the women and families they serve. So there's nothing that precludes that. One of the benefits of utilizing managed care is that they do have more flexibility than fee-for-service, if you will, and they can do things through different programs through value-added services or in lieu of services that could support that as well.
I want to talk about mental and behavioral health rates. The mayor announced a $24.4 million enhancement in funding to increase the reimbursement rates for mental and behavioral health service providers. How did DHCF decide to focus on a rate increase for mental and behavioral health services instead of other types of services that we know are chronically underfunded?
Sure. So as you heard this morning from one of the providers, the last rate study or cost study for behavioral health providers, I believe, was conducted around 2017 or 2016. And so unlike other providers like our home health agencies, FQHCs, hospitals as well, there's usually an annual review of their costs, and then the rates are adjusted accordingly to fluctuations and increased costs, et cetera. And that has not happened with our behavioral health service providers. So we have a current rate study underway that kicked off, I believe it's 1 or 2 years ago, to really dig into all of the services provided across the board on both mental health and substance use disorder to meet the concerns that we were having about the adequacy of the rates. So there is that focus right now. It's part of our overall transformation of the behavioral health system that we kicked off with the behavioral health waiver in 2019. And then to expand when we move into carving in the services to the managed care program this October. But given, without rate increases since 2016, 2017 and the demand of services, it made sense to us to embark on that review with the Department of Behavioral Health.
Okay, so the $24.4 million enhancement, is that wholly within the healthcare finance budget, or is some of that also in the DBH budget?
To be perfectly honest, I couldn't get back to the 24.4. So you had a second question that referred to 17.76. I could verify that number, but the 24.4, I could not. So I'd be glad to work with you and your team. The explanation you provided was generally around the rate study and what we did do that would affect mental health rates.
And so right now, one of the things with behavioral health rates, because DBH has the authority for both the services that are funded locally for Medicaid, but also for those services that are provided to district residents outside of Medicaid. So for right now, the Alliance program as well, you'll see the bulk of the local funding is appropriated to the Department of Behavioral Health budget. But then we still in DHCF have a few $1 million specific to mental health rehab services. And then you will see one of the newer items is that we can leverage the home and community-based services American Rescue Plan Act funding that is helping to support some of the provider increases for the behavioral health providers. So it's a combination of funds across both agencies.
Okay, so in the mayor's presentation for the budget, the one that, you know, she's been doing around town, it says 24.4 million to provide increased Medicaid rates for services in the behavioral health sector. And so what you guys are saying, it's not 24, it's 17, or?
No, the 17 I was referring to was a question that you all asked subsequently in your set of questions.
Yeah, I'm not there yet.
So the 24.4, I can work with EOM and make sure we're on the same page about the 24.4.
Or Adrian. Oh, hold on. Can y'all just switch seats real quick? So you gotta make sure you're on camera.
Yes, sorry about that. As you know, DBH will be here tomorrow, but I can assure you that the 24.4 is an enhancement in DBH's budget for FY24.
All right. Great, cool. Okay, so who then is responsible for the fee schedule? Is it you all, or is it DBH, or like who decides?
Medicaid fee schedule, we are responsible.
Yes, and what we do is we tried to align, this goes back to years ago, it was commonplace for district agencies to have fee schedules or the rates that they paid for different services, same as Medicaid, but different pricing. And so over the past several years, like when I first came to the district in 2008, a lot of effort to ensure that we aligned those rates across the board, because it created a situation where providers were more apt to go and have a human care agreement or direct relationship for another agency and receive 100% local funding for services instead of enrolling in the Medicaid program and billing for that Medicaid reimbursable service. So it was more efficient from a fiscal perspective on we get at the 70-30 match. Agencies that are providing local services don't get that. So for the most part, we tried to align the fee schedule with this, why we work so closely with the Department of Behavioral Health, because they have the same services they're paying for people who aren't in the Medicaid program. So it doesn't make sense to have them vary across the board.
Okay, can you provide us with a copy of the fee schedule reflecting the 24 rates?
Yes. Everything, the fee schedule's on, yes, I think we can, it's downloadable, it's available to folks. So yes, we'll pull
If
that
you could
out.
just provide us with
Yeah.
a link.
Yeah, we'll do a
And the
comprehensive-
codes.
Yeah, we'll do the comprehensive, pull it out for you.
Okay,
So,
great. So in terms of the rate increase, and I'll ask Dr. Bazar on this, but you guys are here and you have finance in your name. How many procedure codes are we talking about? Did we increase everything under the services? Or only like a portion or a slither?
some level of detail I don't have off the top of my head, but we can get that for you.
Okay. And on average, let me see, do you happen to know on average what the increase in the rate we're talking about? Like, oh, providers will see a 2% increase. I'm just sort of saying how we quantify this.
Yeah, to my knowledge, we didn't break it down, like how much the actual increase would be provided by provider type. We have a list of services, one that would be added to existing programs and then 2 new services that will be added. We have those priced out across the program. But if you need to see that information as to how much different provider groups would stand to increase, we have to work on that.
I guess part of the thing, and let me tell you why. So some time ago, because time is missing, we had the board of psychology before us, who's testifying. with several board chairs for other boards. And one of the questions I had for the board chair of psychology is, why don't your providers take Medicaid? And he basically said, financially, it doesn't make sense for us because the rates are so low and we can make more in private practice. So if we have a rate increase, it would be nice if we could publicize of like, hey guys, maybe the game in Medicaid has changed when it comes to mental and behavioral health. Come on in out the wind, because one of the things that I hate about our system, or the just sort of the thought, especially when we hear from residents, is I have insurance and that's great, but that doesn't mean that I have access because nobody will take my insurance. So that's where I'm trying to get us to sort of, it's great that we're going to do the increase, but if we're not going to be able to market it to get more providers to sign up to provide services, then what's the point?
Sure. I will say the rate increases we're speaking to right now really focus on mental health rehab and substance use disorder, and not individual clinicians typically. So the individual psychologist will pull that rate. I don't anticipate that rate is changing because it really is focused on those more intensive services. And some of them will be by a 15-minute increment in terms of billing. So, it'll be like a $10 or $15, whereas some is gonna transition from a 15-minute billing increment to a per member per month, more of a payment like that. So across the week, I can't say it's gonna be a 5% increase across all services. We can maybe give an aggregate, but it's going to be different because of the way the rate study is occurring, right?
Yeah, so that would be helpful for us to just sort of have that information. Let me ask you this, are any facilities, because we're talking about substance abuse disorder, are any facility rate increases included in what we did?
What we've done for providers across the board are 2 inflationary increases, one at 3% effective last April, and then a second of 2% or 2 point something that was effective October 1st of 2022, and that was across the board. For SUD residential, I'll have to check if they are included in the rate study. I just want to confirm that.
Okay.
And just for clarity too, for SUD residential, we don't pay the room and board services. We're precluded from that. And that's something that's funded through the DBH budget.
So for SUD residential, healthcare finance is only paying for the treatment portions.
Correct.
But DBH covers the room and board portions.
Correct.
Okay. This is so complicated. Oh, Melissa, so you keep referring back to the rate study. Which rate study are you referring to?
Behavioral health rate study for the mental health rehab service providers and substance use disorder providers.
Which is separate and apart from the other rate studies that are going
It's
on.
not the school-based health, mental health rate study.
Okay.
We have several rates and we have a home health rate study that we're about to endeavor upon as well. Which we do usually, every several years.
Are your rate studies public?
Oh, yeah.
Wonderful. Can
all
we
the
get a copy of the residential rate study that informed? No. Can we get a copy of the rate study that informed the increases that we're currently doing?
The current behavioral health rate study is not complete. We took the information we had at hand to inform the FY24 rates. So that, and then just for your awareness, part of a rate study is going out and surveying all the providers.
Right.
So they've been participatory in that as well. In addition to surveys, it includes provider focus groups. So it is like a collaborative open process.
No, I understand to that point, but the fact that, and this is a question that or a conversation we had with Dr. Bazaran about the school-based one, where they were having issues with providers actually responding.
Yes.
So when you say that we use partial data essentially to inform FY24, what was the N size? What are we talking about here?
What's the N size?
In terms of people who had sample size,
Oh, okay.
who had responded?
I don't know off the top of my head, but we had several providers respond.
Okay. So to any providers who are listening, it would behoove you to participate and respond to the surveys, because if the more active people are the ones who are the only ones presenting their information, that is what the basis is going to be, where your costs might be different. So everybody got to play in the sandbox.
Very important. And yes, and just also for your awareness in those monthly behavioral health provider meetings, that's when We brought in the consultants who are conducting the rate study to talk to providers. Here's the number if you don't understand how to complete the survey. We can do a one-on-one with you to understand how to complete the survey. And then there's a lot of individual follow-up. Have you completed the survey? Would you please complete the survey? So it is, you know, the data in, and we appreciate that's on top of very busy work that folks are already engaged in.
I know, but if you want to get paid for that beautiful work,
Exactly.
sometimes you just have to do some administrative work
Yes.
on top of that. Okay, so you said that you're about to launch a rate study for which group?
Home health agency.
Home health. Okay, are there any other rate studies that are coming forth?
We're doing an overall study on assisted living services that's more comprehensive than just rate, but also looking at what's the demand or the need or expectations for beneficiaries related to assisted living. And Catherine's yelling at me from across the room for something I've left out.
I just wanted to acknowledge one other thing, which is that we've incorporated waiver case management into the home health rate study as well. So we pay a per member per month rate to our fee-for-service EPD waiver case managers to provide comprehensive case management. And their the RFP that was recently published incorporates a study of their rate methodology as well.
Okay, there was. When's the last time we did rate studying around facilities? So, sorry, these are all the things that are running together. But last week at the DBH, part 1, there was a witness who testified. I want to say it was Woodley House. I see her face. Can't remember. And she said, we're only receiving $65 a day, whereas St. Elizabeth's cost is like $2,000 a day. Now, that could be completely separate and apart, but I have to imagine that you all are involved in some of these conversations, even when it's dealing with DBH CBO providers.
For CRFs, which I think Woodley House is a certified residential facility, we are not.
Okay.
There's no Medicaid funding. We don't, so that's like a room and board cost. My apologies.
That's right. Okay. So for, I guess,
So for like hospitals, we do an annual cost report and we review their cost.
Right.
So it's slightly different than a rate study, but it's, you get a cost report, you do the auditing, you look and make adjustments to the rates. Nursing facilities, I can't remember, we call that rebasing. It's a different terminology, but you based on audits as well. And then that's when we'll take that deeper dive. Is the way our reimbursement methodology configured, responsive to the cost and the experience that the providers are having. And so then we do that and then we come up with a new methodology.
So in general, Medicaid does not cover the quote unquote room and board.
No, for nursing facilities, yes. I know, but generally, no. Because, you know, nursing facility, and first of all, this is just nationally, we're not making this up.
No,
so you know,
yeah.
It's not our own struggle here. But for nursing facilities, that's considered essentially like a full medical environment. So we are able to reimburse for those costs. But generally, it's a very hard line on no payment for room and board. What we've seen different in the past few months that you may have seen in the news is the recent waiver approvals from CMS in states like California and Arizona and maybe Oregon. I can't remember if it's a couple southern states as well, where they are allowing some potential like up to 6 months of rental costs or support there. But it's largely, that is a very strong line between what Medicaid can pay for and cannot.
Okay. So, and this will be my last little section and we'll take a break. We have heard from lots of hospitals, and I brought this up during the performance, right? They have individuals who are, you know, at the facility who no longer need acute care, but they don't have any place for them to discharge to. There's nothing in this budget that I can turn to say, and this is how we're addressing that. And it is a growing issue of people who are there for 300+ days. UMC testified last week. They don't have anyone that long, but they certainly have individuals there for whom they no longer need care from the hospital, but they don't have any other place for them to discharge to. But I guess like, I want to understand what's our plan here to sort of address that, because if we're going to talk from a fairness standpoint, I don't think it's fair for the hospitals to have to do that. And I know that that's somebody who's taking a bed that could actually be used for someone who needs that care.
Yeah, no, Melissa's been working with some of the hospitals on trying to get people out who have these exceptionally long stays where they're not getting medical care. The problem is multifaceted. There's no easy exit to a nursing home because they probably don't meet a nursing home level of care requirement that the federal government would pay for 70% of the cost. And the nursing homes are not going to take them if they can't get federal reimbursement. And if they do take them and get stuck with them, then they know they're going to be on their own. In some cases, the persons who are in the hospitals don't want to leave. And they don't have, if they need a guardian, or particularly if they are, say in the Alliance program, there's no long-term care basis or program to step them down to. We don't pay for long-term care. Long-term plan, we still have to figure it out. It's a very complicated issue. Melissa can tell you about some of her discussions with the hospitals and some of the things she tries to do, but that's generally on a one-off basis. We don't have a systematic approach to resolving this yet.
Okay. I mean, we could talk about that offline. I think we did a unscientific survey of the hospitals, and a couple of them have said we've started to pay out of pocket to step people down, because it is cheaper for us to do that than it is for them to take a room that we need for someone else. And so I think overall, we kind of just have to think about that. Obviously, I know like the Alliance program was never conceived to provide that additional piece, but the longer that we have individuals who are here and who have established residency and are aging, I think we have to figure out what happens here. Because I think this is a gap in our system of care. And not just for Alliance, but even for individuals who are on that cusp of, they don't qualify for Medicaid, but they still can't afford to pay the full private costs of nursing home, assisted living facility, private care, et cetera. So I'd love to work with you guys on that. Awesome. All right. So we've been going for a little bit here. Why don't we take a 10-minute break, and then what's that?
I thought we were done.
No, sir, we haven't even talked about the hospital. We got to talk about Medicaid certifications and the Budget Support Act. Don't think we're not coming there. So literally, I like 4 more topics to go.
Sure, no problem.
In my head, in my mind, we'll be out of here by 5 o'clock. All right, 10-minute break. Okay, we are gonna restart. But okay. A little bit more to get through and then we'll be done. Not really, we'll follow up because we still have several more weeks of this process. And you know what I tell people about the healthcare finance budget, and I provide them with a number of what we're talking about, not with just local, but with federal, their eyes just get really big. And I'm like, yes, we should spend more than 30 minutes or an hour discussing your budget because it is such a huge chunk of what we're spending locally. Frankly, $986 million in local dollars it rivals the schools situation. So anywho, all right, let's talk Medicaid and Alliance recertification. I'm gonna start with Alliance. So we learned from performance oversight, we had some hiccups in the process. Do we have any updated wait times in terms of Alliance certifications?
I think Eugene's going to join us, but for current applications, I believe we are timely.
Yeah, so for renewals and applications that are coming in now, folks should not expect to wait more than 30 days. There are some applications that came in a while ago that are a little bit stickier. I think because they came in on old application forms that DHS is working through. But as of March 27th, the entirety of the backlog, so that's applications as well as renewals that are outstanding over 30 days, is about 360 applications and about 30 renewals. So just a little under 400 total.
All right, so we're making progress.
That is progress.
Where we were in February. Are there any things that we're learning from the Alliance process that we're going to then apply to when we do Medicaid?
It's the Medicaid has a very efficient passive renewal process that, you know, you don't basically have to do anything to get renewed. But there are obviously folks who are in long-term care and new applicants will have to go through a process somewhat analogous to the Alliance, but maybe not as much. I guess the only thing that I can think of is more internal, you know, how we use staff and how staff interact with DCAS. I don't know.
Well, that's what I'm talking about. I'm talking more of the internal pieces, right? Are we going to change how we do outreach? Are we going to change how the form? I don't know. Are we changing communication because of the feedback, right? I think unfortunately, because the Alliance folks went first, it's a good guinea pig of whether or not our processes internally are working or not.
Sure. Yes, we have, we're doing things a little bit differently or hopefully more improved. First, I would say, for me, one of the biggest, quickest lessons learned when we restarted Alliance was that we heard first and foremost really from providers who are working with Alliance beneficiaries about changes or loss in their coverage. So I think we've been more specific about our provider engagement in terms of having specific briefings for pharmacies, specific briefings for our behavioral health providers, specific briefings with our federally qualified health centers, and those groups that have that more kind of routine or consistent touch base with an individual. Overall, we have a complete communications outreach strategy that is different from what we embarked on earlier with the Alliance program. So we do have a communications toolkit that has since been issued with guidance to stakeholders on what kind of messaging they can be providing to beneficiaries or residents. And that's really, you know, underpinned by the belief that if we can amplify the message, then people will hear it. If they see it, then they'll know it and they'll know I've seen this here, here, and here. It seems legitimate and it's something that I need to do. I also think, you know, if you haven't already, there are bus ads now running. We have radio spots that are coming live soon or may already be on air. We like the Alliance program. One thing that we started a few months after the Alliance renewals was a biweekly stakeholder community meeting to establish a routine cadence so folks knew where and when they can see us and ask questions or raise issues. We have now transitioned that into a Medicaid renewal. We'll really take all questions, but that kicked off last Wednesday, the 29th. And we found that to be very effective because it's one of those kinds of things of like, you know, We can only hear and see so much, but when we hear our partners or beneficiaries come to the phone and say, I had this experience, and you hear 2, 3, 4 more people or organizations say the same thing, then that's usually kind of like the red flag of what we may have a systemic issue. And then we can start addressing those. And then also any kind of information that is out there that's not accurate, we can correct as soon as possible.
Okay, so we started this conversation with the Health Benefit Exchange Authority, sort of talking about the handoff processes. And they said, we'll receive a list monthly, in sort of the same vein, I guess, that we have currently going on. One of the things that I'm trying to figure out, though, is what are the order of operations? Like, are y'all going in alpha order? Are you going in random sample order, across the city order? Who goes first?
Sure, it's a combination. It's not alphabetical. Random may feel best, but still not entirely accurate. So when you enroll in the Medicaid program or the Alliance program, you have a date your enrollment is effective.
Yes.
A year from that is when your enrollment ends and you recertify. So we are trying to maintain that annual recertification date for beneficiaries as they expect. Now, there will be some changes to that. So we know we have some folks who are most likely no longer eligible, and we've shifted them in months 3 through 8 for several reasons that I'm happy to go into. And then we have a couple other adjustments that we've made, either because there's a federal requirement that they are asking that we recertify no more than 1/9 of our program in any 1 month. So we've had to make some adjustments to spread.
The feds have asked that.
Yes, they have. And so we have a distribution plan that we've published on our website. We've submitted to the federal government to show that. So, but for the most part, our core principle is to stick with the recertification date that people anticipate and keep them on their regular schedule, if you will.
Okay, so for individuals who you already have their information because they're engaged on DCAS or other systems that you can sort of pull income eligibility, I guess we
Same thing.
consider those the automatic
So
folks.
those are our passive renewal or ex parte, and I'll
Right.
use both because you hear both. We will still do the same thing in terms of keeping them on their annual recertification date. So we had about 12,000 individuals that we just ran through the passive renewal process. Over half of those were passively renewed. They're with folks with coverage ending end of May or end of June. And so that group of folks who passively renewed, they're going to get a notice in the mail that says, congratulations, your coverage has been renewed. Your coverage remains. For those folks who we cannot passively renew, then they get their 60 or 90-day notice that says, hi, in 60 days, your Medicaid coverage is in, please renew as soon as possible.
Okay.
And then at 30 days prior to the end of their coverage period, they'll get a notice that their coverage is about to end. So again, you're going to lose your coverage in 30 days. Please recertify ASAP. All those notices, just for your awareness, are on our website now. We've done sample notices. I think there's probably 10 or more to hit every population and variants that we have.
Okay. So
we bucket kind of if we're talking about Medicaid eligibility for purposes of renewals, we talk about them in 2 big buckets: MAGI, non-MAGI, modified adjusted gross income, non-modified adjusted gross income. Mostly the MAGI folks are going to be your parents, children under 21, really any adults up to 65. That's the group that's most likely we can passive renew. In fact, we have a much limited option on the non-MAGI side. And that for the district, we're anticipating about an overall 77% passive renewal rate, which is pretty high. Under normal circumstances, we're closer to 82%, but just with the increases in enrollment, et cetera. So those are the folks who don't have to do anything. For the non-MAGI, it's a little bit more complicated for a number of reasons. One of the issues for us is just the change and implementation of the new DCAS system. So now we have to have a certain baseline amount of information for that system, for that rules-based engine we talked about earlier, that we did not have from their information from our legacy system. So we have to get that from them. But we've made some changes per our discussions with the federal government to match people with their SNAP income or assets. So we have a better chance of being able to passively renew some of the non-MAGI folks.
Okay, what's the appeal process look like? Is it appeal in-house or?
It's appealed to through
Office of Administrative Hearings. Okay, so what is your agreement with them? Like, is it an MOU?
Our agreement, I believe, and someone may want to confirm, but we have our MOU with the Department of Human Services, ESA, and they actually handle the administrative hearings typically for our programs. We delegate that eligibility redetermination component to ESA. And so they handle the hearings typically. When it comes to
Do we believe they have enough people? Because OAH in the
Yeah.
past has had some challenges in terms of wait time. And so I understand that we are adding, this is a month by month situation, right? So we're not dumping it all at the same time. But in the same vein that we gave the DMV more adjudicators because we were adding more traffic cameras, do we need to give OAH more staff personnel because we anticipate more appeals?
I would have to get back to you on that one. I don't know. I can't quantify.
Our counsel's over there. She deals
Cheryl,
with
ma'am.
OAH all the time.
One of the things I will say where we see a lot of administrative hearings comes to disagreements about that level of care assessment that we spoke about, like what Liberty does.
Yeah.
It has been common past practice for some of our case managers just to automatically file an appeal just to stay services. And we are working, yes, that is a common practice. And I would say there's a lot of work that's been done through Catherine's shop to really encourage folks to remind them, like, please don't just file an appeal to file one. Let's let the process work, get the assessment. They may be assessed the same hours, they may not, and let us go down that pathway. So there's been a lot of education in their routine provider meetings to be clear on what our expectations are for those processes.
Good morning or good afternoon. I'm Cheryl Johnson. I'm the General Counsel for the Department of Healthcare Finance. I meet quarterly with the office, with the Chief Medicaid Judge. In fact, we're meeting later this month we track everything on a calendar year consistent with how OAH. For the calendar year ending in 22, we had less than 275 appeals, and that includes provider appeals as well as beneficiaries.
Right.
For this year, 2023 calendar year, we probably have around 75 because of the PHE. And we have and those are just status conferences. We have very, very, very few evidentiary hearings.
Right. But you're saying that's because of the PHE, but with no PHE, are we about to see
Only OAH can tell us if they need more help. They've been conducting the status conferences fairly quickly.
Okay.
And so within the time frames. And so if they decide if there's more, that they need more help, then I would assume that they would go through their normal budgeting process or assign some other judges from the other, we're part of public benefits. And so from some of the other programs, but it's up to them. And I've not had that concern thus far, but they would have to hire more staff or however through their normal processes.
We met with them, I think, a month or 2 months ago, more focused on long-term services and supports and the upcoming changes, but we certainly covered the PHE renewal process. This was after we got notice that renewals would continue. So they're certainly apprised of what is to come.
Okay. All right. I'm over my time. We've been joined by Councilmember Nadeau. Councilmember Nadeau, we're on 10-minute rounds. So you can welcome.
Thank you, Madam Chair. And thank you, Director and Deputy Mayor. So I want to ask first some healthcare finance questions. The latest DOH perinatal health reports show that Black women, particularly those in wards 7 and 8, where there's the highest percentage of Medicaid funded births, continue to experience adverse birth outcomes. Many states are incorporating evidence-based home visiting into their Medicaid programs, as these programs have track record of keeping women with underlying chronic conditions, trauma and mental health, and helping them and getting better outcomes. Is Department of Healthcare Finance working to extend Medicaid coverage for evidence-based home visiting programs?
Good afternoon. At this time, we are not. However, some of our managed care plans may already connect with some of the home visiting programs. And as we discussed earlier too, that's certainly an option for managed care plans through some flexibilities they have in terms of in lieu of services and value added services. With the new value-based purchasing requirements we have in our contracts, I think the programs like the Nurse Family Partnership and other providers are probably well positioned to have some strategic and supportive conversations with our plans about the work that they can do to improve the outcomes for moms and babies.
So forgive me for not knowing, but in what you've described, that flexibility and the value-based programs, would we be getting the Medicaid reimbursement rate for those programs?
For value add services that when a managed care plan provides services through what we call the value added services, that's actually outside of what the department pays. So that's at the cost of the managed care plan. And for lieu of services, it usually they are providing a service that they believe better serves or provides a better outcome than a regularly covered service. So typically, they can use the money they receive from DHCF for those services. So in that case, yes, they will get some federal support for those.
And would that be the same federal support that they would get if it was covered under Medicaid with the high match rate that we have?
What we pay, so it's our payment to the managed care organizations, and that does get the 70% federal match for what we pay. And then, the managed care organizations are just going to pay whatever rate they set, but it's based on the 70-30 funding from us.
What would the agency's posture be on a requirement for covering home visiting services, such as the services provided by Nurse Family Partnership under Medicaid?
Would depend greatly on, given the budget times we're in, on what the cost would be, if it was separate and apart from what MCOs were already doing. I can't speak to the level of services that MCOs may be providing, but if you wanted a mandate that the health plans provide these services, they will surely argue that should be included in their cost experience. And then we'd have to figure out with our actuary and our budget director what the cost would be before we could opine on whether or not it's something we could do.
Well, let me put it a different way. So right now we have a number of evidence-based a number of evidence-based home visiting programs that we are paying local dollars for. Some of them are under McV. But Nurse Family Partnership, we're paying local dollars for already. We could expand that program if we made it part of our Medicaid program. And I don't need to do the ratio. You already know how to do that math, but that's what I'm getting at here is whether the agency would be interested in that.
So you mean for 24?
In general?
In general, it would have to go through the agency's budget development formulation process with the mayor's office. We couldn't, as a general rule, say, okay, we would be willing to take that on for this budget because we'd be negotiating against the mayor's budget. But we could certainly say that if this is something that was of interest, that we could include it in the budget formulation process for fiscal year 25, and that formulation process begins roughly in September or October.
Wouldn't we need to do a state plan amendment?
If we don't cover the service and you wanted to be a part of the MCO's experience, yes, you'd have to do a state plan amendment.
How long does it take to do that normally?
Well, it depends on CMS, but they will generally make the amendment effective retroactively back to the quarter in which it was submitted. 6 to 9 months is generally what we see.
Thank you. I saw that the Department of Healthcare Finance received a little more than $99 million in federal ARPA funds to enhance, expand, and support home and community-based services for seniors and people with disabilities. What have those funds been spent on to date, and what projects do you intend to fund with the remaining funds?
Yes, for the home and community-based services ARPA funding to date, we have spent the majority of the funding on recruitment and retention and vaccine-related bonuses for direct service providers through home health agencies and other Medicaid providers. We also have implemented our digital health technical assistance program to support the same cohort of providers becoming more interoperable, so implementing electronic health records and participating in our health information exchange. We have one rate study that is in procurement now for a vendor to conduct the rate study that's also supported by ARPA funds. We have funded behavioral health providers to inflationary rate increases through ARPA funding and are bringing on some staff to augment our program integrity activities as we have expanded the funding for home and community-based services, to do some kind of quality, not assurance, but improved quality and oversight of high-risk beneficiaries and who are mostly elderly and with disabilities, to try to keep folks out of hospitals when not letting if they're at high risk for a particular health issue that could push them into the hospital and then start one kind of an unfortunate path that we sometimes see, that once folks go into the hospital, then they go to a nursing facility and don't return to the community as quickly as they would like. So that's something else that we're doing. And then with that, I'll turn over to James or Darren to speak about anything I may have missed.
No, I think you covered most of it, Melissa. The only thing I would add, I think you asked what was the amount we spent so far. And so, since fiscal year to date, we spent 65.3 million.
Thank you. I'm trying to get out of here for Passover, so, okay.
I would add to that, we spent 9.4 million in fiscal year 22 from these funds as well.
Thank you very much. Okay, so I'm going to try to plow through a couple more questions and then give the gavel back because I'm trying to get out of here for Passover. But
if you need additional time to finish up, that's fine.
Thank you, Chair. Okay, so we've talked in the past about the shortage of direct care workers, and we've worked together on increasing wages. We've also heard, I'm sure you've heard, that raising the average wage to $18.15 is insufficient to attract workers to these essential jobs. And there's a lot of concerns right now. Is DHCF willing to consider using any additional ARPA funding to increase the wages for these workers?
The challenge with that is it has out year costs. This is not, ARPA funding is one time. And once that funding ends, the wages are already set at a higher rate than we would have funded with pure local dollars. And as a result, it wouldn't be sustainable in the current financial plan without some major adjustment that we don't have the authority to make.
Any other ideas about how to get that wage up higher so we're retaining and recruiting new workers?
Not in this particular budget. It would have to, if there was a determination that the wage, the wage scheme that we have in place is not sufficient, then if that was a determination that was agreed to on both the executive and the legislative side, then it would have to be factored into the next budget and then rolled into the remaining years of the financial plan. Those adjustments, we have what we think is a pretty robust a wage scheme that will get you over almost almost near $24 an hour at the top end of the scale next year, and I think over 25 in fiscal year 25. Now that is the top of a range for more experienced workers, and it feeds into the average of 117.6% of the living wage. So the challenge in trying to make that to increase that number, given the local cost and the fact that it has to be sustainable across the 6-year plan, is one that can only be wrestled with doing budget formulation on the executive side.
Okay, we'll keep talking. I know it's a tough budget year and it's not easy to have these conversations. We've been talking for a while about this workforce and I think we're still not quite there yet, but okay. So do you happen to have any insights into the final report that's supposed to be coming out for the Mayor's Healthcare Workforce Task Force, when that's coming?
The one from DOH or the Mayor's,
I think you were on this one.
Yes, they had a Dr. Lewis has a meeting scheduled where I think we're supposed to get the final report. So I would assume, I don't have the date in front of me, but that will be sooner rather than later. The draft has been submitted, but it has to be finalized. So we will, given that we have the draft, I suspect that we'll have a final report certainly before the summer.
Do you have any indication that any of the recommendations in it are being implemented in FY24 budget?
There are a couple of, the biggest issue with workforce, there are a couple of issues. One is all the district's credentialing requirements. Too expansive.
Agreed.
And so that's one thing we're looking at. And the budget implications of changing the credentialing requirements are not that substantial. The other issue is specifically, should we be a part of the National Nurse Compact? That also has some budget implications because that means people could, register to be to provide nursing services in the district without paying DC Health any money. That has an impact, but those fiscal impacts are negligible. The larger question about those is just a good policy position. We lean to the view that credentialing needs to be examined, and we certainly should be a part of the Nurse Compact. At the end of the day, we rely on DC Health for their guidance. We have been in discussions with DCHA along with DC Health. We think that we are all of the same mind on this, so I think you're going to see some movement, in the very near future, without major budget implications.
Okay. All right. Well, we're eager to see it, so we'll be waiting with bated breath.
Absolutely.
I know that I have one last question for you. I know my colleagues asked you a lot about encampments earlier, so I really don't want to be repetitive just because I came late to the party. So let me focus in on the one related to my new committee. How does DMHHS work with the Department of Public Works on its encampment clearing efforts?
At my level, what we do is we inform our team on the ground that an encampment site will be closed. Then we get a date for the closure, and then we start from that date. We work backwards to figure out all the services that have to be provided to get us to that date in a way that's reasonable. And then our team on the ground engages the sister agencies who are involved and help us. And we ask that they contribute their services. If it's not a closure, but just a routine matter of an encampment cleaning or bulk trash pickup, I believe those are done as a part of a contract that we have with DPW. But as far as the closures, I'd have to talk to Jamal, who is not here, as to whether or not we don't have a line item in DHCF's budget that says we're going to buy these services from sister agencies to execute X number of closures in the fiscal year. We rely on, the coordination and relationships that we have, and we've not had a problem to date where agencies like DPW say, hey, we don't have the resources to help you with this one. That just has not happened. So, I think the larger question is there a way to identify, I think what you're getting at is a way to identify the cost of a closure. I think it's pretty easy to do. We simply have to get, the agencies that are involved to estimate, what it was that they spent on providing services to my office to execute closures. Now, it will be an estimate because they don't go out and hire additional people every time we do a closure. It's a matter of them estimating what the FTE time is and then putting a cost on that. But to be clear, and this is one of the things that comes with the way the government funds FTEs, if that FTE is a part of your labor force, the money is already allocated. So then they just have to report, if they're going to estimate, okay, we spent X time on closures, X time doing other DPW work, then that's an estimate of how much of that dollars, how much of the FTE was spent doing something else other than.
Yeah, I'm going to interrupt you. I'm going to interrupt you because I follow where you're going with that. And I'll just say this. The Department of Public Works is losing 60 FTEs from the solid waste management team. And I think diverting their time and resources to encampment cleanups is going to be a big drain on their delivery of services. The director has already affirmed that these budget cuts will have an incredible impact to the delivery of services to district residents. And so I'm very concerned about the frequency of clearings that DPW is asked to engage on. So I think we're going to have to figure out how to address that in a budget shortfall. And if this is a core function of DMHHS, there should be funds set aside for it for these agencies.
Well, we don't, obviously there are not funds set aside for it, but I can say, given the priority to having encampments that are not, do not put the residents in danger of health and biohazard problems, that one can easily crosswalk to, this is a function that DPW should be involved in because it's a cleanup function that, and without their efforts, you could have a serious health and safety problem.
Sure, but there should be a line item in the budget for it. So it's not
Well,
just free money,
But it's in DH, I guess my point is, it's in DPW's budget. If they tell us at some point, hey, the money we have allocated for this, or the FTE time that we use for this is not sufficient given what you're asking for, then we would go to Jenny and say, look, we're using DPD at a level that they didn't contemplate doing budget development, and we need to give them some more money. I think we have.
that time might be near. That time might be near.
We have increased the trash pickup contract a couple of times. Since I've been deputy mayor, we've increased it a couple of times, but that's the way it would typically work. And we don't have a problem with that. If we call them and say, we need you to do this, that we ain't got the money, then we go to Jenny and say, look, we need some money because we have to execute this because it is a health and safety issue that cannot be left unaddressed. And she will give us the money.
Okay, well, yeah, we're done. Thank you very much. Appreciate you, Madam Chair.
Councilmember Nadeau, before you go, so a couple of weeks ago, before the budget came out, I sent a letter to the city administrator asking about a status update for several different reports. Long-term care facilities and services report, the healthcare workforce task force report and recommendations, and the DC Calling All Sectors Initiative report. They report DC Health is conducting an internal review of these draft reports. The Office of the Healthcare Ombudsman report from FY21 and FY22, May 2023. The Department of Behavioral Health Ombudsman report. We should expect that one in May 2023. We're going to be doing a lot of reading this summer. The Food Policy Council report, May 2023. The Flood Task Force report, May 2023. The Maternal Mortality Review Committee report, May 2023. So let's see where we are in May. But that also means, Deputy Mayor, you have been doing some reading yourself.
Absolutely.
Thank you, Madam Chair. Thank you, Deputy Mayor.
Thank you, Councilmember.
See you next time.
Okay, so back to recertifications. Healthcare Finance reported a projected, oh, I'm sorry, hold on one second. Is Councilmember Parker here? Okay, great, okay. All right. Healthcare Finance reported a projected $12.8 million surplus through the first quarter of FY 2023 for Alliance provider payments. What's causing this projected surplus?
I'll let Darren give you the specifics, but it's just an enrollment decline, I suspect.
Yes, the director is correct. The actual enrollment in the Alliance in FY 23 to date has been lower than what we projected when we formulated the budget.
Okay, so does the $10 million proposed reduction for FY 24 reflect this updated knowledge of enrollment and utilization?
I would say yes. We work with our partners on the Division of Analytics and Policy Research on their enrollment projections. And though my office doesn't actually do the enrollment projections, it's it's based on the most recent actual experience they have to date. Looking at historical trends and also known policy changes like restarting renewals, et
Okay.
cetera. And so we use that update to formulate the 24 budget for Alliance. We used that updated enrollment projection. And then we also, because the Alliance is a managed care program, we use the latest rates from the actuaries.
Okay, thank you. Let's talk hospitals. I first want to talk about Cedar Hill. Like I said earlier, Ben, welcome to the table. I mentioned earlier, I had an opportunity to go out there. We had a great presentation, so I'm not going to rehash some of the conversations that we had. But as you likely saw, I joined several of my colleagues on a letter to the executive inquiring about the status of the microgrid project that will be on the parking garage, I want to say. There was a $20 million grant from FEMA to design and construct the microgrid. But my understanding is that the contract to manage this project has been stuck under DGS review for the past 5 months. So where are we with that process?
Thank you, council member, for the question. So the Department of General Services, as you stated, is leading that procurement process. So what I'm going to focus on is how the grid is integrated and impacts the hospital. The hospital has been constructed with the ability to connect to a grid, whether that grid happens on day one of the hospital opening or another day in the future. So there was a question in the letter as to whether or not the grid construction needed to align with the hospital. It does not. We have already made the necessary infrastructure investments in the hospital to ensure that a grid can be connected to it later.
Okay, and so in the presentation that we had on site, there was a $4.7 million expenditure for the microgrid included in the Cedar Hill budget. How does that tie into the overall 20 million amount, or is the overall amount 24 and the 4.7 million is the local portion and FEMA will carry the bulk of the rest?
That's a good question. So the $4.7 million that was presented to you includes 2 investments. One for $1.7 million is to install solar panels on top of the garage. Those funds are ARPA funds from the Department of Energy and Environment. $3 million, which will come from the federal grant if the project proceeds, is to make the investments to the hospital to make it grid ready. So in total, all of the 4.7 is federal. 3 of it is being implemented in advance of the overall grid project because you cannot have a successful grid, viable grid, without having the hospital be a part of it, just because it's such a big user of power. That makes sense.
Yes. What does give me pause is you saying if the project proceeds.
Well, I mean, if the project proceeds is just the project, in my understanding, DGS will have more insight into this, is that there are a bunch of issues that the Public Service Commission has to opine on before they can proceed any further.
Okay, so there are things that the Public Service Commission needs to opine on before DGS can move forward, yes?
Yeah, it's part of the overall complexity of the grid. It has to do with the alignment of the rules and regulations around grids in the district.
Okay. All right, well, we'll look forward to a response to that letter for all of my colleagues on that. I want to follow up about the 250,000 for training for UMC staff to prepare to apply for jobs at Cedar Hill. When UMC testified last week, they said we are beginning the conversations around what's going to happen. But I guess my question from a financial standpoint is, when do those financial transfers take place?
The 250,000 will be an MOU from DCF to UMC. That MOU is drafted and will be signed in the coming weeks.
Okay, so it's budgeted in FY23, not
Yes,
24. Okay.
correct. Yeah.
All right. Okay, let's talk about the other hospitals in terms of the Budget Support Act. So you presented a little bit about this, Director, in your testimony. And just for clarity for folks who don't necessarily have the text in front of you, for outpatient, MCOs can pay up to 110% of fee-for-service rates. While for inpatient, it says it's limited to the rates paid on March 31st, 2023. Is that dollar amount rates or the percent of fee-for-service that is fixed?
So Joe Brennan, actuary, DHCF. So it would be the percentage in the of the hospital negotiated contract with the managed care organizations.
Okay, so why is outpatient set at 110% while inpatient is based on a date certain?
Well, so when we look at FY24.
You just lean in a little bit more.
Sure.
There we go. We can hear you now.
I usually try to talk loud, so I apologize for that. So when we look at the different dates for inpatient, we're basically keeping those contracts at the same level that they have been. And for our capitation rate agreements, those contract levels have stayed the same in FY23 and FY20 and projected for FY24. So there is no kind of need to cap inpatient, but in capping outpatient, you want to realize those savings. So that's why you don't want it basically shifted from outpatient to inpatient.
Okay. Okay, I think I understand that in theory. The FIS that we got from the Office of the Chief Financial Officer states that the maximum is set at 110% of fee-for-service for both outpatient and inpatient. You all are saying that's not the case.
No. We can follow up, but I think the inpatient part of that reference may just be an error.
Okay. Just want to be.
Yeah, inpatient rates are capped, but I don't know if it's 110. I don't know if that cap turns into 110%.
Okay, we just want to make
Yeah,
sure.
yeah.
So this $11.3 million savings to the DC government is an overall cut of a roughly $37.7 million to DC hospitals. If we think about it in terms of what the federal match is. Are you concerned at all about the effect of such a cut in payment as it relates to patient care?
I am not, for several reasons. One is we're still paying them above cost. And I think I think Medicaid has met its burden to be fair to providers. If at the very least, we are paying them above cost. And if we're paying you above cost, there's no reason that should impact the quality of care that you're providing to a Medicaid beneficiary. And you know, I will say this, not because we desire to go back to the old days, but we pay some of the highest rates in the country for our Medicaid beneficiaries. Hospitals have historically provided services to Medicaid beneficiaries at significantly less than what we pay now. When I got here, the inpatient rate was like 77% of cost. And they have been living with that for a while. And we were DHCF, this agency we spearheaded efforts to get it up. And so one way, because the hospital said they wanted more money, and so we negotiated the use of a provider tax, which is it's a small assessment on the hospitals, but it helped us get to roughly 98% of cost. We didn't want to go to 100 because we needed the room. Or error, because you don't want to go over the payment ceiling. So for years they were delivering services at 77% and less in some years. So no, I'm not concerned about that.
Understand that. So what I was talking to Dr. Newman earlier, and I asked the question around, are you considered a specialty hospital for the purposes of this? And he said they are not.
Correct.
However, when we look at the makeup of hospitals that we have in the district, their patient population is very different than a Washington Hospital Center or Sibley or Georgetown
That's correct.
MedStar. So are we concerned in terms of the impact it might have on pediatric services around like the specialty care that Children's offers from a surgery and treatment standpoint?
No, that's why we on the fee-for-service side, we use a policy adjuster, pediatric policy adjuster that gives them a kicker for the level of acuity of the population that they serve, that the impact of that pediatric policy adjuster is incorporated into the cap rates that we're establishing for fiscal year 24.
Okay. So what you're saying is in terms of the cap rate, well, hold on, let me go back to the chart that you guys.
Here, you pull that chart up. Can you pull that chart up on slide 16? Oh, okay.
Oh, okay.
Oh, yeah, I have my sheet.
Well, I don't actually think.
So, and to go to slide, I think it's slide 16.
The sort of problem that we have on this side is the presentation that you sent us was the presentation that you did to the hospital association, not the presentation that you actually
Okay.
did.
See what that- But
Oh, thank you. Yes. This
Mhm.
chart.
yes,
Sorry, public, you can't see it, but nonetheless, it exists.
he has it. He can pull it up. But you can go ahead, yeah.
What's that? Oh, hold it up. Oh, they can.
Oh, she's gonna pull it up. She's gonna pull it up.
Oh, she's gonna pull it up. Okay, great. All right, so. This chart that we're looking at is the FY 23 projected outpatient.
Correct.
I guess the question that I have is. Are you saying that hospitals were expecting without the cap that they would just be a linear increase?
I can't speak for what they were expecting. I can only say that when you look at this data, if you look at that, if you look under the bar that says 100, under the figure that says 110%. If you look at the cost per visit, which is the blue bar, that cost per visit, $754. Now, look at the allowed cost per visit. This is what we calculate as the amount that we will allow the MCOs in their negotiations. It's $832. At that level, at 100% of contracting, MCO allowed, children's would be getting about 105% of their costs. Now, if you go over to the next bar, next two bars, and say, what would it look like if we allowed the MCOs to contract at 120% of cost, which was the initial projection for fiscal year 24.
You mean 132?
No, under the bottom, look on the
Oh,
bottom.
I see.
So
Okay.
if we allow them to contract, and Joe, if I said something wrong, you clean it up.
No, you're good.
If we allow them to contract at the projected rate for fiscal year 24, before we came in and made adjustments, the projected outpatient rate will go to 132% of cost. That's a lot of money. And so we said, go to the next set of bars. What would happen if we cap the MCOs at 110% max, which is what we are now proposing, and the observed rate is 121% on average, which is $11.3 million in savings. So when we allow 110%, when you do the math, and you can talk to the actuary, the hospitals appear to be doing just fine.
Yeah. So for those who can't see the chart, we'll get the chart online at, oh, maybe it's coming.
There
There
it
it is. All right, wonderful. Now everybody can see what we're talking about here. So what you're saying is that even under the proposed FY 24 projections, the cost per visit will be $754 per $754, but that the hospitals would still be allowed, or the MCOs would still be allowed to pay up to $915.
That's correct.
If we had no cap, it would be $998, which is roughly, I'm not really great at math, but I guess we're talking about a $60 something difference.
Yep.
I don't know. Darren, am I? Okay.
Yeah.
Great. That's why I had a calculator in college.
Mhm.
Okay. So let me ask this question, and this, I guess, is a little bit more basic or not, but how do you all decide who goes MCO versus who goes fee for service?
Well, Melissa is leading an effort to get everybody in managed care.
I know, but we're not there,
We're not
according
there.
to your charts.
85%. When I first got here in 2011,
Where we at?
the sort of the line of demarcation between who was in MCO versus who was in fee for service was typically a long-term care plus people who were identified as having some SSI serious. That population tends to be much sicker. Over time, Melissa's made the argument that we need to put more people in managed care.
You are really
No,
throwing people under the bus today.
I agree with the position.
Okay,
And, but it's a difficult thing to do. So she has been working on it for a couple of years, and we are moving more people who would normally be in fee for service into managed care. The goal is when this is all said and done, to essentially have everybody in managed care except folks who are in long-term care, long-term institutional care, or some of the waiver programs. Everybody else we would like to see in managed care. Is that right?
And simply put, it's based on your eligibility. So whatever the eligibility category you come into the Medicaid program with right now in DC determines whether you're going to be in managed care or in fee for service. And so right now, after 2020, we moved more adults into managed care. There's the SSI adults that the director was just speaking of. And so in the fee for service population, it's individuals in our waiver programs. So the elderly, persons with physical disabilities, with developmental disabilities, and some foster children as well. But it's your eligibility category that determines your pathway managed care fee for service right now.
Well, what eligibility category does the persons who are in ICFs fall?
They come through as a SSI or long-term care, sorry,
Right.
long-term care.
okay. All right. Once that transition takes place, what percentage of people are we talking about? Do you think will still be left on fee for service?
I think probably less than 5%.
Less than 5, okay.
Yeah.
Hold on a second. My bad. Okay. Okay. So one of the questions that has come up as we talk about now moving behavioral health over to the Medicaid MCOs is how the MCOs will interact with prior authorizations. Will people need to go through that whole process again, or will it transfer over?
So when we have the initial carve-in of the benefits, what we've expressed to stakeholders and providers is that we will have a series of what we're calling bridge policies. So for the first 18 months, any prior authorization that was set prior to the carve-in will be honored as we transition into managed care. That's what we do when we have any transition. It's in effect right now for our new contracts. And so we have folks that as of Saturday who are switching different managed care plans, but for the next 90 days, that's our the continuity of care transition period, we honor all those prior authorizations. So we will do that when we carve in the behavioral health services, but like I mentioned, it's a much longer 18-month period as we work through all those things.
Okay. Overall, MCOs have a per member spending that is approximately a third of fee for service. We talked, I guess, a little bit about this in terms of it's a different patient mix that's in the fee for service than otherwise. But are there any other things that are accounting for MCOs? In some ways, it seems like operating a bit more efficiently in terms of their patient mix.
I don't think it's because the MCOs operate efficiently, because they don't provide the care. The providers deliver the care. MCOs just build a provider network, and now we require all of them to have the same provider. So any cost differences that were largely a function of in the past, one MCO having all hospitals and other MCOs having hospitals except MedStar and GW, which tend to be a little bit more expensive. Those differences are washed away with universal contracting. Now, there's still some differences because the strength of, some CEOs may negotiate maybe more successful, even within a rate range of negotiating a higher rate than others. But the issue of efficiency, the MCOs have very little control over that because their job is to build a provider network that provides beneficiaries access to the same care regardless of which plan they're in, and then make sure that those persons have knowledge of who those providers are and have access, unfettered access to those providers.
Okay. I'm in my last little bit here. One follow-up I have, so from the performance oversight hearing, you all stated that the agency was open to restarting the maternal health task force because people liked it and they like you guys.
I didn't say that. Listen, you said that. Yeah.
Along with managed care, it's all me.
Yeah.
There's a problem. just-
What is the timeline for restarting, and do you have sufficient agency funds to convene?
Yes, what we've talked about internally since Oversight is to try to reconvene the maternal health advisory group in June. I think it's what we've talked about. That way, and we're still formulating what we're trying to figure out is how we can dovetail the perinatal mental health task force work along with maternal health advisory. We'd like to bring the maternal health advisory together probably June-ish. Probably first thing, talk about renewals. 'Cause one of the things we want to make sure is that pregnant women don't lose coverage if they should still be eligible.
Yeah.
And how we can utilize their networks and everything. And then start to bring in that perinatal mental health task force discussion and recommendations. And then at the end of the perinatal mental health task force, at the end of the calendar or fiscal year, to see how they potentially merge and move together. So
Yeah.
we're aiming for summer is the short answer.
I was reading through the DC Health most recent perinatal and infant mortality review report that they just released. And one of the things that still stuck out to me was the number of Black and Latino women who still were not seeking prenatal care until their second and third trimester, or not at all.
Right.
And I'm, to a certain extent, when we're talking about like the number of people that we have in this, we're talking about many of those being MCOs. How are we holding their feet to the fire on some of this? And frankly, I know there is only but so much they can do, right? They can't require someone to go to the doctor or have all those things. And I recognize that we are nationwide. We're in a weird period of time, right? I think in Texas, you can't get a doctor's appointment in your first trimester anymore because of all the shenanigans that are going on down there around reproductive health. But I think this is critical for us. And for the MCO, we're paying y'all a lot of money. So what are the accountability triggers that we have here on some of these, whether it be maternal health, diabetes care? Are you going to your appointments? Are you keeping up with your appointments? Are you, all those things? What are some other comorbidities that we have? Very high. Hypertension is another one in terms of really big. So what's our levers here that we have with the MCOs on this?
Well, we have a system of performance metrics that we employ. Now, that does not capture the issue of delayed care for maternal health. It's sort of more broadly focused on whether or not you're keeping people out of the hospital based on identifying their illnesses before they become chronic and require hospital care. It's based on whether or not you are keeping people from coming back to the hospital after they are released within 30 days. You don't want them to come back. And it's also based on whether or not you're keeping people who have low acuity problems out of the emergency room. We can certainly, and I think it's probably a good idea now that you mentioned it. I think one of the things that we do need to consider is adding something on maternal health as a performance metric. Once we do that, this is what the way it works is we withhold a portion of their payment. And we say, look, you get all of it back if you hit all the targets. And I think we have reached a point. We also, because we give them about, I think, $25 per member per month to provide care coordination. And they make efforts to notify beneficiaries based on a read of their electronic health records. They know if they have diabetes, they know if they're pregnant. And then from that, they can have, they can make efforts to communicate with them to direct them to appropriate care.
Right.
We can add maternal health to our performance metrics. I think that's an excellent idea.
I think that has to happen.
Yeah.
And in sort of you talking about what we include right now in terms of performance metrics. Okay. if you haven't gone for any of your prenatal appointments, your pregnancy, your delivery is, it might cost us more money on
Oh,
the back end,
absolutely.
right? In terms of whether it be complications, preeclampsia, all of the various issues. And so I think for this, we have to think differently. Especially if I'm paying you for care coordination and you can't call somebody to say, hey, I saw, why don't we get you connected and get these appointments? Oh, hey, we have transportation services available. Oh, hey, we are reimbursed now for midwives. Oh, hey, you could get a doula. Like we are paying for these things. And I feel like if the MCOs are getting a larger chunk of this money for the coordination piece, because frankly, I have some other, community-based organizations who are saying, pay us and we'll do it better than the MCOs are doing it.
Yeah, what the challenge there is, we've tried to engage a lot of the community providers. They want us to, I had discussions with some of the FQHCs and they were asking for a per member per month rate that was almost more than we pay the health plan. And I asked them, is this going to be full risk? They said, oh no, we can't do full risk. That's a problem.
Right, but are their outcomes better?
I don't know. They said they can't take on full risk. Full risk means we give you a certain amount per member per month. You are responsible for that person's health care, their cost completed. You can't come back to us and say, you gave me, $50 million for their care, but at the end of the year, it cost me $75 million. You owe me $25 million. No, that's not the way it works. And that's what the health plans face. Now we have modified, because they were taking a beating, we have modified and we adjusted the model where we now share risk. Above a certain amount, the district will pay a portion of the cost. They start making a ton of money because they've not invested as much in medical, the patient's medical expenses. They have to give some of that money back to the district. We can think about that with community providers, but they have to be willing to take on some risk. Other than that, we're just taking money from the health plans who are assuming full risk.
Yeah.
And giving it to.
I'm not saying that it's the way to go, but I would say that if the whole crux of an MCO and why we're moving people is for the care coordination piece, plus the full risk, we'll put that on the side, but like the care coordination piece, like I'm just trying to determine how we evaluate whether or not they're actually leaning into that work.
Right.
As it pertains to patient care and delivery. So you said you would be open to adding this as a performance quality metric.
Absolutely.
Is that done on a fiscal year basis?
We can move pretty quickly on that. Lisa Truitt is not here, but we would talk to our actuary. We would inform the plans. We'd have to do a contract modification. I believe, unless the contract language that's broadly talks about performance metrics is sufficient. If that is sufficient, then we can adjust, we can withhold payment based on, some system of performance, and we don't have to specify what the particular metrics are, then we could move very quickly. If we have to do a contract modification, it'll add a little time to it, but not much. So we will, we'll start having those conversations with Lisa Truitt, who runs healthcare delivery. We can start having those conversations with her tomorrow, bring in the actuary, and then notify the health plan that we're going to do this.
And we do have core measures already that the plans do report specific to maternal health. So we're not starting from ground zero on this one.
Yeah.
And I think the piece that you're speaking to is really adding that, the incentive or the, to make sure that we see what happens.
Yeah. I mean, even when I went on a tour to Howard, they were saying, oh yeah, most of the people that we see come deliver at Howard now, that when they come in labor is the first time we have seen them.
And then we often don't see the postpartum visit, which is why
Exactly.
we built it into the doula rate on that one, just as another window of trying to make sure we see those moms again for so many reasons, but yes.
Yep. Okay. Councilmember Pindo couldn't join us, but she asked me to ask some questions. So these are questions from her. She said certain violence interruption activities undertaken by the executive agencies may be eligible for federal Medicaid reimbursement.
Yeah.
Oh, hold on. Would covering these services require a state plan amendment or waiver, or has healthcare finance explored either of these to facilitate using funds for violence prevention?
Melissa's done some work on that.
Sure. So we're in discussions with Linda Harley Harper and her team about what services that are currently funded fully locally and make the Medicaid reimbursable. There's a number of them. There's a couple states before us who have already received approval for this. And the one thing I can't remember, is it SPA or waiver? And when it's what we can do under state plan amendment, but it's something we're actively looking at right now.
Okay. Her second question was Deputy Mayor Turnage. Under your DMHHS hat, have you coordinated the Deputy Mayor for Public Safety and Justice, the Office of Neighborhood Safety and Engagement, the Office of the Attorney General, the Office of Victim Services and Grants, and or other agencies to identify, I think you answered this, Melissa, but I'm just reading it, to identify violence interruption programs and services eligible for Medicaid reimbursement. I think you said you were talking on it. Okay, I think you answered her last question too. Hold, please. Okay. Ashley, do you see any members? Great. Well, those are all the questions that I had. We have some follow-ups, so I just want to say those on the record, and then I have some stuff that I have to say to sort of wrap this hearing up. I will say on separate and apart, Deputy Mayor Turnage, Melissa, thank you so much for your engagement with our team on the IVF bill. Which I have to say, like, was I had to go through a mourning period on that. And so much so that, I mean, I have a congresswoman, but I wrote another congresswoman and I said, I need you to change. I need you to propose that CMS change it in terms of essential benefits, because I think it's just a lot of the tiered systems that we have in our healthcare system, we can only do so much on the local level, but the feds have got to step up in terms of their level of coverage to make sure that just because you have Medicaid doesn't mean that you can't have the full suite of access of services. Okay, so for the follow-ups I have over here, IT funding specifics for funds from the federal government, a detailed spend plan for IT, other service charges, acquisitions and maintenance, the number of people processed in DCAS. Oh, you have the number? Okay. How we got to the 24.4 million behavioral health rate increase, we'll follow up with Dr. Bazaran on some of this tomorrow, but it seems like I said, the math is not mathing for us. And so we just want to get some clarity there. We'll follow up in the summer on the Liberty Health wait times. Hopefully we can get down to the 2 days. The fee schedule for proposed behavioral health rates, pulling out those that are a part of the rate study. So what we'd like to see is the FY23 rates, as well as what you're proposing for the FY24 rates. And then the committee staff will follow up with a couple other data related questions. We get a data dump. We also have budget books. Sometimes they don't match. So we need you guys to help us reconcile the two. So we'll be in touch with all the varying AFOs and financial folks. This gets to the fun part of the budget. Okay. In closing, Deputy Mayor Turnage, thank you so much for your testimony and for making your staff available to answer questions from the committee. This concludes the hearing today. If anyone would like to submit testimony, the public record for the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance will remain open until 5 p.m. on Wednesday, April 19th. You may email your statements to astrange@dccouncil.gov or leave a voicemail at 202-430-6046. If you choose that option, please speak slowly and spell your first and last name for the record. Our next budget oversight hearing for the Committee on Health will be the government witnesses for the Department of Behavioral Health tomorrow beginning at noon. The time is now 4:46 p.m. and this hearing is adjourned. Thank you.